Yes, ma'am. So we will start in time, sir.
Absolutely.
Yeah. Next 5 minutes, Aishwarya.
Sure, sir.
Can we start?
Yeah, please do.
Yeah, please.
All right.
Okay.
So, good morning, ladies and gentlemen. Very warm welcome to all of you. And I welcome you to the first edition of the World Healthcare Conference. I'm Aishwarya with you. And I welcome all the dignitaries who have joined us. A special warm welcome to Mrs. Preeti Sudan, WHO member. I also welcome all the experts in the field, healthcare field, who have joined us. Warm welcome to Professor Randeep Guleria, Director, All India Institute of Medical Sciences. I also extend my greetings to all the participants and also the organizers, of course, welcoming Dr. Anil Garg, President, World Health Conference, and a very warm welcome to Razdan sir as well. So, ladies and gentlemen, the conference is being held virtually as we are in the middle of a pandemic. And even as we speak, more than 184,000 cases were reported in India in the last 24 hours. And not just India, several countries around the world are witnessing a recent surge in coronavirus cases. And the COVID-19 pandemic has brought to light the importance of healthcare in the country and around the world. It is indeed time to reflect upon the present situation, but also plan for the future. And that brings into focus this particular conference. And the theme of this conference is Medical Healthcare Transformation, New Normal to Next Normal. As we know that the year 2020 was a watershed moment for healthcare in India as well as around the world. And that highlights the importance of this conference and many more conferences that are going to be held, not just in India, but across the world. I invite Dr. Anil Garg, President, World Healthcare Conference, to start the conference with a welcome address. Dr. Garg, please.
Thank you, Aishwarya. Dr. Anil Razdan, former Secretary, Power, Government of India, and Chairman, Energy and Environment Foundation. Mrs. Preeti Sudan, former Secretary, Ministry of Health and Family Welfare, and member of WHO Independent Panel on Pandemic Preparedness and Response. Dr. Randeep Guleria is a busiest person in pandemic time, Director, AIMS, New Delhi. Distinguished delegates, dignitaries, leaders in healthcare industry, distinguished speakers, award winners, and participant exhibitors. Let me welcome you in this unprecedented COVID times to join this World Healthcare Conference virtually. Support of Niti Aayog, Ministry of Health and Family Welfare, Government of India, and our association partner, Association of Indian Medical Device Industry and Association of Healthcare Providers India. Dr. Gyani is here, is most welcome. Healthcare is transforming at a very accelerating rate. Pandemic COVID catalyzed this process of transformation. Healthcare providers will need to innovate and adopt these technological challenges rapidly. Leveraging the power of artificial intelligence, deep learning, neural networks, namely artificial neural networks, ANN, convolutional neural networks, CNN, big data, Internet of Things, blockchain, 3D printing, 5G robotic surgery, and nanotechnology are few of the new technologies for which global healthcare organizations of all sizes, types, and specialties are becoming increasingly interested. As how these modern state-of-art technologies can support better patient care while reducing the cost of reducing cost and improving efficiency. Keeping patient first approach in view, the theme of this conference is focus on the accelerate healthcare innovation with greater emphasis on content, connectivity, cutting-edge technologies to improve healthcare safety, quality, effectiveness through collaboration, innovation, and shared knowledge exchange. That's why this conference. I will just say that, dear participants, during this 2 days of World Healthcare Conference, you will gain insight into the strategies used by world healthcare leaders, health experts, innovators, influencers, pharma companies, device manufacturers to reduce cost while ensuring quality healthcare, improve efficiency, and patient-first approach. This means that patient can get back home quickly, safely, happily, and in good health from the hospitals, and also to create new growth opportunities in healthcare sector. Let me once again welcome international and national distinguished speakers, participants, delegate, exhibitor, awardees for this annual international conference and expo focus on modern healthcare on fixed date every year. This is an annual conference, fixed date 15 to 16 every year. Thank you very much. Thank you and welcome.
Thank you so much, Dr. Garg, for the welcome address. And now I welcome Mr. Anil Razdan, Chairman, the Energy and Environment Foundation, and former Secretary Power, Government of India, for the theme address. Mr. Razdan, please.
Thank you very much. Very good morning to all distinguished participants, and particularly Ms. Preeti Soodhan, former Health Secretary, Government of India, now a member of the WHO Independent Panel for Pandemic Preparedness and Response. And of course, Professor Dr. Randeep Guleria, a most eminent medical professional in India and heading the Premier Institute of the Government of India, AIIMS, as well as award winners to this event. We are all meeting in the shadow of an unprecedented, I would say, not only a crisis, but a calamity in our lifetimes. Particularly, I think this generation has never seen a global pandemic of this dimension. And I would say maybe in the last 100 years also, this could be perhaps one of the biggest health crises to have hit the world. Now, this has, of course, been facilitated by the free access and communication and virus. I'm not a medical man. Virus is something that needs not only treatment, but also a response from the citizens. Because I can only think of a panel of HIV/AIDS. There is a treatment for it, but there's also a need for basic precaution. And that is where I think the link between the citizen and the medical professional is extremely important. Both have their responsibilities and also their obligations, as well as help from each other. Well, this global pandemic, I think, is both a financial destroyer for economies. It has shaken the oil world. For the first time last year, oil, which is supposed to be a global king trade commodity, fell into negative. So even the titans can fall to this inner side effect. But this, I think, pandemic has also brought the world together for a collective review and action as never before. And I think that has saved this generation from a much greater scourge. There has been a very quick response by medical researchers, and they have produced the shots that we are getting across the world from different companies, though there is a debate whether there is a vaccine or when will an actual vaccine come. The health infrastructure, I think, particularly in the developing countries, has been inadequate quantitatively. And developing countries were battling to fight that, leave aside the qualitative aspects. But nevertheless, this crisis has shown that from the most rudimentary health worker to the senior most, they have stood together, they have fought this pandemic to the best of their ability. Otherwise, the damage could have been much more. Well, health is a sector which is not seen as much investment as it ought to have seen. And I was reviewing some of the old 5-year plans to find that really health did not get the kind of priority that it ought to have got. And we were mostly battling with a dispersed kind of healthcare. Now, health is wealth. Everybody knows you fall ill, wealth is of no use to you, and also your earning capacity gets affected. And I think this affects the lower economic strata more than anybody else. We've seen the massive exodus of workers across the country last year, and we only hope that we can halt it, because distant learning can be done for the educated, for the highly intellectualized activities, but not for physical activity. And physical presence is necessary. But the flip side of it, that when we say health is wealth, unfortunately, over the past few decades, leaving aside the public health institutions owned by government, health has also been used to generate a lot of wealth well beyond its equitable limits. Now, that is something I think which future governance will probably have to control, because the business of health generates wealth. It is well known. Future research in health also requires wealth and huge investment. So the relationship between health and wealth is more than symbiotic. It is also financial. Now, sometimes the question is raised, what is COVID? Is it only a medical problem? Or is it also a social and health education issue? In my view, COVID has shown that this kind of a communicable disease is also a social health education issue. When we were imposing the lockdowns, my doubt of the matter was that we're treating it as a law and order issue. It is a very fundamental education issue, which of course, because it took us by surprise, we didn't have time to prepare. But ultimately, I think it is a social health and education issue, where the basic norms which are to be observed outside medication are probably more important than treatment itself. And that is where a very close coordination between the education department and the health departments and various governments is, I think, the need of the hour. There's also, I think, I worked in the nuclear sector, so my mind works in that direction also. There is need for global laws on biological research to check any calculated or negligent proliferation like nuclear safety and proliferation. I would not like to elaborate more on the subject, but I'm sure that the intellectuals and the medical participants in the panel today are aware of what I'm talking. What is the future? I would say distance diagnosis, the future. Just as we are conferring today through this medium, we need healthcare through that kind of a medium. But that, of course, is something which is, it stops at a level. Beyond that, you have to seek medical attention in a medical facility. Hopefully, that state should not arise for most of us if the precautions and social health education is taking its due place, which it has not over the years. We need to increase our spending, not only global, but national and local on health issues. Health in India used to be a subject which was really starting at the municipal level when I was growing up as a young boy in the city of Delhi. But today, everybody thinks it goes up to the state government or to the national government. I think it's something which begins at home, extends to the neighborhood, and then moves to the city and on to the state and thereon. And I think that is something that we have to be conscious of. The government of India, and I think the state governments, have done a phenomenal job in battling the crisis. Frontline healthcare workers, Medicare professionals have done yeoman service. And I think their debt can never be returned by the citizens. The citizens can never thank them enough. The vaccination task is a massive national task, which has been taken upon with a big smile and a lot of courtesy in India, I can tell you that. The other point that I would like to just speak on briefly is what is the next normal as a theme of the conference. I would think it's home medical care. The citizen has to be his own medical attendant. There have to be a proliferation of neighborhood clinics. We had some decades back talked of barefoot doctors in China and some other countries. I think we will need a lot of telemedicine to be growing in the future. There has to be, I think, compulsory health insurance in times to come for the entire workforce. Disease alert detectors, much as you have in the face of terrorism and other things, you have other kind of alerts. I think there have to be disease alert detectors so that infected populations do not mingle with the uninfected ones. Telemedicine and Medicare will be on the increase. And we'll have to see how best we can do it in a professional way. Now, revolutionary citizen-friendly medical diagnostics, I think, much like the Alexa in our homes, may be coming sooner than expected. Like this conference on healthcare I think treatment will also become virtual. Thank you very much. And I must thank all the busy participants for having joined us on this very important event. Thank you very much and welcome to the event. Thank you.
Thank you so much, Mr. Razdan, for that very informative speech. And indeed, 1 year ago, India lived through a lockdown trailer by observing a day-long Janta curfew. And for the first 75 districts of the country, it is also the first anniversary of that lockdown. And the rest of the country was shuttered from 25th of March. So we have seen how these 12 months have actually changed our lives. And of course, the COVID-19 pandemic has also given us a lot of lessons. And the one person who has been in the middle of the because she is former Secretary of Ministry of Health and Family Welfare, Government of India. She is also the member of the WHO, the Independent Panel for Pandemic Preparedness and Response. So I would welcome Mrs. Preeti Sudan and invite her for this special keynote address and give us some insights into not only the pandemic, the COVID-19 pandemic, but also the theme of the conference as well. Mrs. Preeti Sudan, please.
So thank you, dear organizers, my senior colleague Anil Razdan sir, Dr. Anil Garg, and Dr. Guleria, with a huge salute for all the hard work that he has been doing over more than a year, and all the distinguished panelists who are here, the participants. Thank you for inviting me. Well, yes, it's true. We started our battle against COVID on 8th January 2020, and now we are more than a year and a half into it. It's been a journey of learning, of disappointments, of triumphs, and today we are in the middle of a second wave. Though our per million cases at about 10,000 are still low, our fatality rate is again low as compared to even developed countries. It's at 1.23%. And we yesterday did 26 lakh tests. Let me tell you that we had just one lab, and today we have more than 3,000. So we have ramped up our facilities. We've already vaccinated 11 crore people, which is not a small feat. But the downside is that we have added nearly 1 lakh cases yesterday itself, though 93,000 people have recovered. So COVID is raging, and I think everybody is trying to do their best. But one lesson that comes out of all this, and which is also the theme of today's conference, that how healthcare is transforming, has transformed, and must transform. First and foremost, we must recognize that health is a global good. We no longer can think that it's an individual, government, municipal responsibility, as very rightly put by Dr. Anil Razdan sir. It is a global good, which means you need huge investments, you need multi-sectoral action, you need technology, you need individual responsibility and collective responsibility, you need ethical treatment, and you need wellness in healthcare. So my emphasis is that promotive and preventive healthcare is what we should be now looking at also. So just I'll take you through this little journey as I have been witness to the transformation of healthcare in the last few years. I was fortunate to be health secretary for nearly 3 years. You see, it was in 2017 that National Health Policy was revised, and we thought about a comprehensive healthcare. I would like to say that around the world also, I think except for Thailand to some extent, nobody talks about preventive, promotive healthcare. It's only curative services. how to improve our hospital care, how to improve, disease control. We are not talking, nobody's talking about wellness, but this national health policy did talk about wellness, and did pick up on what was called Bhure Committee report in 1943. So I think this vision was very well articulated, and also 2018 itself, this sometimes what happens that policies don't get translated into programmatic interventions. But in 2018 itself, Ayushman Bharat was announced, a short step towards comprehensive universal healthcare. You see, it had two pillars: the health and wellness centers, which promote preventive and promotive healthcare. What was happening there? You see, we used to, as Anil Razdan sir also said, that municipalities, our neighborhoods, they used to actually take care of the primary healthcare of the population, and all our services were actually maternal and child centric. But now, with these health and wellness centers, some 12 packages have been added, which includes NCD, preventive screening, and you see the non-communicable diseases. As you know, the burden is rising with our sedentary lifestyles, with the food we eat, and the way we sort of now live. So diabetes, hypertension, the cancers, that screening is done in these health and wellness centers. Today we have 70,000 already, and we are aiming at 150,000 odd. And then, of course, the second pillar was the Pradhan Mantri Jan Arogya Yojana, where you see the most needy 40% are covered with insurance, with trust, that government pays their money for hospitalizations for critical and catastrophic episodes. Now, the important thing I would like to say is that this PMJ is also a reflection of how government and private sector can work together. So there is private hospitals are empaneled, and they also treat people ethically at reasonable prices. So I think that's a first step towards transformative healthcare model in India. And that's what I would like to also stress here, what Dr. Anil Razdan said, that, the neighborhood clinics are very important. Yes, they are to-go places. The health and wellness centers are to-go places. And I'd like to inform this August gathering, maybe you know already, that, in the midst of COVID, one very important silent transformation has taken place. Under the Prime Minister's Atmanirbhar program for MSMEs, the small medium enterprises, for the first time, small clinics, family clinics have been included. So now they are eligible for, incentives, for subsidized capital through banks. So that's a big step forward, and I think that will play out in years to come. Next is that, we have always been addressing healthcare disease-wise. So we had vertical programs for TB, for malaria, for handling vector-borne diseases. Of course, immunization and all was part of RCH services. And new initiatives have also been added, like quality, care delivery rooms under Lakshay, then Prime Minister's ANC program, where the private doctors give their time on voluntary basis. And then the tobacco control that we've been doing, 85% warning on cigarette packs, and more recently, the banning on e-cigarettes. So all these initiatives have been going on, but the important thing is that these verticals are now getting integrated horizontally. And that's through the Ayushman Bharat scheme that I'm talking about. Next, I'd like to also draw your attention that addressing social determinants of health are very important. Sanitation, toilets with running water, clean drinking water, nutrition, ensuring access without bias to gender, caste, class, information asymmetry. These are determinants that need to be addressed and are getting addressed. If you see this year's budget, then we've been talking about 137% increase in healthcare budget. And it's very pertinent that government has looked at sanitation and drinking water as a health component. So that's the way to go, and that's the transformation that is also required. I have already spoken about need for multi-sectoral synergy, and Anil Rajdan sir also mentioned it. So some of the examples have been, where actually Beti Bachao Beti Padhao scheme, which I had the fortune to also get associated with, deals with not only, I would say, the gender discrimination or female foeticide, but also with empowerment of women, and education of the girl child. So the various ministries like HRD, WCT, health work together. Similarly for Swachh Bharat, similarly for drinking water. So I think all this convergence that is taking place at the government level needs to take place also at the Gram Panchayat level, in our homes, in our minds, because I feel that wellness is really, really a mindset. Then, of course, we can talk about this all, but how do we do it? So there have been reforms in medical education. There have been large-scale additions, as you already know, in medical seats, both PG seats and also MBBS seats. 30,000 additional seats in the last 5 years. 73% increase in DNB. Additional PG seats to about 18,000, and new competency-based curriculum introduced after 21 years in MBBS pan-India, a district residency scheme for 3 months for PG students so that they know what it is to work in villages. And most important, of course, the National Medical Commission now has replaced MCI with outcome-based education. Not just how many rooms you have, how many labs you have, but what are the outcomes. Along with this, I'd also like to say that very recently, this Allied Health Professionals Act has come into being, the National Commission for Allied Health Professionals. Mr. Rajdan said that, we need to be our own doctors, we need to be our own therapists, and I sort of agree with him. And also we need trained people who can actually sort of assist both doctors and the patients. So therapists, mental health is a huge issue now, especially we are all in lockdown, and we are not mingling as much. And there are new forms of communication like this digital platform. So mental health professionals, then geriatric care professionals, then palliative care. So these are all the this huge team of health professionals, which I have called as wellness workforce, will also now get transformed through this act, which has come into being in this parliament session. It has now become an act and a law. So this will also transform healthcare in India. So I would like to conclude that we do have a legal framework in place. We are emphasizing on preventive and promotive healthcare. Digital health is very important in COVID. Let me share with you that there is this eSanjeevani software that we had. We were actually doing peer learning through medical colleges through this software, but it was quickly transformed into a telemedicine network, and more than 50 lakh sessions have been held. Dr. Guleria is here. He may like to tell you how they have done a telemedicine in AIMS, how he has coordinated with all AIMS. So therefore, you see, digital health initiatives are very important. We are now insisting upon it also in our WHO panel, because even globally, the norm setting, the privacy issues, the ethical issues of digital health need to be sorted out, and the privacy law needs to come in. So all these issues are being addressed, and this is again a transformative period for all of us. I think we will. The whole world is changing, and my generation has seen black and white TVs, and today we are seeing and operating on a digital platform. I mean, how much we have seen. And I'm sure the future generation will also not be a world that we know. It will be a very, very different world. And I also want to add that one of my dreams has been, and I'm sure it'll also be actualized, is that we must have health in all policies. That means whatever government does at whatever level, central level, state level, municipal level, panchayat level, a mindful scrutiny of all proposals keeping health impact in view is very, very important, because as we have seen, health impacts each and every aspect of our life, whether it is social, whether it's economic, whether it's mental, whether it's psychological, and of course, lives and livelihoods also has to go on together. So we are really at a very transformative stage as far as healthcare is concerned, and I'm sure that together India will move forward to show the world a new way. Thank you.
Thank you so much, Dr. Sudhan, for throwing light on on several topics, subtopics under this topic. And as indeed pointed out very well by her, this is a transformative period for all of us across the world, and very well said that India will show the path, hopefully show the path to the world as well. I now invite Professor Randeep Guleria to shed more light on this topic, because he's been in the middle of everything. He's talked about the enforcement of COVID appropriate behavior, and he has been saying that how the progress made by India in the last year should not go in waste. I'd invite Professor Randeep Guleria, Director, All India Institute of Medical Sciences, is also the member of the National Task Force for COVID-19 Management, for the industry keynote address. Dr. Guleria, please.
Thank you very much. Good morning. Mr. Anil Razdan, Chairman, the Energy and Environment Foundation and former Secretary, Power, Government of India. Ms. Preeti Sudhan, former Secretary of Ministry of Health and Family Welfare, Government of India, now with the WHO. Dr. Anil Garg, President, World Healthcare Conference, dignitaries, other dignitaries who are part of this conference, delegates, ladies and gentlemen. First of all, really, let me start by congratulating the organizers for holding this World Healthcare Conference on a virtual platform. Post-COVID or during COVID, health has actually become a very important issue and has really taken the center stage. These are challenging times for us, not only for India, but for the globe, because never before have we seen a pandemic of this nature. And this has really put a huge sort of challenge in the healthcare industry. And I think this is the time when the global community has really come together, and we've realized that we have to innovate. And that is something that has been part of what has happened in India and globally. I remember 1 year ago when we started working on and the pandemic was just starting, there was this huge issue in our hospital itself and in the country. Every day I used to have a meeting with our group, and we used to wonder what we should do. There was the issue of shortage of PPEs, shortage of N95 masks, shortage of ventilators, oxygen beds. And we started working very aggressively on seeing how we could really overcome this shortage. And I think this is where a lot of innovations happened. People moved out of their silos, started talking to each other, whether it was industry, whether it was the engineering section, or whether it was people in the healthcare sector. This led to a lot of garment industry coming in to make PPEs. A lot of N95 masks were made in our countries. Companies which are actually involved in making cars got involved in making ventilators. And in a short span of time, we were actually in a position where we could export PPEs, had enough N95 masks, and there were indigenous ventilators which were all made. Also, we started looking at our testing. We were having very few labs which were able to do testing for COVID-19. We started a huge program where we started talking to industry, getting the viral transport media, the nasal swabs, the kits for RT-PCR being made in our own country, which brought the cost also down, and there was no shortage as far as the kits were concerned. At the same time, there was need to have more and more labs. So a group was formed which started mentoring various institutes across the country, and they started mentoring all the colleges and all the other departments which could do RT-PCR testing. And from just a handful of labs, now we have more than 2,200 labs which can do testing for COVID-19. And we keep on looking at how can we further expand? Can we look at veterinary labs? They also do RT-PCR for animal pathogens. So a lot of them have got involved in doing RT-PCR testing for COVID-19, getting attached to a medical institute. So there is a supervision from the medical institute, but their lab gets used for doing testing, and that allows us to do more and more testing as far as RT-PCR testing is concerned. We converted our CB-NAT, which is used for diagnosing tuberculosis, into a cartridge-based testing kit for diagnosing COVID-19. So I think this pandemic really taught us how to innovate and how to really start breaking various silos that we had in interacting with each other, so as to really take up the challenge which COVID-19 threw to the medical community. But it's still not over. We are actually facing a huge crisis now because of the fact that the cases have continued to surge. We have crossed 2 lakh cases per day, and that is also leading to increasing mortality. And I think therefore there is a need for us to see what are the way forward. As was mentioned, we realized that there is a huge strength in e-learning and the technology that uses the network and which can use the internet is very powerful and has not been used that much in the past as far as the health sector is concerned. Teleconsultation became legalized because of COVID-19, and now across the country you can have teleconsultation, and you can patients who were not being able to come to the hospital because of fear of COVID could take the consultation from the doctor through teleconsultation. And this was very helpful for non-COVID care, especially for non-communicable diseases, patients with diabetes, hypertension, or with chronic respiratory diseases who just needed to adjust their medication, were able to do so without having to come to the hospital and having the fear of getting COVID-19. We also realized that we needed to have a standard protocol, and we started at the All India Institute of Medical Sciences what we call the eICU care for COVID-19. Every Tuesday and Friday, we interact with hospitals across the country to look at treatment strategies, because this was a new virus and people did not know how to really go along treating this pandemic. Should they give steroids? What is the role of remdesivir? What is the role of other drugs like hydroxychloroquine? And over the last 1 year, I have probably talked to more than 500 hospitals which are managing COVID-19 and discussed with them management strategies and seen how varied the strategy is and how there is a need for us to really talk to each other so that we have a uniform and a better strategy so that we can save lives. So that is something that was also a part of learning. We started what we call the Centers of Excellence in all states with the support from the Ministry of Health and Family Welfare, where also training was done on various issues on management. And I think all of this is something which we need to take forward as we go to the new normal or to the next normal post COVID-19, whenever that era comes. So this is also part of the learning. We also started having what we called our national grand rounds, where we discuss cases and again have a lot of interaction through the social media as far as the management is concerned. But what has been the learning in all of this? I think the first thing is that there has to be more and more investment as far as the health sector is concerned. Even if you look at the data from before COVID, India was ranked 176 out of 191 countries when it came to government expenditure on health. So we have to really increase the expenditure. And I was part of the high-level group of health committee, which was formed by the 15th Finance Commission of India to really see how health could be improved. And we had given a report to the Finance Commission, which was incorporated in the report which they presented to the Parliament, which was tabled in the Parliament. And there, a few things that we had really highlighted was that the time has come that the right to health becomes a fundamental right for every citizen. And this should be part of our 75th Independence Day pledge, that we must say that every citizen has a right to health. And that is something which is fundamental. And that's because, as we realized in the COVID-19 pandemic, that if you don't have a healthy nation, it percolates down, it sends ripples to every sector, whether it's industry, whether it's education, all of them get affected. And therefore, health is multi-sectorial, both in terms of the care that is needed, but also in the term of the effect that it has. And therefore, we have to really start investing more and more in health. The second important thing is that it's something where technological interventions has lagged behind. A lot of care can be provided to patients by looking at technology. Telehealth is something that we have to really understand is there, and we have to grasp it and be able to see how best we can use it. All of us carry or have devices on our wrist which can tell us everything from our ECG to our heart rate to our saturation. But we could use that to a larger extent in providing care to patients in rural India. We could use that by using a neural network platform to be able to predict a heart attack rather than having a heart attack happening, by just looking at its alteration that happens in a person's basic parameters. In a patient with chronic respiratory disease, we could predict that his saturation is falling, and therefore he needs to really go into to a hospital before he really becomes critical. And also develop a strategy that the nearest hospital could be alerted so that he is there to receive him whenever he has a problem. So technology is already there. It has to knit it together, and it has to become part of the health sector. And when we talk of technology, it has to be patient-centric. We have to really look at how do we reach out to these patients rather than giving a technology which is so high-end that they are not able to use it. So it has to be something that is looking at the feasibility as far as our patients are concerned. And that's why whenever we talk of technology or of the changes that are happening in medicine, we must have the patient at the center of it all to see that is he or she comfortable with this, and is it equitable to all sectors of society, irrespective of caste, creed, and socioeconomic status. So I think that is what we need to do. We also need to really look at research and development. India needs to invest more for R&D. What we've seen is we are very good as far as manufacturing products is concerned, but research and development in the health sector, in new products, in new molecules is something where we haven't really invested that much in. And this was something which we saw is possible because of the vaccination. India used to manufacture vaccination, but it did not have a strong platform for doing research in vaccine development. That has changed so dramatically in the last 1 year. We have now 7 to 8 vaccines which are being made or researched in our own country, and so many others are being looked at. So this is something that we need to harness. And to harness this, there has to be a sort of a connect between academia and industry. Science and industry need to start talking to each other so that molecules and research which is done in academic institutes, new molecules, new point of care tests, or new vaccines. Currently, a lot is not really looked at as a startup or as an investment by industry so that they can take it forward. This is something which is done so much in US and in Europe. Why can't we have entrepreneurship as far as science and health is concerned and promote our own scientists to really take it up and collaborate with industry to develop new molecules, new vaccines, new point of care. And finally, I think it has a lot to give in terms of the economy. And therefore, we need to really look at it as a sector which is both a service sector, but a sector which also gives so many jobs, so many other opportunities, whether we talk of medical tourism or so many other things. The health sector is very, very important, both as a service sector, but also as a sector for employment, and that needs to be kept in mind. There's also a need to develop a comprehensive health insurance scheme, which really is encompassing for everyone. Currently, we have Ayushman Bharat, but there are a lot of middle class people who are not covered as part of that is concerned, and they get caught in the gaps, and sometimes they have to pay a lot out of their pocket, which causes many of them to go below the poverty line. So we need to make it more comprehensive, more inclusive, even if it means people have to pay a little bit out of their pocket, so that it is covering, I would say, more or less the entire population or majority of the population of the country. And then we have to really look at the concept of One Health. What the pandemic has taught us is that this planet is actually something that has to be looked at both from the point of animal health, plant health, and human health. They cannot be separated out. Most of the outbreaks that we've seen over the last 15 years, whether it be bird flu or avian influenza, whether it be SARS, or whether it be Zika or MERS coronavirus, or any of the other outbreaks, even Ebola for that matter, have actually been viruses which have jumped species and infected humans. So therefore, if we really need to look at how do we handle pandemics in the future or prevent them, we have to look at One Health and health of everyone on this planet, that includes health, plant health, and the environment. So that's something that we really need to keep in mind when we talk of a healthy ecosystem as far as health is concerned. So I'll stop here. This is the thoughts that I had. Thank you very much for inviting me to give my thoughts. Thank you.
Thank you so much, Dr. Guleria, for that speech. And indeed, over the last year, especially healthcare workers have delivered, and they really deserve a standing ovation, whether we talk of the doctors, the nurses, the CEOs, pharmacists, even hospital volunteers, and other people who have played a very important role especially the last 1 year. And amidst all of their hard work, hospital workers have also experienced anxiety, stress, they've experienced loneliness, and also some sort of burnout, because there is immense pressure on them. And not to mention that, of course, they have put their lives on the line each day. So it is the now time for us to announce the EEF Modern Healthcare Global Excellence Awards 2021. And the awardees are requested to give a 1-minute brief acceptance speech after a brief citation. So may I now request Mr. Anil Razdan, former Secretary Power, Government of India, and Chairman of the EEF, to honor the outstanding eminent personalities of the healthcare sector by presenting this prestigious EEF Modern Healthcare Global Excellence Awards 2021. The prestigious Excellence Award is being first conferred to Mrs. Preeti Sudan. She belongs to the civil services in India, and she has been an IAS officer of the 1983 batch from Andhra Pradesh cadre. She retired as Secretary, Ministry of Health and Family Welfare, Government of India on 31st of July 2020, after nearly 3 fruitful and successful years, especially the last 6 months, during which she was at the forefront in tackling the COVID-19 pandemic. She has in the past successfully handled outbreaks of diseases like Nipah and Zika in different parts of the country. And amongst her notable contributions to policy have been initiating and implementing 2 major flagship programs of the country, that is Beti Bachao, Beti Padhao, Ayushman Bharat, which is, of course, the world's largest government-funded universal health coverage scheme, with the twin pillars: cashless free hospitalization for the 500 million needy, and also free preventive and promotive primary healthcare for all through health and wellness centers, legislation on National Medical Commission that will bring in major improvements in medical education, and legislation on ban of e-cigarettes. Ms. Preeti Sudan made significant outstanding contribution towards the healthcare sector. So the EEF Modern Healthcare recognizes her excellent contribution in the healthcare sector and confers her the EEF Modern Healthcare Global Excellence Award 2021. Ms. Preeti Sudan, please.
Thank you very much. Thank you. Thank you so much. Though I am both honored and embarrassed because I feel I just did my duty, and I'm grateful that I got an opportunity to serve my nation, and it could not have been done alone. It was the teamwork and work of many, many people who, my colleagues, our seniors, our doctors, our healthcare professionals, and everybody who made this journey very fruitful, not only in my tenure as health secretary, but also in my entire service of 37 years. Thank you very much.
Congratulations, Preeti.
Thank you, sir. Thank you.
I congratulate you, and also would like to inform the audience that maybe I think a decade later, she succeeded me as a sub-divisional officer in District Ambala. And
yes,
I think that particular subdivision, I also had my block training in a primary health center, and I know the kind of excellent rapport which a health worker can have for development, because it was the first block in the country to have covered 100% family planning during the emergency years. Thank you very much, Preeti, and I think you've done all of us proud and the nation proud. Thank you very much, and congratulations.
Thank you, sir.
Congratulations, ma'am. Very many congratulations. And let me announce the next winner. Of course, it is Professor Dr. Randeep Guleria, Director, All India Institute of Medical Sciences, New Delhi. He is the first DM in pulmonary medicine in the country. Dr. Guleria, recipient of several awards and honors, including the prestigious Padma Shri in 2015, and Dr. R.C. Roy Awards for Eminent Medical Person, Himachal Gaurav Puraskar, Swasth Bharat Samman, and recently Doctor of the Decade Award by the Indian Medical Association, and also the National Excellence Awards. Of course, the list is long. More than 450 publications, 49 chapters, 50 research grants, and more than 300 invited lectures. Dr. Guleria is the personal physician to the Prime Minister of India from 1998 to 2004, and many national and international dignitaries. He is the advisor and consultant to various international and national bodies, including the WHO, Geneva, and the IAEA, Vienna. So Dr. Guleria also made significant outstanding contribution in healthcare sector. The EF Modern Healthcare recognizes his excellent contribution in the healthcare sector and confers him the EEF Modern Healthcare Global Excellence Award 2021. Dr. Randeep Guleria, very many congratulations. Sir?
Thank you very much. And I'm really, I would say, honored and as Madam Preeti Susan said, embarrassed also a little bit to get the award, because all of us have been doing our job. And I would like to dedicate this award to all my COVID warriors who are still fighting the COVID-19 pandemic. This is something that we've been doing, and we all consider it a challenge that we have taken and would continue to do so. Also, as has been said, this is part of my job. I am a doctor, I'm a pulmonologist, so I deal with respiratory problems, and the pandemic is also predominantly a virus which causes respiratory problems. So I've been just doing what I thought I could do in the best way possible. And thank you very much for considering me for this award. I'm really honored, and thank you.
Congratulations, Dr. Guleria. And I think the institution and the country is really honored to have you at the helm of affairs in this pandemic. You've done a great, great job, and we're proud of you as a country. And I think your contribution can never be emphasized appropriately. Congratulations to you and your team. You're only representative of the entire health workforce of the country. Both of you. Thank you very much.
Congratulations, Dr. Guleria, from my side also, and a huge God bless.
Thank you, ma'am. We both worked as a team. Really.
Congratulations, Professor Guleria.
Thank you. Thank you very much.
Thank you so much, and congratulations to Dr. Guleria. And also, I would invite the next awardee, Dr. Girdhar J. Gyani. Dr. Gyani is currently working as Director General, Association of Healthcare Providers, India. He is widely recognized as founder of Healthcare Quality in India. During his tenure as Secretary General, Quality Council of India, Dr. Gyani played a pivotal role in the formulation and operating of National Accreditation Board for Hospitals and Healthcare Providers, that is NABH, for the first time in the country. He functioned as the founder CEO of NABH till he superannuated in July 2012. And during this period, about 200 leading hospitals in the country got accredited and providing boost to the medical tourism. Dr. Gyani is the recipient of numerous awards and recognitions, including 3 Lifetime Achievement Awards by leading organizations. Healthcare Executive magazine gave him the title of Chanakya of Quality. The EF Modern Healthcare recognizes his lifelong outstanding contribution in the healthcare sector and confers him the EF Modern Healthcare Global Lifetime Achievement Excellence Award 2021. Dr. Girdhar Gyani, congratulations.
Thank you very much. Thank you very much. And at the outset, let me thank the President of World Health Conference and Expo, Professor Ajit Garg, and also our senior, bureaucrats, Mr. Ali Razdan, for confirming me on this award. I must tell you that I got associated in the healthcare in 1998 when NABL was in the formative stage, and that came after my training in United Kingdom by Government of India on the healthcare quality. But my actual breakthrough came in 2004 when Mr. Hota, that time Secretary Health, invited me that can we do something, how do we improve the healthcare quality and establish the framework in our country. And that was the challenging task. I feel I was privileged to be in that position, and with the help of, at that time I remember 6 senior doctors who came together and started working on this journey of healthcare quality, which came through NABH. So this is a journey which I am continuing even my superannuation, because the new formed association requested me to take care of the advocacy issues with the government, because having served in government for 25 years. Although at this point of time, sometimes I have to fight with the government. I am not using the word fight, but I do that advocacy. But my main emphasis is now how do we build capacity into the Indian healthcare system. And I am rather privileged that I am being given the award along with the 2 stalwarts of the country today, Madam Preeti and of course, Professor Randeep Guleria. Thank you very much. Thank you very much.
Congratulations, sir. Congratulations. And now let me announce the EF Modern Healthcare Global Women Leadership Award 2021. And it is being given to Ms. Heather Lee Flannery. And she is the founder and chief executive officer of Consensus Health, a spin-off from Consensus AG, effective March 2020. She chairs the IEE SA Open Standards Development Working Group, that is blockchain in the healthcare and life sciences. She's also the co-founder and board chair of blockchain in Healthcare Global. Ms. Flannery has served as industry faculty for the United States Department of Health and Human Services, Office of the National Coordinator for Health IT, and is an active consultant and advisor. Ms. Flannery also founded and led Obesity Prevention Policy and Management, Inc., an innovative provider of disease management, population health, research administration, and information technology, managed services for health systems in the Americas, and an early adopter of blockchain technology. Ms. Flannery has driven business model innovation via technology, early adoption throughout her 25-year career as an entrepreneur, technologist, and strategist. She has consulted in public sector in the context of international development, bringing a global health perspective to her work. Ms. Flannery also demonstrated as an outstanding international leader in blockchain in healthcare. So the EEF Modern Healthcare recognizes her excellent contribution and leadership role in the healthcare sector and confers her the EEF Modern Healthcare Global Women Leadership Award 2021. Congratulations, Ms. Heather Flannery, please. Can we have?
I think she will join in her session, which
All
she
right.
is sharing tomorrow.
Thank you. Congratulations.
All right, very many congratulations. And now let me next announce the EF Modern Healthcare Global Women Leadership Award. And the award is also being conferred to Dr. Liz Palsworski. She is a multi-award winner and globally recognized health advisor and mentor to CEOs, executives, and boards internationally. She sits on 3 international advisory boards, is a lead judge in the annual European Healthcare Design Awards, and is a visiting professor at the Ukrainian Catholic University in Ukraine. Dr. Liz's career as a CEO spans diverse areas of health in the public, private, and not-for-profit sectors and in institutional banking. She demonstrated a leadership role in the healthcare advisory and strategy in government sector and private sector, and also in global knowledge sector. The EF Modern Healthcare recognizes her excellent contribution and leadership role in the healthcare sector and confers her the EEF Modern Healthcare Global Women Leadership Award 2021. Dr. Liz, please.
She might have left and join Mr. Razdan's session next after this.
Yeah, because she had joined us earlier. But anyway, congratulations to all the winners. And now let me invite Dr. Anil Garg, President World Healthcare Conference, for the vote of thanks.
Distinguished dignitaries, award winners, Lifetime Achievement Awards, and Women Leadership Award, Global Excellence Awards, and industry people, participants, and exhibitors. Let me thank once again for your coming and making this conference, which is meaningful. Health transformation is a must. Everybody has realized, and Dr. Guleria has made a very important point that One Health for the planet. This will be the theme of next conference, as it is very well said. Then I have to thank Niti Aayog, Ministry of Health and Family Welfare, Government of India, and our association, or with our partner and associates, Association of Medical Device Industry, Association of Healthcare Providers, and to all the distinguished speakers. Thank you very much.
Thank you so much, Dr. Garg. And with that, we come to the end of the inaugural session. And we'll take a very short networking tea coffee break. And we'll be back at 12 noon. And we'll be starting with the plenary session. And the first session is going to be chaired by Mr. Anil Razdan. And the session will be on accelerating digital transformation in healthcare. That is going to be the topic of the plenary session after the networking break. So I'd like to thank everybody who joined us in this inaugural session. And with that, the conference is open. And we'll take a very short tea break now. We'll all be back at 12 noon. And we'll be starting off with the plenary session. So I'll see you in about 30 minutes from now.
Thank you.
Thank you so much.
Sir, Shubham and Shurya will be moderating or helping as a master of ceremony in your session, and I will be joining other session.
Okay.
Yeah,
They're parallel sessions?
yeah, parallel session.
Okay, fair enough.
Thank you, sir.
Thank you. Well done. We
Thank
kept
you.
up time because they're all very busy today. And I think, I'm glad we could relieve Dr. Guleria bang on time, and also
Right,
Ms.
sir.
Preeti Singh, because they've got meetings to attend.
Right.
Absolutely.
Thank you.
Well done, Aishwarya. I think you did it well.
Thank you, sir. Thank you, sir. So we'll see you in 20 minutes.
Now, the next session that I'm supposed to be chairing, who all are the speakers now confirmed? There's Dr. Liz Peslovsky,
Yes.
but you were mentioning something else. In my list, she's Integrative Leadership CEO of the CELUS Global Knowledge Exchange, Sydney, Australia.
But as far as the award, this thing was given to me.
I'm here. So sorry, Anil, what was the question?
Hi, Liz.
Hi.
Good morning from India. You are shown as Integrative Leadership CEO of the CELUS Global Knowledge Exchange, Sydney. Is that true? Or you want me a change? Give me a change.
We can do that, or I'm the visiting professor at the Ukrainian Catholic University in Lviv, Ukraine.
Okay, because that is what was I'm a little baffled, because I did hear of, sometimes I find that the mobile connectivity is more reliable these days than the other connectivity because it's heavily overloaded. Anyway, do have a quick coffee break. The other members, Dr. Garg, I see a Dr. Siddharth Jain, Managing Director, EPI India, and Dr. Venkat Ramani Sudigali,
Yeah.
Mr. Neeraj Lal,
Yeah.
and Faye Karnavi Sahai.
Yeah.
Yes, I'm here as well.
Okay, Faye, hi, how are you?
Good, good.
She is waiting from last 3 hours approximately
Oh my God,
from San Francisco.
really sorry,
Oh,
Faye.
No,
Keep
I
waiting.
feel honored to be here. Did you want to organize it as a panel, or I also have slides? I'm flexible to
Slides.
whatever you want.
Yeah, you must show your slides.
Okay, okay.
Who is handling our session, Shubham, or is it Aishwarya?
Shubham, Aishwarya both.
Okay.
And so this is one session which is common, and in the next session I will go in the next session.
Okay. So another 15 minutes, we'll be back with each other.
Yes, sir.
Yes, sir.
Could
Yes,
we
sir.
have a test of our sharing of our screens for our slides to see if they work?
Yes, you can.
Great. Yeah, Liz, that's a great idea. Why don't
Yeah,
you share, and then
Is
I'm
it
going to share
green?
mine.
Green one at the bottom.
You can. I've got a sign saying you cannot start screen share while the other participant is sharing.
You can share. Share a screen.
Yeah, so I
Yes.
think there's a screen that's being shared right now. So
Yeah.
probably that has to be. Now you should be able to do that.
Now you can share, ma'am.
Yeah.
Thank you. That's
Yeah.
me.
You're on screen.
Yes.
Perfect. Thank
And
you.
Liz, if you can just throw a little more light on your face. We are seeing a slightly darker.
Okay. Yes, I will do that. I will do that. I'll stop sharing so others can have a go. And
No,
the light.
on your face, if you can brighten the light. Yeah, that's very good. That's better. Maybe a little more, if you can. Yeah, that's better. Maybe if you come closer to the screen. Yeah, I think that's great. Thank you
Thank
so
you.
much. Okay, I'll quickly grab my coffee. Thank you.
Welcome, Siddharth.
Good morning, sir. Thank you so much for having me here.
Yeah.
Excited about this.
Yeah, so we have a coffee break and just for 10-15 minutes. And
Definitely.
thank you.
Thank you.
Where is my dog?
Good afternoon, everyone.
Good day.
Good,
Good afternoon.
Good afternoon, Dr. Anil.
Thank you. Good afternoon, my dear.
good afternoon, Dr. Venkat. Welcome to the plenary session. Welcome to the
Thank you.
conference. Dr. Razdan, Mr. Razdan, let me know when we can start with the session.
I'm okay. I'm here with you.
Sir, we'll have to first announce the award for Dr. Liz because she had missed the award ceremony and she was not there. So before starting off with the session, we'll announce
Yes,
the
we
award.
do the award first.
All right.
Sure.
All right, so let me announce the awards. Of course, we've talked a little bit about the awards and how these awards are basically celebrating the excellence, innovation, and best practices in the healthcare sector. It's a tribute to the winners' professionalism and commitment and to demonstrate excellence in healthcare sector. So let me announce the award to Dr. Liz. The award bestowed upon her is the EEF Modern Healthcare Global Women Leadership Award 2021. Now, let me tell you a little bit briefly about Dr. Liz. She is a multi-award winner and globally recognized health advisor and mentor to CEOs, executives, and boards internationally. Sits on 3 international advisory boards. She is a lead judge in the annual European Healthcare Design Awards and is a visiting professor at the Ukrainian Catholic University in Ukraine. Dr. Liz's career as a CEO spans diverse areas of healthcare in the public, private, and not-for-profit sectors and in institutional banking. Dr. Liz has demonstrated leadership role in healthcare advisory and strategy in government sector and private sector as well, and also in the global knowledge exchange. So the EF Modern Healthcare recognizes her excellent contribution and leadership role in the healthcare sector and confers her the EF Modern Healthcare Global Women Leadership Award 2021. Dr. Liz, very, very congratulations.
I feel extremely humbled by getting the award. And I actually want to dedicate the award to everyone who organised this conference today, because everyone who organised it recognised that not only the pandemic, but global health is a wellness issue that covers all sectors. And health is an ecosystem, and these conference organisers, they recognise this. So I'd like to dedicate this award to them. So thank you, Dr. Anil. Thank you very much, and I dedicate the award on your behalf as well.
Congratulations, ma'am. And now I would invite Mr. Anil Razdan, former Secretary, Government of India and Chairman, EEF, to please chair the plenary session. The topic for the plenary session that begins in just 2 minutes from now is accelerating digital transformation in healthcare, artificial intelligence, machine learning, and deep learning. So I would invite Mr. Anil Razdan to please moderate the session and also introduce the key speakers for the session.
Thank you, Aishwarya. Welcome, delegates, and I think congratulations to our award winners. And I think, Liz, unfortunately, we couldn't have you in the opening session. I think you're doing a great job, and I'm so glad that women are at the forefront of this health pandemic. And the foundation has, I think, been fortunate in identifying at least 2 women leaders who richly deserved this award. The session we will be having right now is Accelerating Digital Transformation in Healthcare, Artificial Intelligence, Machine Learning, and Deep Learning. Now, artificial intelligence, as we all know, is the intelligence of the future. And I think where human capabilities are receiving reinforced support from extraneous intelligence is something which I think is opening new vistas of not only learning, but also performance as well as management. And I think this management includes health management. And in the opening session, we had very illuminating talks by the two awardees, Ms. Preeti Sudan, as well as Dr. Randeep Guleria. And Dr. Guleria talked about virtually on your prescriptive, or I should say diagnostic, kits on humans so that they can be forewarned for any emergencies. Now, that's the kind of modern healthcare that we're looking at. And we're also seeing where healthcare can guide you what to do next, to be your counselor sitting at home or on your wrist. Now, this is, I think, artificial intelligence, machine learning. Again, what machine can read out of you and what machine can tell you to do, and what all it can do for you in a non-invasive way. Because tomorrow's medicine, as I see it, a large portion of it is going to be non-invasive. And we used to have a saying in India that there are people who can gauge the ailment you can cover from by feeling your pulse. They can gauge you by talking to you. Other physical signs which can lay before them what really ails you. External signs. Now, these signs, I think, are now being mastered by machines who are going to tell you the future. And deep learning is something which, well, for people of my generation is too deep. And I think that there's a lot to learn into the future. But then we also have to take care that these advances in the medical profession do not invade the privacy of individual citizens beyond a point, and also do not become elements of mischief, because every technology has its positives and its negatives. So while we work for advancement of treatment, of cure, of human health, we also have to take care of human privacy and invasion in health. It is my privilege today to introduce our distinguished panel of speakers. We have Ms. Faye Karnavi Sahai. She's partner and co-founder of Mirai Global. We have Dr. Liz Peslovsky, who just got our global award. She's Integrative Leadership CEO at the Salus Global Knowledge Exchange and also visiting professor of the Ukrainian Catholic University. We have Dr. Siddharth Jain, Managing Director, EPI. Dr. Venkat Raman Sudigali, Director and CEO, Excel Multi-Speciality Hospital. Mr. Neeraj Lal, Group Senior Vice President, Medicover Hospitals, India. It's my privilege now to invite Ms. Faye Karnavi Sahai, partner and co-founder, Mirai Global, to kindly begin her presentation.
I'll just start sharing my screen. Can you hear me okay?
Please, Faye, go ahead.
Yes. Oops. And are you able to see the screen?
Yes, we can see it.
I wanted to say that I think healthcare, as we've seen through COVID, is such a critical item. And we've seen industry transformation. We've seen the rapid generation of a vaccine. We've seen how payments can go online. We've seen how insurance has to react to the increasing risks and where we're going, and how it can be digital anytime, anywhere, with any device. And as we look at it, you might think, are we really moving to all digital? We think in healthcare that you're going to always have this hybrid world, more so now than ever before, of the face-to-face and digital, complementing and engaging with your clinician, your patients, and your providers. When we look at the ecosystem, I know many of us here are joining globally. I'm globally from San Francisco in the United States. We know that there is a lot of activity. There are now 70 ecosystems with $4 billion, and a lot of it going into the AI and advanced technology. And it's continuing to accelerate and grow, which I think is very promising. I focus on healthcare investments, and I invest in a lot of startups, as well as kind of just strategize with large corporations on their innovation strategy. What we've seen is some of the largest IPOs on the stock market, an 18% increase in healthcare deals, that healthcare artificial intelligence deals have raised up to $1.1 billion in deals recently. And it's been the largest ever investment period in healthcare companies and startups. As we look at it, we've definitely seen increasing areas, whether it's oncology or cardiovascular or diabetes, and now a growing femtech area in women's health as well, which I'm proud to say is coming along as well. But as we look at artificial intelligence, we really see that the benefits that are achieved from that, where some people are scared of AI and a feeling that it's going to overcome, there are some real great benefits. Benefits in making it more efficient, for our providers to be able to focus on the patient rather than inputting the data, to improve our decision-making process based on the latest studies, findings, insights, and trends, and really enhancing to our new insights to more predictive and personalized medicine from that standpoint. So I think this really enhances our relationship between the providers as well as the patients in this. As we look at it, you'll see a lot of people are trying AI across all different ones. As some people fear, it's kind of reducing headcount from that standpoint, in a sense, automating ourselves out. It's actually the lowest percentage right there, the lowest all the way in the bottom left in actual results. It really is augmenting and offering us a way to become more efficient for the future. One thing, though, as was stated so well from Neil, was that we really need to consider when we're using AI, what is the value proposition that the problem we're trying to solve, not that we're trying to use a shiny new tool. Does that company look like it will be around in the future? Is it flexible and agile for the ongoing? And does it have that trust and transparency? Is it something that we can, as we look at some of these engines, the data that we have, the security, the privacy, the data of our members and our patients, does it have that trust that it's going to build? And will it provide all the support that we need? So one thing I put in here, just because as we look at artificial intelligence, wearables, internet sensors, that are growing all around the world, but especially in the healthcare industry, whether it's your blood pressure or your temperature, your glucose. There's some really interesting startups that we're seeing. Some that are smart tattoos coming to manage your temperature, check glucose in your sweat, look at your light exposure, UV, really being able to test to a lot of smart watches, whether they're Apple or Samsung or Fitbits, now going into smart jewelry and rings, to smart clothing for patients and hospitals, and smart compression shirts as well. So we really see some interesting things happening in this area. And I did want to say that as we're talking about AI and where we're going, we know as far as some of the data that's happening is some of the large giants like Google, Amazon are all going into healthcare. And I just wanted to put one example of Google Health. If you look at all the assets they're engaging on that, all the amount of data that they have and that they're training, that they understand where you are, what you're doing, how you're paying. They are making quite a few investments into healthcare and search that allows and enables our doctors and clinicians to better search the electronic health record, be able to enhance for screenings, treatments as well. So these are some of the examples that they're working together with hospitals, clinicians, providers on kind of tools and investments into chronic disease states. So that's just a quick kind of highlight from that, as well as all the investments that they're making into millions and millions of dollars into healthcare and partnering and collaborating together. So I wanted to kind of see if we wanted to turn it over to the another speaker, or from that standpoint, or if there are any questions at all. So I will stop sharing.
Faye,
Yes.
would you like to carry on, or is that all?
I didn't want to go too much overtime. I can carry on.
No, it's all right. I was just going to mention that maybe 12 to 15 minutes for each speaker. We have 5 speakers and our session is 90 minutes. So maybe we leave 10 minutes at the end for some questions. So maybe if you want another 3-4 minutes, go ahead.
Okay. I apologize. I wasn't sure since I know things got moved around, so I wanted to keep it short and honor all the other speakers. So I will continue then. Let me share the screen. Sorry about that. Try that again. The joys of technology when you're going live. One thing, just talking about Amazon and what's been happening here as well. We see Amazon moving into healthcare as well. They just launched their Amazon Care. They are first directing it to their own patients, telehealth, data. They've also purchased a pharmacy company for pill distribution. They've been getting into healthcare distribution as well. They're looking at robot delivery service. They are PillPack from that standpoint. So it's going to be very interesting to watch and see what Amazon does. They're training their Alexa, their smart digital assistants, and partnering with startups. So they're doing diabetes management, medication reminders, blood pressure with Omron. So they're using it as a platform and really using the AI to understand and train on these skill sets as well. So really interesting from that start. Apple, given its hardware, and it's known for its hardware, whether it's the iWatch or the iOS or iPads or iPhones, from that, they are now getting into healthcare as well with their Apple Kit, and they've kind of interfaced with that, but also in a sense, their watch, and now they have an Apple healthcare record. So with their 1 billion devices globally and all the health data they have now with your blood pressure, your oxygen, your sleep, your fall detection, your medical ID. They've been teaming up with multiple healthcare companies, offering fitness and watch adaptive patients, but also with 11 different healthcare institutions that they are currently in the US accessing the health records online. So now that you can seamlessly have that online and download it from your provider. So interesting from that standpoint of how they're engaging. As we look at Facebook, you might ask, well, Facebook hasn't been as active, but what we see is they're trying to go into the prevention health and where they're going kind of on their social platform and kind of the recommendation engines and complete actions and reminders based on that. And also kind of the sharing with others and loved ones from that standpoint. So we've definitely seen a lot in kind of Facebook leveraging all their data in AI to kind of do both recommendations as well as sharing. One thing Healthcare Digital does a really interesting kind of cycle here, but what I found interesting as we kind of look at it where AI is triggering and helping enable a lot of the new innovations from all the data, whether it's the panomics and what is going to continue for the future in this, but we're also seeing a lot happening in the health monitoring, remote monitoring, safety fabrics, Google's DeepMind project Sideways, as well as predictive and preventative tools. So as we look on to the future, I think AI is bright, but we do need to be very cognizant of the privacy of it, how it is creating the algorithms to ensure it does not have bias. What we found with the early renditions of AI, there was quite a bit of bias based on the data set. It needs to be very diverse from that, representative of all cultures, racial ethnicities, genders, age groups in that, and that it needs to be well trained. So I think several of you knew when they first started Siri, it didn't recognize my mother's accent, right? It was, when we first did computer vision, it didn't recognize darker skin tones. So as we look at artificial intelligence, we need to be really aware of how we're training these solutions for the future, especially in digital health, where we want it to be equitable and accessible for all. So thank you for your time.
Thank you. Thank you. I now call upon Dr. Liz Peslowski. She's Integrative Leadership CEO at the Salis Global Knowledge Exchange and also visiting professor of the Ukrainian Catholic University. Liz, go ahead.
Sharing my screen. So my topic today is talking about accelerating digital transformation in healthcare. And I consult around the world, and one of the greatest problems I am finding is that we're actually asking the wrong questions. And that's what I want to talk about today. So when we're, apologise for that, when we're looking at where digital health is going in the future and how we're going to transform it, we've got to ask certain questions. What are the current drivers of health globally? It's not only COVID, it is a history of the drivers. What are the problems we need to overcome with digital health? I'm finding that we have infrastructure problems that can always be overcome, but I think we're ignoring the human element. You know, we are humans, we're not robots, and I think we need to take greater consideration of human element, and I'll talk about that. But the key questions that we need to ask, and every country needs to ask this, are we growing digital health to support a disease-focused model of care? Or are we growing digital health to support a wider definition of health, health as an ecosystem? One of the key questions that we have is, and I apologise, this is jumping all over the place. The drivers of health around the globe is, and this can be in India, Ukraine, the US, Canada, Australia, any country. We're all got the same drivers. One is to reduce the cost of healthcare, and hospitals are seen as a place of last resort. We've got to reduce the rapid growth in the demand for treatment services globally. Everyone's looking at addressing health inequalities. Our vulnerable population, whether they be rural, socially disadvantaged, and increasingly empower our patients towards taking greater responsibility of self-care. And globally, in every country, everyone's frustrated by outdated hospital facilities and technology. These are the same drivers in every country. And when we look at digital health, how are we going to actually solve these drivers? Clearly, and everyone's been saying this at the conference so far, the growth of digital health has been spurred by COVID-19. Certainly, the growth in virtual health at home or digital health at home through telehealth, remote monitoring has been exponential in every country. E-pharmacy prescriptions are actually starting in some countries where we're before. The electronic medical records, I don't know one country who has not had major problems introducing the electronic medical record among service providers, but it's had an exponential growth with COVID. And we've just heard about artificial intelligence. Certainly COVID is spiraling our love for digital technology. Infrastructure problems can be overcome, but in Australia, we did a lot of research about the adoption of digital technology. And we found that with the doctors in particular, their adoption was variable. We cannot underestimate the fear factor of actually implementing digital technology. So, you know, we gave doctors in a lot of our specialty hospitals in particular, fantastic digital technology. At the end of the day, 98% of them still used their phone as the main form of digital technology. And the reason they did that was because they haven't been trained to do video consulting. They don't feel comfortable with it. A lot of the specialists aren't used to talking to their patients on a one-to-one base. You know, they usually have their nurses to assist them. They're not able to examine physically, and they're concerned about the risk of misdiagnosis. They only see part of the body. They're not quite sure if the patient's explaining the symptoms. And a lot of times they can't follow through on certain tests because there's a lack of infrastructure in the community. We can't ignore the human factors of digital. About the patients. We've got to ask, can all patients use mobile phones for telemedicine purposes? Some of them have never used anything but using it for a phone or possibly emails. Infrastructure, not everyone has connectivity to a network or even stable electricity. My biggest concern around the world is health literacy. How do we describe the symptoms to our doctors? We've never been taught health literacy. What questions to ask our specialist? To actually understand what the specialist is saying without being embarrassed to ask questions because we don't understand. Language barriers, and lack of education of patients about their own healthcare. I don't know any course in primary school or high school that actually educates us about our own health. There's also the information, the discernment. In Ukraine, one of the biggest problems with digital health is the misinformation on social media. You know, it is quite clear that people will listen to social media rather than actually listen to government policies in a lot of places. And data mining, the inappropriate use of health data. And as the preface said, you know, the fact that algorithms sometimes do consider racism unintentionally. So we really have to look at the human factors in digital health. But this is the heart of my talk, and that is, are the digital health technologies strengthening health service delivery based on treatment of disease, which is very much a hospital-centric model, or the wider population health needs? supporting health as an ecosystem. Because whatever answer you are giving to yourself now on asking this question, you will go down a very different path of success. Hospital-centric digital health is seen as the panacea. Spurred by COVID-19, most countries are moving towards a hospital-centric model of digital transformation. Now, quite often people think of countries like India or Ukraine, but the NHS in England aims to move to a digital-first model in the next 10 years. By 2030, their aim is that the majority of people will be accessing healthcare via apps and technology. They're moving down, like most countries, to a hospital-centric model. And this is one of my concerns. I used to run hospitals. I ran one hospital and I ran 24 hospitals. I'm a hospital administrator by background. And, we deal with administrators in government all the time. Any hospital disease procurement model is finance driven. Unfortunately, we are forced by management to always ask the question, by procuring digital telemedicine and artificial intelligence, are we cutting costs? Are we earning more revenue? Are we going to make savings long term? And unfortunately, the most important question, are we improving clinical outcomes, usually comes as number 4. There is a danger in moving down the hospital-centric model. There is an alternative, and it's what the keynote speakers said this morning. Digital health is COVID-19 has shown health is an ecosystem problem. Different solutions are required nationally in each state, locally within each culture. We're looking at the World Health Organization determinants of health, the range of personal, social, economic factors that determines the health status of individuals and the population, socioeconomic, the quality, accessibility of health services, the level of poverty, the level of housing, the type of pollution, water, sanitation. All these are relevant during COVID. So we've got to move away from the hospital-centric and actually understand the importance of the ecosystem. We actually ask a whole new range of problems when we look at the ecosystem. No longer is it treatment focused. We talk about wellness creating environments. It's about wellness as a way of life in all sectors, physical wellness, mental wellness, and social wellness. It's actually a totally different mindset change, focusing on the environment and the determinants of health. That leads to digital health become an enabler. Health is now a cross-sector, collaborative and co-creative initiative. We need digital health to enable us to do a whole-in-government approach where we link health, education, police, planning, transport, all the information together, where we actually link private sector from retail to entertainment, the not-for-profit, community groups, every workplace, every individual. So a holistic view is an ecosystem view. It's not a treatment-focused view. And the whole lot of questions that we ask here are very, very different than most questions most countries are asking. This is where I think India can be a standout. India does this very, very well, and I've done a lot of courses, Ayurvedic, alternate medicine in India. And one thing that India does really well is empower individuals towards self-care. Part of it's necessity, but part of it is because you consider a range of therapeutic regimes. You take into consideration the current health solutions used by residents, and you encourage them by creating health aspects to them. And you recognise the importance of the natural environment to achieve wellness. And I just want to talk about 2 of those because I think they're very, very important. India stands out with a lot of its alternate medicine is that you actually consider the whole person. You consider that every person is vulnerable, they fear health. Our emotions is where we live. In India, you understand energy bodies and how that varies daily. We feel depleted or full of energy. We are intellectual and intuitive beings, and we do look for instant solutions, but at the same time, we are loving. We each strive to feel loved with social connections, and we are spiritual because that's where we feel safe. If we're going to do digital medicine, we need to look at ourselves holistically, not robotically, as we are currently doing in most of our solutions. And I want to stress the complementary and alternative medicines. You know, I went to India to learn about energy medicine and Reiki, and I am a Reiki healer as well. But I noticed that complementary and alternative medicine is something that is commonly used in India, immediately available, less expensive, natural. Patients feel listened to quite often by these therapists, and they can satisfy their spiritual needs. And you recognise the importance of nature to create wellness. You know, I mentor CEOs around the world, and I have to teach them to ground themselves in their body by going out to nature, because it's something that they're not taught. So we need digital health solutions to be able to absorb the importance of nature and grounding people in their own body. And the fact that natural landscapes help physical activity, encourage social interaction, and also mental health. We need globally national policies, and I think India can take the lead on this. National policy initiatives mainstreaming population health and wellness as an agenda in society, nationally, state, and at local initiatives. To encourage strategic investments, and Faye, this is a good one for you, and partnerships in growth of health systems in a wellness environment. We always need to get measurable results through improving and sharing knowledge. If we can't measure our results, they will not succeed. And to implement robust national monitoring, reporting, and evaluation. India has the power, and I sincerely believe this, to be the global leader in an ecosystem virtual health model. And thank you for allowing me to present, and I'd love to answer questions at the end of the time. Thank you.
Thank you, Liz. Raised very interesting issues. It depends, alternative medicine depends who's the alternative to what. Because antibiotics is not the only medicine. I'm glad you raised this issue. Thank you very much. Our next speaker is Dr. Siddharth Jain. He's Managing Director, EPI India. Siddharth, please.
Thank you,
Go
Mr.
ahead.
I'm just going about to present my slides.
Share the screen. Green button.
Are my slides visible?
Yeah, we can see you.
All right. So I'm going to take a little bit of a different approach, whilst my panelists have been talking about different technologies, and I will also touch upon the key technologies. I wanted to delve a little into the strategy and the decision making that goes behind selecting these strategies. So very quickly, I'm just going to introduce EPI. I'm going to talk about the IT strategy, digital transformation in itself, and the technology trends that help us achieve digital transformation. So EPI is today the world leader when it comes to data center and IT services, specifically digital transformation, data center consulting, training, etc. We present across the globe in 65 plus countries and 130 locations. As I mentioned, we've been recognized as an expert data center and IT service provider. Not spending too much time on this, I will jump straight into the topic, considering that I have a lot to talk and obviously the paucity of time. So talking about the IT strategy, the first thing that comes to my mind is obviously the entire industrial revolutions that we have seen, right? So historically, if we talk about the industrial revolutions, we are talking about typically 4 industrial revolutions that started sometime in the latter part of the 1700s with the steam engine, going on to electricity, telecom, IT, nuclear, and the latest, the industry 4.0, as we call it, which is driven by the internet. Now, obviously, what this is doing is bringing together digital, physical, and biological systems, right? And that is where healthcare is also poised to benefit a lot from this latest revolution that is happening. Now, when we talk about IT as a strategy, I would typically talk about 3 strategies that have existed. The old-fashioned way, which was typically keeping the lights on kind of a situation. It was more of, trial and error. So the typewriter got replaced by the computer and we said, oh, we're moving digital, right? So that's typically what we call the old-fashioned way. The traditional way, again, looked at aligning the IT to the business. So the objective was to improve staff productivity. It was to reduce the cost of running operations and obviously optimize and improve your business processes. The focus was still on TCO, or total cost of ownership of running these projects. The modern way, as we see it today, is basically looking at IT acting as an enabler, right? And that is exactly what we are trying to achieve with all these technologies that we're talking about: big data, AI, blockchain, machine learning, etc. These technologies are going to act as an enabler, helping organizations not only generate revenue, but hold the customer in focus, right? So the only way to succeed in today's environment, in this changing environment, is to have a very, very customer-centric strategy, right? And this is very, very clearly evident from so many examples that exist today. Why is Amazon and Apple so successful? Faye just spoke about what all Amazon is doing. Apple, what are they doing, right? So why are they successful? Because their strategy is very, very customer-centric, and they are ahead of the curve of technology and not sitting on the fence and waiting to see what's happening, right? So the modern way is basically to focus on customers, and more than TCO, the focus is on ROI, or return on investment. So naturally, the way forward is to adopt the modern way, or the modern strategy for digital transformation. Now, with that, what exactly is digital transformation, right? Now, of course, you can find various definitions of digital transformation on the internet, Wikipedia. I mean, you name it and you have it, right? Now, one definition that I really like is, which talks about digital transformation is the integration of digital technology into all areas of an organization, resulting in fundamental changes. So what we are concentrating on is the outcomes to how the business operates and how they deliver value to the customers, which again goes back to the modern strategy, talking about being very, very customer-centric. Now, digital transformation, if you ask me, does not change what we do. It's actually going to change us, right? And that is the fundamental premise that one needs to keep in mind, right? It can be something as game-changing as giving you the ability to visualize brain activity inside a human being using a simple consumer-based EEG device, right? You would get access to waves and cells inside a brain that we never knew existed, right? It could be something as game-changing as genome editing, which basically is helping us today fight cancers and all those kind of things that are there. So digital transformation changes outcomes and truly empowers people to create a more equitable growth, right? So that is the underlying premise of digital transformation. And from there, we basically need to move ahead. So what are the drivers and benefits of digital transformation? Of course, it's helping us with robust and faster decision making. It is helping us improve efficiency in delivery of our services. It is relating to an enhanced customer experience or value that is being delivered for our customers. In this case, could be our patients to whom we are delivering services. Enhanced profitability from an organization perspective, and increased market penetration, reach that is made available using technology, and ultimately the overall risk reduction is what we're doing, right? So now digital transformation, the key drivers, of course, very business related, but the truth of the matter is a lot of it is related to how the business performs. Now, when we talk about digital transformation, what to understand is it's not like you switch on a light and the light comes on, right? This is an ongoing journey. So changes are going to take time. Technology is changing and it is changing very fast. In fact, it is changing as we speak. So obviously, the more profound the change, that much more difficult and more how do you say it? It's going to be a little more challenging to have those changes implemented. So it needs to be comprehensive and holistic. You need to obviously cover a huge number of processes within your organizations, interactions among different areas, transactions, your technology evaluations or evolutions that you are going to see, changes in the internal and the external factors. So all these things need to be looked at while planning your digital transformation strength. Now, a very, very important aspect in digital transformation is not only about the technology, right? We tend to obviously look at all the buzzwords. Now, needless to mention, all the technology that we are talking today are no more buzzwords, right? We have seen use cases and we are seeing how we are benefiting from it. But again, I would still like to, stress on the fact that successful digital transformation is not going to begin with the technology, right? You need to focus on overhauling the entire organization with a customer-focused goal in mind. And most importantly is having the right people at the right place. This is what is going to enable driving the successful digital change, which is often more about the people involved rather than about the technology. So technologies will keep evolving. We will see more technologies coming, but we need to have a right set of people or right skilled, right? So you might need to hire new people, you might need to reskill or retrain your people, but having the right team is extremely important to achieve the digital transformation. Now, talking about digital transformation frameworks, these are increasingly necessary as every organization that tries to keep up with the rapid pace of change that is happening with the technology. So digitalization is happening faster than any of us can really change, right? So we all know how fast the technology is changing. Technology is driving the change, but human demands are also pressing and forcing organizations to adjust quickly. Now, we've also seen that if we do not adopt these technologies at an appropriate pace, we are going to get left out, right? Kodak is a very good example. Blockbuster is a very good example. I mean, all these got disrupted just because they closed their eyes towards the changes that were basically coming in the industry. Organizations that neglect to get more strategic and purposeful in their digital efforts are going to risk missing out on the potential offered by the emerging technologies and solutions. So the benefits, of course, are that you need to have an agreed organization-wide approach, an understanding of change and how your employees are going to be involved. How are you going to reskill them? How are you going to basically involve them in this new way of doing things. You need to create a blueprint that maps the current state and the goal that is basically the end state. You need to have a guide to engage with your customers to make them a part of this ongoing journey, right? Because ultimately, the key thing is to have a very customer-centric focus. The mandate to assess current systems and skills versus the required future state systems and skills, obviously looking at all the different technologies like cloud, IoT, big data, machine learning, AI, etc. So coming to the digital transformation technology trends, again, I'm just going to touch upon these at a very high level because I know we have even the next session that is focusing on detailed sessions on these technologies. But at a high level, I thought it was important to touch upon these. So if you look at the technology trends, obviously we have a whole lot of these. You have blockchain, big data, AI, which is obviously machine learning and deep learning as well. Your converged and hyper-converged solutions, augmented reality, smart cities, robotics, 5G. 5G is going to have a major impact in helping enable all these technologies that we are talking about, right? We're moving more from a hyperscaler model to an edge model, and that is going to be enabled by the rollout of 5G. So when we talk about the technology strategy, new technologies obviously have the potential to grow the business and operate more efficiently. But for each of these, we need to determine how will it contribute to the organization? What is my competition doing? Does it fit into the current architecture and infrastructure that I have? Assess the resources and the funding that is going to be required to adopt and operate and run these technologies. What is going to be my roadmap for adoption? There has to be research and development, some innovation, a pilot project, ultimately a rollout. And once it is rolled out, the ongoing operations need to be managed effectively as well. I'd like to pause here and you know, when Dr. Anil invited me to speak at this conference, I was really excited and thrilled about it. And I also tried to do a small survey with a lot of hospitals that I could have access to. And leaving apart a few very large pan-India establishments, the more mature, large size, but regional hospitals, it was really surprising that they did not even have the basic cyber hygiene in place, right? And when I say cyber hygiene, I'm talking about how the data is stored. Now, I'm talking about patient records, the entire ERPs and everything. It was just housed on a few servers kept within the hospital. There was no proper backup solutions available. There was no cybersecurity mechanisms in place. Backups were taken plainly on some external hard disks, which were also lying attached to the server. So now in today's date and age, if there is a cyber attack and if there is a ransomware attack wherein your data is encrypted, your external disk, which is lying connected to your servers, also is going to get encrypted. So your backup is also rendered worthless, right? The only way to recover from a ransomware attack is to recover from your backups, right? So something as simple as that is also missing. And that's precisely the reason why I thought we need to go down to a much more foundational level than get into all these high-level technologies. So you need to first get to that level of basic cyber hygiene, and then you follow the strategy and the evaluation of the technology, your current setup, your resources, and how do you move ahead with the digital transformation. So research and development and innovation is also going to be an important part of your digital transformation or optimization. You need to perform a research on what is available. You assess the tools and the emerging technologies, verify how these are going to align with your requirements as a healthcare entity, your IT strategy. Investment decisions are commonly based on the best fit, which is strategically, financially, and culturally evaluated, right? You need to partner with companies who are at the forefront of the technologies to ensure that you will be able to achieve the benefit that you have set out to achieve. Now, coming to all these different technologies, so I'm just going to very, very quickly touch upon at a high level. So blockchain is obviously today becoming a very important aspect and has significant benefits for the healthcare industry as well. So blockchain basically provides a secure global platform or a ledger that allows both individuals and enterprises to make and verify almost instantaneously a wide variety of transactions. Now, obviously, this is intended to provide a tamper-proof record of transaction metadata, regardless of the transaction type. So here we are also talking about medical records, for instance, right? Because the biggest fear any healthcare establishment or an individual has is about leaking of their medical records. So blockchain obviously can play a very, very important role here as it obviously would provide you that security. So blockchain comes in different configurations. So it could be a public or an open source, a distributed network, or a private network, which basically requires explicit permission to read or write. Right, so blockchain, to give you an example, you could think of this fish that you see on the screen as the vaccine for the COVID-19, if I were to relate it to the situation today. So I could have a track of where this vaccine was manufactured, on what date, by which organization, the entire supply chain, how it moved from the lab where it was created, where was it, at what temperatures was it stored, how many points did it move, who was given the vaccine, what was the date that this person was given the vaccine, and obviously the entire chain of command is what you have complete visibility, fully secured, without the requirement of any government intervention, right? So that is, again, a great technology that the healthcare industry could benefit from. Big data, which is also one of the foundational topics for this, this session. Obviously now big data is a term used to describe the exponential growth and availability of data, structured, semi-structured, unstructured, and trying to make sense out of it. So if you look at the definition by Gartner, big data is basically high volume, high velocity, or high variety information assets that require new forms of processing to make more sense out of these data, that is going to assist with decision making, give you insights, and obviously help process optimization. So the keywords here are the high volume, high velocity, and the high variety, right? And trying to make sense of all this, making data more actionable so that you can benefit from that. Now, big data is basically...
excuse me, Siddharth, we'll need to wind up soon.
Sure. So I'm not getting more into details of big data then. Artificial intelligence, of course, which is nothing but simulation of human intelligence processes by the machines. So again, we're talking about the AI, which gives you the ability to have some cognitive abilities to basically support and take action. So again, AI technologies are your machine learning and deep learning, which are going to assist you do that. Cloud computing, which is fundamental, as I already spoke about, having your records in a much more protected and a safe manner, having backups, disaster recovery plans in place. And lastly, the Internet of Things, which is basically, again, as we spoke about, the connected devices, the wearables, which are going to assist with, moving ahead. So consumer IoT, commercial IoT, industrial IoT. And in the healthcare, you've seen a lot of use cases, both with consumer IoT, where we talk about the wearables, and commercial IoTs, where we talk about connected medical devices. So to summarize, digital transformation is no more just a buzzword, but a need. Those who choose to sit on the fence will be disrupted, and this is what we have seen happening. We need to start with creating the right strategy, which is customer-centric. We need to address the low-hanging fruit to start with, basic cyber hygiene, as I mentioned, get the right people to execute the strategy or train the existing teams, and then select the right technologies, keeping the business goals in mind. Right. So thank you. Sorry for having gone slightly over time, and I'll be happy to take questions as they come. I am just moving from stopping share.
Thank you very much. Thank you very much, Siddharth. That was very informative, and I think a wake-up call for all of us to get used to the new normal. The only question which comes to my mind is, what does your artificial intelligence or deep learning say? Do we have a vaccine yet, or only a DNA exciter? A quick question to your AI expert.
Yes, so that is, when we talk about AI and machine learning, we're talking about now again getting into more predictive analysis, right? So again, if you look at it, we are still, there is no conclusive answer at this point in time. But yes, we're seeing a lot of things moving ahead, and hopefully soon we should have an answer to that as well.
I thought I was a bureaucrat. You're giving a very bureaucratic answer that even I'd like to give Parliament. So AI seems to be no better than a bureaucrat.
I would tend to agree as of now.
Okay, thank you so much. Now, our next speaker is, we'll probably have questions at the end, is Dr. Venkat Ramani Sudagali. He's Director and CEO of the Excel Multi-Speciality Hospital. Please, Venkat, go ahead.
Thank you very much. I hope you can see the screen that I'm sharing.
Yes, we can.
Great. I feel privileged to be amongst the learned panel members. Very, very nice. Congratulations to Dr. Liz, and I'm very impressed with the way she presented. This is a tech-related topic, but her presentation was equally human, I would say. I want to thank Dr. Anil and the team members to take the initiative to conduct such a wonderful conference, very relevant in the current scenario. So my name is Dr. Venkat. I am a consultant radiologist. I trained in the UK. I was in the UK for almost 20 years. I still do consulting for the UK NHS and Ireland, even if I'm physically in India currently since the last couple of years. I also am the director of a hospital in Hyderabad. I'm the ambassador of the UK Royal College of Radiologists. I also have startups and health tech firms that I'm consulting to. So I would just focus, I would start off with a broad overview about healthcare technology and the digital transformation, but focus on a couple of interesting models that I work on at the moment. So my interests are, basically a clinician, so I do my clinical work every day, which is probably the most important work that I do, helping my patients in day-to-day life. And that's what is my passion. So every technology that you can talk about, unless they deliver what you want to the ultimate end user, which is a patient in our case, is what we all need to aim for. I also do a lot of academics. I do advisory roles. I'm also a health tech consultant in various firms, as I just mentioned. So healthcare is actually going global. If we talk about healthcare or health technology confined to a particular region or a population, I think we are making a mistake. And especially COVID has proven that the world's health is actually very important. We have seen the effect of, pandemic, people traveling across the nations and spreading the virus so quickly. We're also talking about vaccine passports, for example. So important to consider healthcare as a whole, as a worldwide phenomenon, I would say. And India, coming to our country, is that we have a worldwide workforce. Many Indian origin doctors, nurses, pharma, for example, are everywhere in the world. We are the software hub of the world. Even though Facebook is a US-based company, they probably have more stuff out in India rather than anywhere else. We have a very big medical devices. We are called the pharmacy capital of the world. We are the biotechnology capital of the world. We have the largest vaccine manufacturers in the world, and we have been giving out vaccines, which probably no country has done so far um, due to COVID. So when we're talking about digital transformation, healthcare revolution, etc., we all know about these things, and people have been talking about since the last decade or so. Robotics, Medtronics actually has a factory which is just very close to my place where I live in Hyderabad. So 3D printing, I know we have a 3D software making facility in our radiology images where we develop a model, send it for 3D printing, and the patient can have a 3D printed prosthesis specific for his age, size, sex, and his fitment. We have talked about wearable technology, telemedicine, genomics is another field which is very interesting and looking forward to future. So these were the well-established, I would say, but the future of healthcare would be a little more grayish area for the time being, but very promising, I would say, on the whole. Blockchain technology, it's a secure, transparent information sharing, which is probably going to revolutionize, especially in the field of insurance tech sector in a country like India, where the insurance is starting to build by leaps and bounds. We've got VR and AR technology. And I've seen several demos by a few companies where they actually have VR technology to teach the medical students, which I found was very interesting. Big data, AI and ML, I'll give you a couple of examples. Drone technology for delivery of medicines. This was, a fantasy world a few years back, but now it is reality. And we also have stem cell therapy building up. But when we talk about all the latest and greatest technologies, fantasy worlds, I would say, in some areas, but are we making improvements in patient care, patient safety? Are we improving the quality? Is it timely and sustainable? Is what my question is going to be for all the panelists and the audience. Now, let us focus on our nation, India. I would say India is actually the hub of healthcare and health tech startups. I work with the ISB Healthcare, which is the Indian School of Business, one of the most well-known business schools in the world. And especially after COVID, there has been a revolution in terms of healthcare startups. And we have so many, including software, hardware, we've got AI technology, we've got medical devices, we've got device and analytics in one startup. We've got so much of funding which is going on. And indeed, the healthcare sector is going to be 300 billion plus in the next couple of years is what the prediction is. And actually, we are living in a world of health tech revolution. And if you see almost every area, fitness, genomics, biotechnology, deep technology, telemedicine, pharmacy, personal healthcare, healthcare IT, home healthcare. So many areas, they have been discovering new areas where technology can penetrate and make a difference to daily lives of the people. As an example, I work with this artificial intelligence company, which has been making a global impact in healthcare revolution. TB has been a problem worldwide and more so in India. Still continues to be a major problem. There are many places in the world, Africa or Far East, Latin America, where TB is still a big burden. And we can use artificial intelligence to take an X-ray to diagnose within seconds what's wrong with the lungs, and then quickly refer the patient for urgent treatment. And this is an example where we did some COVID cases where it quickly analyzed as a follow-up regarding its progression or regression, which was extremely useful for the number of cases that we are doing, especially in COVID, which is rising. And this was one of the case studies in Italy, which got published in major journals as well. Another example where breast cancer screening, it's a very, very well-known and well-established fact in the Western countries, but in India, cancer screening is still a no-go area in many remote locations, especially. And, we can use thermal analytics, for example, which this company has been using since the last couple of years and making significant progress. So this is a point of care, small device, which can be sent to any remote location, and then images analyzed based on thermal sensitivity within the breast tissues, and a diagnosis can be given. Another thing which I was talking about was patient's passport or medical communications. We all use WhatsApp at the moment, which I think is really, really annoying for some of the clinicians, especially people like me. They sent me about 2,000 images on WhatsApp asking me to instantly diagnose, and I can hardly see what's going on my small mobile screen. But we all should have a secure, certified means of communication with the patients and with the fellow clinicians, I feel. And this is one of the tools which I am working with. It's a UK-based company. Extremely useful for a country like India, where patient can be remotely located, specialists can be only in the city centers, and you can quickly send an image to them and ask for clinical opinion and do some innovative work in those fields. So I am wary of the fact that the time is an essence in this presentation. So just going across, what is the cost of innovation? We should really think about this major thing which nobody talks about. Is it going to replace the staff? Is it going to decrease the number of staff? Is that our concern even? What about the patient? Do we add to the patient's billing saying that we are using new technology, we are using artificial intelligence? The patient is going to worry just about his treatment. Is it going to be a problem-solving tool or a problem-making tool, all these technology that we have? What is the value and what does it make sense at the end of the day is my major question to everybody to think about. So when we talk about healthcare of the future, we all want healthcare to be better, faster, and but actually speaking, we need better patient's experience, faster diagnosis and treatment, and higher efficiency and cost savings. So new technology should not be costly for our patient. It should be saving costs for the insurance sector, to the patients, and to the hospitals as well. So just a last slide, which I want to conclude by saying that the world is becoming a small place. India is a major global player in healthcare segment, and the photographs that you see is all the Indian origin people who are major CEOs of many companies across the world. So we are here to stay. The sky is the limit. So anybody who wants to collaborate with India, with myself, please feel free to get in touch, and hopefully we can change the world for the better. Thank you very much.
Thank you. I think very interesting talk, but I think it begets a question from me that I'm glad when you see respect and recognition for other systems of medicine. I think when we talk of holistic medicine and convergence of different systems and different technologies, I think the time has also come for medical researchers and practitioners to probably respect and recognize other systems of medicine and their relevance, because the traditional systems have preceded a lot of allopathic institutions, except that they were not well scientifically researched or documented, but they were kept as family treasures or secrets. And I think the scientific mind of the 18th century onwards did not percolate into the other systems of medicine. And maybe the time has come to integrate all these systems of medicine through the benefits of IT, AI, and what you call deep learning. Doctor,
absolutely. And I just want to add one small point, Dr. Anil. You've absolutely said the correct thing, that we cannot confine to just one healthcare system. Basically, because we are only talking about the human health in the physical form. There's a lot more to each human body. We've got the mind, we've got the soul. So as a healthcare, we should have a holistic approach to our patients, not just the physical form. Thank you.
That is, you see, about, you rightly said, we've got to address all the various components of health, not only the visible physical ones. But I was talking of the systems of medicine, and I think the time has come to integrate them also. And when we are saying the globe is one, we do need to bring them at par in terms of the kind of rigors which I think modern medicine demands, and the kind of recognition also which needs to be given to ancient wisdom. Well, thank you very much for this very informative.
Can I just make a comment on that? Because I can't agree with you more. And a really good example of what you just said is now in cancer care. If you look internationally, and I was lucky enough to do an international best practice study tour on this, most of the places of excellence for cancer care now have integrative medicine, where they combine Western and Eastern medicine. We can no longer ignore that, because when you survey cancer patients in any country of the world, 80% of them use alternate medicine, but only 20% of them tell their doctor. We have a duty of care to actually support our patients and integrate Eastern and Western medicine.
Quite true. That is what I was looking at, because I think this pandemic should bring about some degree of integration. And because we did, you see, earlier in the session, talk of alternative medicine. It's just like saying it's a foreign language. Now, foreign to whom? Alternative to whom? You see, there is no single language which you can claim to be God's language or nature's language or God gifted. So these systems of medicine, they should, what we in modern, I should say, Western medicine call as alternative medicine, they should learn from that, learn the rigors of it, and the need to base it on modern science, verification, and verifiability. I think the point has been well brought out. There is, I think, accelerated healthcare and diagnostic investment. Now, I said earlier in the morning that, see, health is wealth. We all talk about that. And there are three aspects of wealth that I look at. And one is, of course, a healthy person he can't enjoy his wealth till he's healthy. Number two, health has become a big money spinner, healthcare. Now that is inevitable, because anything that is necessary for giving you comfort is certainly going to be a money spinner. But when money making becomes the prime objective, healthcare is lost out. And that is where I think the need for transparency, some degree of stricter regulation, and also accountability. Because we are talking of risks of misdiagnosis in videos or mobiles, or the kind of artificial intelligence that we are talking about. So I'm quite sure the legal experts will put enough unintelligible legal caveats in all this, and maybe there will be some protection. There is need for protection also, but what I was trying to say is that there is need for a regulatory body to oversee and build public confidence in healthcare and the newly emerging systems. Because after all, we are trying to, unless you do that, you will not be ensuring that health is there for all. And the last point, luckily, I think this pandemic has shown that our investment on health and healthcare, public investment, I would say, or publicly shareable investment, is not as much as it ought to have been. And I think we need to invest much more in preventive health and also in research and development in public institutions. I'm talking in the context of developing countries particularly, because unless you put money into the system, it is not going to develop. And unless you put a rigor of scrutiny, it is not going to develop in the right direction. And unless you put some degree of accountability and strict punishment for spurious medicine and for fake advice, you will be leading into a lot of frauds in the times to come. But I think this session has been extremely, informative. And I throw the floor open to any questions from the audience and participants, or even the panelists between themselves, because we've had a wonderful list of panelists. Why I'm taking this liberty to do so is we just received word that Mr. Neeraj Lal, our participant here, is caught up in a meeting with Telangana, I think online, and he's unable to free himself for this meeting. So we had that additional 5 or 10 minutes. Maybe the panelists have the first right to ask any questions of each other.
You had a great question on data and security that is associated with the whole AI ecosystem. And I think it was directed towards Siddharth. So Siddharth, could you take that question from Faye, please?
Yes, Faye.
Faye, would you want to elaborate?
Go ahead, Siddharth.
No, I'm looking at the question. I'm not able to see the question.
Yeah, Siddharth, so I think the question was in regards to the medical hygiene, right? So,
right.
And that's one segment, but with AI and ML and all that, big data comes up data security and all, data security as well. So right. Any thoughts on that, on those lines would be great as well.
Okay, so going back to what I was saying is, we need to have some basic level of cyber hygiene with all these things. Now, today we're talking about the newer startups and all those things, which are really using these technologies as an enabler to deliver these services that Dr. Venkat spoke about, or the tools that were shown to us by Faye, right? So those are already there. But again, what we need to understand is till today, the brick and mortar, the hospitals that are delivering these services are the first point of contact for our patients, right? So these are the points where a patient who basically, senses some discomfort or is suffering from an ailment or illness reaches out to. And the state of the IT or the so-called digital transformation at these hospitals is a bit concerning, right? And that is where, again, talking about the basic hygiene came in, and then going on to the cybersecurity aspects of it, especially with the COVID-19. We have reports from the WHO, we have reports from the Interpol, which have shown that how targeted the healthcare industry has been. Specifically, all the vaccine manufacturers, the supply chain of the vaccine manufacturers, these have been extremely vulnerable to attacks, right? And that is where bringing in a lot of cybersecurity, initiatives for these hospitals, these healthcare establishments, manufacturing vaccines, distributing vaccines, etc., becomes very, very important. It needs to move from the basic antivirus solutions, etc., that we talk about, to more AI and ML enabled security, right? Where we can actually predict what is going to happen over our network. We can actually visualize, right, what is going to happen or what is happening. In most of the cyber attacks, it's been seen that it takes almost about 260 days before you even realize that somebody is already sitting inside your environment and understanding or learning your organization, right? So, and intruder is there in your organization for almost 1 year. He understands the relationship between people. He understands the relationship between all the processes you run, etc., before he actually takes action. And it takes 260 days before you even realize that, right? So that is where, again, you have security operations center solutions, SOC solutions, or intelligence SIM solutions that we talk about, which are AI and ML enabled with a lot of self-healing capabilities, which in the technology parlance, SOAR, which is basically able to take action on its own based on what it detects. So yeah, I mean, there are a lot of things available. But again, as I mentioned, it has to be a step-by-step approach. It's not an all or nothing situation. So we need to start somewhere. And it is about time the healthcare industry, really looks at this seriously, because today, as we speak, they are the largest or the most vulnerable, the largest targets for hackers and the most vulnerable today. I hope.
Thank you.
Question or
any questions coming in? Venkat, I think you were putting a query across that maybe we should be in touch, but we are in touch, and go ahead and ask some questions.
Well, we do.
I know radiology is a science where the greatest advancements have been made. And I think, Faye, I can see you also on the screen. Maybe you can want to ask a question.
Yeah, we do have a question from Mina about when do you think a complementary integrated approach of medicine would be applicable on the ground? And Dr. Venkat, do you want to start with that, and I can follow in with you?
Sure,
Yeah,
go ahead. Choice is yours.
I think India is leading the way in this field, actually, because we have equally excellent, in fact, world-class care at least in the major centers, which can provide excellence in medical care. And if we take the example of cancer care, as Dr. Liz said, we have really good scanners, treatment, proton therapy centers, etc. But we are also aware of the fact that there needs to be some kind of complementary, and it has been scientifically proven that not just medical or the allopathic care, but also a spiritual healing component needs to be there for patients to get better fast. And it has been scientifically proven. And indeed, many of the centers offer these kind of complementary treatments. And in fact, I know a couple of centers who have practitioners going in and speaking to their patients when they are through their chemotherapies. And I think the patients feel better. And, that is what everybody needs. Cancer care, cancer chemotherapy, these are all tough things. And even if there is prolongation of life, how is the quality of life? So essentially that is what everybody was trying to get the message across, that we should have a holistic approach, not just confined to one medical allopathic type, but also complementary therapies as well. Thank you.
And Liz, I see you nodding your head. So please chime in.
Sorry, can I just add to that? There's a lot of research out there already. We just don't share the information. So, it's proven, and it's been in the Western highly regarded journals that, acupuncture is used for pain relief, hypnosis to reduce stress, the use of vitamin C. But there's also a lot of evidence too that it's very, very dangerous if you actually combine some of these therapies together as well. So there are a lot of risk factors as well. You should never use vitamin C when you're doing chemo treatment. So, I think we need to get the information out there. I actually did a consultancy for a Chinese company in Australia, a company in China who wanted to come to Australia and build a centre of excellence based on Eastern and Western medicine. And it took me about 6 months to work out what their real driver was for setting up in Australia. And what they wanted was actually a Western port to do their research so they could get their research published in Western journals. Because there is a lot of research out there, but because it's not in, Western countries, they're not actually put in the appropriate journals. So I think we need to actually focus on the research that's out there and actually sort out the publication issues as well.
Liz, I think you raised a very relevant point, you see, because all research, including, medical research, needs some protocols. And I think if you want to integrate the various systems of medicine or consider them holistically, I think these protocols have to be laid out appropriately. And it's only if you conform to those protocols, you will get the recognition. But then this calls for somebody who is managing that system or that protocol to also respect and appreciate that there is another point of view. Just as we are multilingual, we are multi-religious, but we can also be multidimensional in the kind of medical care that we are talking about. Because a lot of medicines in the allopathic system are also derived from herbs. They're not molecules which are taken up in laboratories alone. It's not only bioengineering. It is also, I think, acceptance of certain effects in homeopathy is another such system. It did emerge and it is effective in many known cases, particularly in cases where I would say, sorry for taking you into another domain, and that is veterinary care, because it's like treating a child who can't yet speak when you're treating somebody else. So you have to go by symptoms, symptomatic treatment, and your ability to observe. And I think that is where artificial intelligence and the collection of this data that we're talking about through machines is going to help you tremendously.
Yeah, I just wanted to add, I agree that I think, as Dr. Venkara was saying, that India is far ahead in really looking more holistically of both Eastern and Western medicine, recognizing it as such. When we look at other cultures in healthcare systems, I can speak to the United States, we do not recognize that. We do not reimburse for it. We do not have protocols for it. We don't look at the drug interaction, Anil, as you were saying as well. And I think AI will help us get that insight as well as the interactions and the effectiveness out there more. To Mina's question, the hope that we have this virtual platform and the data and the input from that, but also from multiple cultures, backgrounds, heights, ethnicities, to look at the implications of them as well will be critical. But my hope is that we'll actually go faster towards that, because our healthcare systems, our bodies can't sustain where we're going and what we're doing. So.
Yeah. One thing that we haven't discussed is the limited education doctors get in their medical training. So they're not actually exposed to complementary and alternate medicine in a lot of Western medical colleges. So by the time they come out, they're very ignorant. And therefore, because they're ignorant, they're fearful of complementary and alternate medicines. I was in one hospital, running a hospital, and I actually did a survey of oncologists about their thoughts on alternate medicine for cancer care. And I got 3 distinct responses. The first one was, I know everything I need to know. I don't think I need to know anything else, so I'm just going to ignore it. Another response was, I'm really scared because I don't understand it, and therefore I'm going to ignore it. And the third, and this couple of doctors I absolutely loved, well, I'm actually using it, but I'm not telling anyone because in case I get in trouble. So it just sort of highlights again the human side, that we need to start approaching alternate medicine in the medical schools. So people are exposed very, very early So they actually see a person holistically, not as a component part of a body, which is currently the case in a lot of medical schools.
I think, Liz, you are absolutely talked in the right direction, because I firmly believe that the greater the ignorance, the greater the arrogance. And the more you read, the more you realize that the less you know. So I think life and learning doesn't end. It only begins in a medical college. And I think if that is understood by our medical practitioners and policymakers, that may be the beginning of a new era of healthcare and treatment. And that is where I think artificial intelligence and what I said, deep learning, is I think deep means going to the depth of it. And there are various depths and layers of knowledge that we have not yet unearthed, because the human mind and the human brain has its limitations. And that is where AI and machine learning will take over and hopefully provide the answers to future generations may not be in our generation. Thank you very much. Unless there are more questions, we will say goodbye to meet again.
There is one more question from Ematron. Many of the procedures and skills in complementary medicine are not accepted by Western medicine because there's no evidence by research. Should we apply Western research evidence before we accept the complementary medicine? And I think, Liz, you were talking exactly to this kind of point.
Precisely, Faye. That is what I was saying, that there's need for protocols. You need to bring all these systems on a single, protocols which are mutually acceptable.
Look,
and that is where I think the other systems have lost out.
One of the areas I get really, really frustrated with Western research, and look, I've got my PhD and I've got my master's and whatever, so I am an academic and a researcher and specialise in translational research. But take me to a Western conference where they do research on meditation and or energy work or whatever, and I feel like I want to hit someone because they continuously ask the wrong questions. They use intellectual Western thinking to a holistic notion of medicine. So they ask the wrong questions. If you get the wrong questions, you get the wrong answers. So I think we have to be very careful in what questions we actually ask.
I think we need to shed that diffidence or ignorance, and I think artificial intelligence should become an integrator of the different systems of medicine in the future, but it has to be preceded by, I think, protocols, which are the rules of the game. So thank you very much, and I thank each one of you for having spared your valuable time to attend, and also given an opportunity to an ignoramus like me to sit and listen to some very, very beneficial views and leave richer. And I hope each one of you has the same experience. Thank you very much.
I just want to add one comment just to sign off. I'm very glad and in fact amazed. The topic was artificial intelligence and technology, but we talked about healthcare as a holistic phenomenon and the human body and mind, etc. So it just shows that maybe working with machines is just not enough, but you should actually take care of your patients at the end of the day. So very nice. Thank you, everyone.
Thank you, Venkat. Although I'm a career bureaucrat, but my father was a medical practitioner, a surgeon. So there's some background to that. And I have two dear friends in your profession, Dr. Harsh Mahajan.
Oh, yeah.
And
I know.
Also his former senior colleague, Colonel Shekhar Pant.
Very nice, sir.
I've
Pleasure.
known them over the last 40 years, I think. Thank you very much.
Thank you.
Mr. Chairman, and thank you, distinguished participants and speakers. We will have this discussion in future also, and definitely on next year on 15th of April. Thank you very much.
Thank you.
Thank you, Dr.
Thank you.
Garg.
Thank you very much.
Right,
It's been a pleasure.
thank you so
Thank you.
much. Yeah, thank you so much to all the participants, and also a big thank you to Mr. Anil Razdan, former Secretary, Government of India, and Chairman EEF for moderating this session so beautifully. And of course, we got new insights into the topic of accelerating digital transformation in healthcare. And as our dignitaries pointed out, that healthcare sector is undergoing a critical transformation, and this transformation in healthcare is the key to enhancing and boosting access and driving efficiency in the healthcare sector. And of course, we talked in greater detail about the integrated approach that we must all have in the healthcare sector. So I thank all the speakers and also the chair for moderating the session. And we have had a beautiful session. And I would like to inform all our speakers that for them, there is a Zoom link that that is being shared with them. But for the rest of the participants, they need to connect through our 3D platform. And for the next subsequent sessions as well, for all the speakers in this session, if you want to join the rest of the sessions, then please join us through the 3D platform. And with that information, we'll take a short break. We'll take a lunch break here. We'll be back with another important session coming up ahead, in which we'll be discussing about artificial intelligence, big data, blockchain, deep learning, and robotic surgery. But time for a very, very short break here. We'll be back. Thank you all the participants and the speakers and the chair for this beautiful session. Thank you so much all. We'll be meeting in about 20 minutes from now. Thank you, sir.
Hi, everyone. We'll start the session in like next 2 minutes. Hi, Juby. How you doing?
I'm doing good. How are you?
Great, thank you. Just waiting for 1 or 2 more participants to start, and we can start then. Hope that's okay with you.
No worries.
Cool. Hi, Anne. How you doing?
Hello, I'm fine, thank you. Nice to meet you.
Great. Great. Nice to meet you as well. We have Mr. Sethi as well. And then I think we're just waiting for Ms. Uma to join, and then we can start. So probably a minute more, and then we can start.
Hi, everyone.
Hey, Dr.
Hello,
Ramir, how are
everyone.
you doing?
Good, good. Good to see you all.
Perfect.
And I don't know if you remember, we met in Africa a couple of years ago. In one of those African
Nice to
symposiums.
Where did we meet, Dr. Uma?
I think it was in Kenya. Did you come for that Africa Health Business Symposium?
Yes, correct.
Yeah, I moderated one of your sessions, dinner sessions.
Yeah, nice to see you again. I'm so sorry.
No, I remember you because you have a name which spells in a very unique manner. In Africa a couple of years ago. Yeah.
Thank you. Nice to see
you.
Where did we meet, Dr. Uma?
Kenya. I think it was in Kenya. Did you come for that Africa Health Business Symposium? Yes.
Yes, correct.
Yeah, I moderated one of your sessions, dinner sessions.
Yeah, nice to see you again. I'm so sorry.
No, I remember you because you have a name which spells in a very unique manner. In Africa a couple of years. Yeah.
Thank you.
Nice to see you.
Where did we meet, Dr. Uma?
Dr. Uma?
Yes.
Hi, Dr. Uma. This is Aishwarya. Ma'am, when can we start the session? Since you're going to be chairing the session. So we'll start the session as soon as you are ready to start.
Well, I'm ready to start.
All right. So since I've got the green signal, let me start with the plenary session. And the topic for this plenary session is going to be artificial intelligence, big data, biochain, deep learning, and robotic surgery. So we have had an excellent inaugural session, and the plenary session after that, we had an excellent discussion on artificial intelligence. A part of it was also covered in the plenary session before lunch. And some part of it is we are also going to discuss in this session that is also going to focus on blockchain and robotic surgery aspect as well. So let me at the outset welcome all of you. Let me introduce the key speakers for the session. We have Ms. Judy George Veze, RN. I'm sorry if I'm getting some names pronounced wrong, but I'm welcoming Ms. Juby. She's the CEO and Chief Innovation Officer, Globex Health USA. Very warm welcome to you, ma'am. And also I would like to welcome Dr. Tanzila Saba, Associate Chair, Information System Department, Research Professor, IEE Senior Member, Artificial Intelligence and Data Analytics Lab Leader, and also Associate Professor, College of Computer Information Science, PSU, Saudi Arabia. I'd also like to welcome Dr. Anne Arts, head the Novartis Foundation, Switzerland. My very warm welcome to also Dr. Tavpritish Sethi, founding head, Center of Excellence in Healthcare and faculty lead for entrepreneurship, and also assistant professor, computational biology, Indraprasth Institute of Information Technology, Delhi. A very warm welcome to all the speakers for this session. And Dr. Uma Nambiar, she's going to be the chairperson for this session. And she's also the chairperson of the Digital Health India Association. A very warm welcome to all the speakers and the chair. Now, let me hand over the virtual mic to Dr. Uma Nambiar. And I would request Dr. Nambiar to please start and chair this session.
To have put such a wonderful session together. We have had excellent sessions in the morning, and I am sure all of us who are part of this gathering here know that if we have to realize our dream of equitable, affordable, and accessible healthcare, then digital is the way forward. I also feel strongly that by adopting digital technologies in healthcare and to deliver good healthcare, we will be able to uphold the ethics and transparency in healthcare, which many times the patients are very wary of and they're not sure what we are doing. Some of the things that we are going to address might seem very, usual for the people who are working in this field of healthcare technology. But from the point of view of healthcare provider on ground, it might still look like a dream, which is far away. But the past experience of the 1 year with COVID, if that's an indication, we can understand that the ecosystem of digital health is getting stronger progressively. And it was, if I was to say that there is the good, bad, ugly of COVID, then the good of COVID was just one. And that was acceleration in the strengthening of the digital health ecosystem. And by making sure that people across the world, whether they were the patients or the healthcare providers, they realized how important it is to adopt digital health. But yes, there are challenges that are going to be. There are some regulations that still need to come forward. There are challenges of, getting a more immersive experience for the healthcare provider, as well as the technologists, the digital health worker, the health informatics champions to come together and work together. So these kind of sessions help to actually enhance that knowledge. And we have a wonderful panel. And I am going to introduce the speakers as they come. So the first speaker for the day for us is Juby, and who has had more than 2 decades of experience in the healthcare industry as a registered nurse and thereafter a certified case manager, an MBA in healthcare systems, and working in chronic disease management, healthcare quality, and an innovator in her own right. So can I welcome Juby to please come forward and take the stage.
Thank you, Dr. Uma, and thank you everybody for asking me to join and give me this opportunity to come and share some of the innovations that's going on in the United States. Is it okay for me to share my screen and to run the slides? Okay. Bear with me as I just switch over to the beginning. Okay. Are you able to see my screen?
Yes.
Yes, we can.
Yes,
Thank
yes.
Okay. All right. And just ping me if I go over the time, but thank you everybody. And we're going to be
You have
covering.
about 20 minutes to beat, so I forgot to tell you. So each speaker has 20 minutes.
Okay, great.
Yeah.
Perfect. So yes, I am the CEO and Chief Innovation Officer for Globex Health, which is based out in USA. We're going to cover some things about AI, big data, deep learning, 5G, blockchain. I'm going to do less on big data because there are a lot of others who are more experienced and going to be sharing. But I'm going to start with talking about a little bit on that policy and need for regulation changes and within healthcare, and some of the underlying reason why some of the changes are happening within the United States and also globally. Cost of healthcare, 5G and edge computing, obviously blockchain. As Dr. Uma said, I am originally from Kerala, India. I grew up there, but I immigrated over 30 years ago, my whole family. And I, even though I am started as a nurse, but I started coding since high school. So everything I did ended up in the technology layer with the business side. And fortunately, unfortunately, I was based out of an area where that's where the IBM's world headquarters is, and the university I went to is where a lot of resources from the high school I went to had a lot of technology. So I ended up getting involved with technology very early in life, and it's very natural to me. So as I got involved in healthcare, technology is also something that automatically comes into my landscape. I touched my first THR setting it up in 1996. Piloted BlackBerry for healthcare in 2000. I saw my first robotic surgery somewhere in 2003 or 4. Again, that is the Da Vinci system that's commonly used now. Natural language pilot somewhere in 2007 or 8. IBM Watson AI for healthcare as his first healthcare client with oncology program from Sloan Kettering. On and on it goes, but I enjoy this area. And in this iteration of my career path, which is focused on aging, elder care, polychronic condition management, and innovation with a touch of healthcare finance and into it. And one of the things that we as a group ended up having to do is look at hardware, software, and the clinical side with the payment. And that is where Globex Health is. It's a digital health and innovation company. And we do massive clinical, technology, algorithm, healthcare, compliance, reimbursement. Our focus is, and we are led by an infectious disease, immunology, pediatrician, trauma medicine leader. And with this pandemic, we are pulled into that area pretty heavily. Cost of healthcare in the United States is pretty high. $3.6 trillion of is the annual spend, about 18 to 19% of the GDP, which is about $10,000 to $11,000 per person per year. The area that I focus on is 1.5 trillion, which is about inpatient hospital stay, and also the massive entitlement program, which is called Medicare, which is the elderly, taking care of the elderly as they retire over 65. It's $800 billion a year. And US has a problem because baby boomers, what they call commonly term us, these are the World War II The children of those couples from that time are turning 65, about 10,000 per more every day and coming into the system. More people need to be managed still with that $800 billion budget. So there's massive efforts going on in trying to mitigate that situation. And also there are several other government programs in the United States. The one on the left is the American Indian Tribal Nations and Alaska Natives program. It's about 1.6 million people. And on the right lower is Medicaid, which is the state-based for poor and underinsured. On the left side is the Veterans Administration, which is also about 8 million people, which is for soldiers. You can you do more while spending less? Yes, that's possible. And that is the promise of AI, innovation, IoMT, and some of these new things that we are seeing. And that's why it is starting to get more adopted a little bit more faster. We're in the middle of fourth industrial revolution. That means what you see as your normal, what you do today, maybe in 5 to 10 years, that is not what is possible. That role or whatever it is, that process is different. Jobs will be gone and new jobs will be established. I say that because I saw that happen within that first year of IBM Watson AI being implemented in 2011-12 onward. So it's just been that process you will have to prepare for. FHIR is the standard for healthcare interoperability and exchanging healthcare information. There are some rules and changes that's happening in the United States. That means that data exchange will be happening better, faster, more friction-free. And this is that regulation that Dr. Uma was talking about. In 2019, CMS, in anticipation of all these massive, more people coming into the system, changed some rules that allowed for remote health monitoring to be reimbursed. So tracking somebody's blood pressure and maybe weight, or tracking some things if you have chronic conditions, became a reimbursable at home. It's managed at home. The physicians are getting paid to do that from their office. And that really opened this amazing opportunity. And telehealth was very strangled by regulation. FTC, which is it was just too many organizations trying to manage it. There was some waivers, and now it's really, really taking off. And in 2020 into 2021, during COVID, there's a lot of waivers that went into effect, and more are reimbursed. So if with US being a third-party payment system, which commercial insurance, the government entitlements that I showed you, it's always that third party who is going to be paying. And that means you need to make sure that there are ways that structure is in place, and which now that it's it is in place, this is taking off pretty fast. We're starting to see now early adaptation of hospital level care at home, which is CMS just started approving that. That's pretty big. Virtual care is now starting to emerge. Augmented reality, virtual reality based, you're starting to see more of usage of that. Drivers of remote patient health monitoring and wearables. Patient-generated data. Provider or physicians are more amenable to doing this because now there's an incentive, which is financial, and also trying to do the right thing by their patient. And it's all underpinning is pay for performance, these massive change into that reimbursement system. Some of the wearables, the left side is a newly approved, FDA approved, a federal Food and Drug Administration, reviews most of these devices. That's the watch that's approved for blood pressure. It's interesting. This watch is about $500. I look at it and I'm like, you can just buy one for less than that. That works similar, but this one has the Food and Drug Administration's approval. The next one is an attachment to any smartphone that allows you to check your blood sugar. The other one is ECG, and the last one is for meditation or brain waves. On the left is an Apple Watch, but I put a link to Apple's Health Kit. They have created it, so a lot of hospitals are starting to look at it. Organizations are building more things with that Apple Health Kit. They made it open source. Many institutions are also choosing to create their own health kit type. They don't want to end up relying on a particular platform. So their Mass General, which is part of Harvard University, is doing that. Stanford Health and Stanford is doing that. And a few others are starting to consider that. The next one is pain management. Quell is for acupressure point, I believe is what it's being used, but it does a great job for pain management. Diabetes management, this is the Dexcom G6 continuous glucose monitoring and some of the newly cardiac one that's available. What all this does is improve care outcome. So combination of remote health monitoring, telehealth, and some of those IoT and Internet of Medical things allows physicians and others to intervene when in the prior world time you couldn't do that. You have to have the patient come into an office or a clinic or hospital. Now you can provide care in the rural communities, farming communities, places that's hard to reach, patients who do not have the ability to commute, spend that money or take time off to get to a clinic or wherever that is. And so this is being adopted massively in the rural area of the United States, Appalachian. Tribal nations are starting to look at, to get access to it. There used to be, and years ago, I almost 15 years ago, the government tried to do tribal virtual clinics are just set up. There is nobody there, but if somebody have something, they can come in, press a button, or try to remote into another state or a different area where they can get support. It worked kind of, but was not enough. So this now you can do a lot more. On the lower right, you can see that veterinary medicine is starting to come through also. That's happened during COVID. And imagine if there are more of the IoT, IoMT devices that capture more, you can do more with that in that area. AI and ML algorithm, artificial intelligence and machine learning in software as a medical device, app as a prescription is starting to happen. And it is also reimbursable, so paid by the health insurance, not by the person. Algorithm as a clinical decision-making tool is already happening. FDA, again, Food and Drug Administration is starting to approve that. About 18 to 20 of them are approved as of now. This is AI for imaging and teleradiology. This is what has already happened. This is the early adopter. It's been going on for at least 6 years now. Radiology is massive ingestion of images have taken place. The AI had time to learn, and it's pretty accurate. Now, it's not just one AI now. There's multiple AIs doing different things for that one imaging service. Last I had an opportunity to look at what is happening at Lenox Hill with the head of cardiac imaging, and he had about 10 to 12 AI companies and AI working on this, and it was amazing what they're able to do with this. So what it is faster, cheaper, diagnosis and treatment, maybe a physician level, doctor's office level, or remote area level where actual diagnostics can be happening. This is an example of actual use case example of AI in healthcare. During COVID, this is an outpatient diagnosis of COVID, and they're put on hydrochloroquine and azithromycin. But they have done a baseline 12 lead EKG, and then with the smart watch, they are doing ECG monitoring, and it came out as pretty accurate. And to do this, they use deep convolutional neural network, unit architecture with 11 convolutional layers and 6 residual blocks. They used it with Keras, with the backend of TensorFlow and Cardiolog's platform. This was published in Journal of Cardiology. I have a link. Feel free to look it up if you want. AI and machine learning. what is being used in healthcare for hospital systems are using this. When you say hospital systems, they have to look at their bed count, admissions, discharge, transfer internally. So this is all managed with an AI in a centralized way. Supply chain, just-in-time ordering, and also my area of interest, revenue cycle, healthcare finance area is also using this now, cognitive AI, robotic process automation. Let's talk about blockchain. I ended up getting into blockchain because of the cybersecurity area, and one of the organizations I worked for had a 80 million health record or health people's record hack. And as part of the mitigation, somewhere in 2014, 2015, I got involved with the blockchain. Early blockchain work is always in healthcare finance, not healthcare finance, just straight up finance, especially international money settlement. Banking has adopted this massively. I think there's a play here for healthcare. It's a slow adaptation. It's not as fast. It's taking time, but it's starting to see now. Blockchain is technically, it's like a big database. It's linked to multiple other database, and it's got privacy, smart contract, consensus, and it saves time, it removes cost, reduces risk, increases trust. When you do blockchain in healthcare, there are three types of blockchain. There's a public, private, and a consortium or a hybrid. So consortium is ideal for healthcare area. This is a blockchain layered one that is happening in the United States through the government channels. And they don't like to use the word blockchain. So this is Trusted Exchange Framework and Common Agreement. And this is going in effect in the middle layer, which is health information exchanges between different states. Everybody needs to report in. So if we have 50 states, I want to say 50 exchanges, but I would say less. There's some that share, and that's where this early blockchain is going, and it will later on expand into other areas, but there's pretty good framework built now. This is an example of blockchain-like work that I am involved in, and this is in in the Medicare, the elderly. That $800 billion budget area. This is a massive effort to take care of some inefficiencies that's happening there and put patient first, patient in the center. You can see many areas like the nursing home to the hospital to the home care, they were all siloed out. It's not as interconnected. So, and then families are not as involved or care. So there's a massive effort going in effect to kind of mitigate that and put them all into that one circle, and everything is shared and everybody has access to what they are allowed to have access, and patient can be managed better in wherever they are, preferably in their home, so that remember that 50% of the spend is in the inpatient plus the hospital provider. So if they can manage better at home, the cost is less. Advanced connectivity, 5G. We're starting to see some 5G. 5G is 10 times faster than 4G. That means you can see more, you can have more imaging, more complex things can be done. The challenge on that is infrastructure. Not everyone is built for it, including the United States. So that's a challenge that we're facing, and we're trying to work around it. What you call as 5G is not real 5G, what you're seeing out there. Edge computing is something that goes in tandem with 5G. Right now, everybody uses cloud for your data, and information moves from cloud to whatever you're doing, especially in healthcare. But going forward, when you have 5G and it's massive amount of information, including all that Internet of Things, you need to have edge, which is hybrid, and that would allow and minimize the latency that can happen. Um, Another workaround for this latency and on infrastructure issue is low orbit satellites. Amazon has deployed massive amounts right now. Let's talk about robotic surgery. Remote surgeries are now starting to happen. This is now more well done now in mining area, operating equipments, but you can see on the right, remote robotic surgery using 5G, an example from Italy. And on the left side, you can see some published on a journal. Again, they use the Da Vinci robot. It's important to have that 5G so there is no latency. So whatever the surgeon is doing immediately happens in milliseconds, not in seconds. So it's a significant difference. This means that doctor in Italy could be performing a surgery in the for a patient in the United States and right on another patient somewhere in India, and then move on to a patient in Philippines. So you don't have to have physician in the surgeon can be geographic agnostic. Rural healthcare, this allows for all these innovations allow for better care, even in rural area where harder to provide that care. You can have virtual clinics, many little packages that allows for everything, components, everything that needs to have the diagnostic or intervention can be readily available and can be, decisions can be made remotely. This is an example from Canada. The VR, a virtual reality patient using that, it could be for rehab, it could be for occupational therapy and various reasons. US Veterans Administration has taken a lead in this area. This is a virtual medical center built with Unity, and something that I had some early access and some involvement and guidance. You can see the acupuncture. I was in the late part of the prior session. They do use integrative medicine. This is a neurosurgeon who designed something that would help prepare for surgery, and it's being piloted. Surgeon's name is Osama. He is part of one of the innovation programs that I helped run inside New York City. It's less mistake, better preparation. Neurosurgery is harder, so this allows for them to prepare and plan ahead. Data analytics and predictive modeling, risk scoring, risk stratification, but ethically, because you can put in different constraints. When you have massive amount of data and you can have insights, you can see things that you may not want to look at and make judgments on. There's some issues in the United States that has happened. I just want to mention. Otherwise, data is amazing. You can do great with it and bring a lot of data layers together. Just wanted to mention a couple of topics that's going to be coming down the pike is genomics, precision medicine, nanotechnology enabled healthcare solutions that could be biologics or devices. Another one that I just wanted to mention is personal to me is the post-COVID syndrome. There's a lot that's happening now in the United States with the lingering effects, and some efforts are going on the government side trying to mitigate, study this, but the knowledge gap and confusion that's happening does cause some delay in this. I personally have seen this type of issue from some of the 9/11 dust exposure, World Trade Center dust exposure, except for the no cancer part. But so this is very, I created just a LinkedIn group to kind of share information. After we presented this to some government agencies about a month ago, and there were so many questions, so we ended up just creating this. I think I stayed close to time. I don't know. Dr. Uma, let me know. Questions?
Yeah, what we can do is, we can take questions at the end, because that would consolidate the time that we have. Is that all right?
Sure.
Yeah. So I do not see our second speaker here. So which brings me to, because Tanzila doesn't seem to be here. In case she joins later, we will have a join afterwards. But in the meanwhile, then let me invite Anne to deliver her presentation. So Anne has had an interesting journey from being director of a tuberculosis center to leadership positions in the Red Cross. Now she heads Novartis Foundation and very closely involved with data. And besides diabetes, I think population health is their forte. And it would be a pleasure to listen to you.
Thank you so much, Dr. Uma, and it's a real pleasure to be with you today. Let me also share some slides maybe to walk you through what we are doing. In fact, the Novartis Foundation is really, as you said, Dr. Uma, working on how we can advance data and AI-driven approaches to improve population health at large in the world. So in fact, our work is focusing on low-income populations wherever they live, and until now, mainly in low and middle-income settings. But why do we do that? Because the challenge of global health nowadays is really unprecedented. As you all know, the COVID crisis is just a wake-up call that our health systems are not really prepared to address all the burdens we are facing, and specifically not in low and middle-income settings, where there's a real huge tide of a triple burden across the world now, with rising obesity and the rising numbers of chronic diseases, besides the acute diseases and infectious diseases that are still there as well. Rapid urbanization is huge, specifically in low and middle income settings, and it's compromising the existing infrastructure for health and care delivery. So not only these risks of constantly emerging new diseases, but all these other things coupled to a massive shortage of health workers, skilled health professionals in the world, makes us realize that we need to do things differently. It calls for innovating health and care around the world. And I was very inspired by your speech, Juby, of everything that is already feasible and going on in the US with the use of data and AI. It's really inspiring. But let me tell you that there's a lot of things going on with AI as well across low and middle income settings. So this is our mission at the foundation. We advance data and digital-led approaches towards population health to help systems in country transform themselves from being these reactive systems waiting to see people getting sick before they care for them, to become proactive, predictive, and even preventative so that they can keep their populations healthy. The building blocks of our work are, on the one hand, our urban cardiovascular population health approaches on the ground, where we have main urban health initiatives across Latin America, Africa, Asia, and now starting also in the US. Another building block of all of our work is the Global Data Collaborative on Cardiovascular Population Health that we have been setting up together with Microsoft and Accenture, and where we are now partnering with the World Heart Federation to make it one big global hub of cardiovascular data that we can use to help policymakers make better decisions on their allocations or on other topics in health. And lastly, we work on catalyzing new policies for AI integration in health. And that work we do through our work with the Broadband Commission for Sustainable Development and through our dialogues that we organize between cities. AI for Healthy Cities is an exchange platform where cities in high-income settings that have massively successful examples of how AI can transform health and well-being in their population with cities who don't have so much experience yet. For example, the dialogue that is now happening is between Montreal, which is probably the gold standard of how you can use AI in urban planning for improving the health of the population, with São Paulo in Brazil, where we have been running our cardiovascular population health approach with the state government and the city authorities since quite some years. So these building blocks then coupled to our multi-sector partnerships we have set up in the different areas in the world, help us to achieve our goal. And let me give you just one word about this Global Data Collaborative for Cardiovascular Population Health, because I feel it may become a real important tool for policymakers in the world, regardless where they are, really do this thing to re-engineer their health and care systems into these proactive, predictive and preventative systems. It is feasible, but you need to do it with the right data and use real-time data in an ethical way, as you so rightly underlined, Juby. I very much appreciate that point. You have to do that to really then build those policy guidances or influences that can have the biggest impact on the largest number of people. So this is not a data collaborative that will look at cardiovascular medicine or medical care, because there's many data collaboratives like that around the world. This one specifically will help policymakers. How can we allocate our scarce resources best, or how can we target those populations who need most our interventions? Because we see there's a lot of waste in the system. I don't have to tell you, I'm sure, of how resources are managed in a general way without having those insights from the real-time data. So that's the goal of the data collaborative. Now, our work with the Broadband Commission for Sustainable Development, I'm not sure if you know that organization, but the Broadband Commission exists since a little more than 10 years. It is an organization co-chaired by ITU and UNESCO, and brings together all the big tech players, telecommunications players, with the CEOs of Microsoft, Google, Amazon, everyone in that Broadband Commission, coupled with the public sector leaders in the field of telecommunication and digital innovation and AI innovation now, with some other private sector players. So it's a huge organization, and in there, we are the only health voice currently. With luckily this year, we have the World Health Organization also joining the Broadband Commission. So we have been chairing the working group on health specifically there since now 5 years. The first one looked at how national governments can really tap into the potential of digital to transform their health systems in more efficient health systems. And that report came out in 2015 or 16, I believe, a long time ago, but it really stressed that what you need first and foremost in a country to do so is political vision, that digital is important for your health system, and then commit to sustained financing for it. You need intergovernmental and intersectoral collaboration between IT, health, finance, all of these different sectors, otherwise it won't get off the ground in national digital health strategies. And you need a framework for national regulatory standards, legal standards, and interoperability standards to be able to tap into the potential of digital. The second working group specifically looked at how digital transformed the way we can address the needs of chronic patients with non-communicable diseases, as they are very much left behind in many low and middle income settings where health systems are only geared towards acute care. And the last working group now that came out with our recommendations last year in 2020 was focusing on how AI is already making a tremendous impact in the world on health and care, but also on how governments can really advance in their maturity to deploy AI solutions in their health systems. So we looked at a landscape analysis of about 300 use cases of AI across the world, and distilled the insights from that landscape analysis to then build that roadmap towards AI maturity in health. All of the experts and members of the Broadband Commission who participated in this working group are here on the screen. So you see that all the big UN players, but also a lot of big private sector players are in the game here. And we have worked together to build this very solid recommendation for maturity, for advancing in your maturity to deploy AI in the health and care systems. So we distilled the landscape analysis, and we found 5 main use cases You've probably heard about that already, but the main use cases were not only focusing on clinical care, as you can see, clinical care is very important, the use of AI there, specifically what is most advanced, as you also highlighted, Ruby, in image-based diagnostics that is much faster and more accurate thanks to artificial intelligence now, but also in many other settings, like, for example, Apollo Hospitals in India, one of your major healthcare providers in India, has developed with its millions of data on cardiovascular disease, for example, has developed a new cardiovascular risk score that first started with 300 indicators, distilled it down to 40 indicators, and now is using 7 very simple indicators that don't even require an investigation with a blood analysis, but 7 simple indicators can predict if a person will do a heart infarction 5 to 7 years later. And that risk score far outperforms the good old Framingham risk score that we know from all the long-term follow-up studies in Framingham from the 50s and the 60s. So Apollo's risk score is now going to be, is already validated in a data set with the Netherlands government, is now going to be validated in our data in Brazil, for example, because it is simple and scalable in a massively important way. But all the other use cases are as important. We've seen how AI has helped. In the beginning, AI was the factor that made AI discover. This unusual cluster of pneumonias in Wuhan was detected by Blue Dot, an AI-driven screening. So population health and the prediction of epidemics was already being done a lot with AI, like with the examples of Magic Box from UNICEF, for example. Preclinical research and development of new drugs has been massively advanced and simplified with the use of AI. We've seen that drug discovery is advanced much by using it. What kind of drug we already have on the market, can we repurpose them for certain clinical pathways? Because AI has discovered new pathways in different diseases. Benevolent AI here is an example of how in the beginning of the COVID epidemic, they were able to scan all the drugs on the market already and find which ones would potentially have an impact on COVID. And they discovered that one of the rheumatoid arthritis drugs was massively active on COVID as well. Other examples of patient-facing solutions, one very important one is the Chinese Ping An Good Doctor. Ping An is a great health insurance, or a large health insurance company in China, which has developed 24/7 services online with internet hospitals, internet health centers, internet pharmacies, delivering with the goal to deliver access to a doctor to every family in China, access to a health plan to every family in China, and access to a health record. So Ping An Good Doctor already is doing more than 1 billion consultations per day. So if you can imagine, that kind of a setup has been revolutionized in the way we deliver health and care now, if you look at that example in China. And lastly, AI is massively influential to optimize how our health and care systems function, in fact. You can not only automate supply chains or your human resource capacity planning, you can also automate the detection of a cardiac arrest by someone who is calling a call center. So Corti is an example of how the AI model uses voice recognition to recognize that the person who's calling has a cardiac arrest. And it's much faster than the responder to the call can recognize it. So, and we know that every second counts in the recognition of a cardiac arrest. So these examples of innovations were really important in the world and are having a massive impact already. So I told you about Apollo risk score, the Ping An Good Doctor example. And based on all of these insights, we then distilled that into a roadmap for a country where they should invest in if they want to become more ready to deploy AI throughout their health systems. And interesting enough, it's not only about investing in data and technology. It is obviously one of the main pillars, but it's not the first and foremost important one. The most important one is that governments invest in their people capacities and in their workforce capacity, because we see that increasing digital skills throughout the workforce and in the educational system, integrating it from the start will really help us to transform health systems. If that doesn't happen, there's going to be a massive gap in skills for deploying such solutions in health systems. So that's the main important factor governments have to invest in now, not to be left behind, because low and middle income settings have most to gain from the innovations we have in our hands now, but they can be losing a lot if they don't use that and they don't invest in the right domain areas at the moment. The second one is obviously the data we need and the technology. You need the infrastructure, you need quality data. I'm not going to dwell on this because all of the other speakers before us have massively underlined that importance as well. You need really good, strong governance and regulatory systems to keep the people safe and to manage data privacy, obviously. And then a fourth investment area that is crucial for being successful in deploying AI in your health system is that the design of AI solutions has to be needs-driven. It doesn't work with coming with a well-intended solution to a government and offering it. It has to be coming from the needs assessment first. So any design, any AI solution has to be designed on a needs basis and has to be human-centered. So the innovators have to take into account who will use the innovation when they design it. Otherwise, it will fail. We've seen it massively in many examples across the world where it fails because there was no thought up front by the innovator of what kind of processes you need to think about when you will have the solution to integrate it in the system so that it helps and augments the capacities of the human resources working in those systems instead of being an extra burden for them. We've seen too many examples of where digital technology has become more of a burden to the professional who's losing time on looking at his screen in the computer to introduce all the data they have to introduce instead of having time with the patients. AI can definitely give time back to health professionals with their patients and help them focus on what they are best at, taking care of people instead of having taken care of the software and everything. So that's crucially important to invest in for any health system that wants to start deploying these innovations. Putting the right partners and stakeholders around the table, obviously also in alignment. The government has to take the coordination role, because if a country is facing massive numbers of innovations in its health system, it cannot really coordinate or overview it anymore, and it will never be completely responding to the priority health needs of the government if of the country or the state or wherever you are looking at the population, because you need to work in this needs-driven way. If the partners that are bringing innovations have not been talking to each other, there's going to be a fragmented landscape, such as we've seen in many, many countries with digital technology in health. And that crucially is needed to be avoided. So the decision makers, whether that's the city government or whether that's the payer, which can be a private sector player, that's okay. It has to be those decision makers that are in the driver's seat to design or to allocate AI innovations to the needs they have. And then lastly, the governments have to be open for innovative business models to be able to make sure that we have incentives for innovators to work on the needs that governments or payers of system managers are expressing. There need to be this incentive for innovation. So that's something that has to be invested in as well. So this roadmap of 6 main pillars is a report that is available online. I can send you the link and you can look at it yourself with all the nice descriptions of all the case studies, but we are now translating that roadmap towards AI maturity in health into a self-assessment tool for any system manager, any decision maker on the ground to assess its own maturity. Because one country can be well advanced in the people and workforce area and have enough digitally and AI-driven skills in its population and workforce, but may not be ready with the necessary regulatory systems or may not have the right partners around the table. So you need to assess each single area or domain of this roadmap to be able to understand where you need to invest in a priority. So that self-assessment tool will be rolled out now in this coming months with several countries. We have been validating it with several countries already, and we are improving and optimizing it so that it can be really a self-assessment tool done by anyone who wants to assess its readiness to deploy AI solutions in health. So stay tuned for that tool. But let me end by saying that AI in health and care systems is really saving lives already. It strengthens health systems. It's not replacing health professionals per se. It's giving health professionals more tools in their hand to provide better quality of care, better long-term care, and deliver better health outcomes for their patients. And that's what every health professional wants. I know myself, because that's what you want as a health professional. I've gone a long way in my career, as you said, Uma. I started as an emergency physician, which I am trained for, in conflict areas around the world. And I was dropped in guerrilla areas in countries where there was conflicts going on since many years by plane, dropped by plane with my bicycle. And I was going on my bicycle from village to village where village health workers had been keeping patients who needed medical care for my attention. Obviously, I came too late in many cases. You can imagine me and my bike crossing the river and in the middle of nowhere. Nowadays, you can solve that by a simple phone call. So I'm the most passionate advocate for telehealth, if you may, and virtual care. If you have a simple phone call, is something we did 10 years ago in Ghana, I already demonstrate. You can really improve the quality of care from a village health worker. You can guide them through their patient care. And now AI with the robots you were talking about, Dubi, I think this is gonna really revolutionize a lot for specifically the remote workers, but also for urban population health, because the needs are even higher there as people really have no access to the necessary care in these rapidly growing cities where there's absolutely a lack of infrastructure. AI in health has to become a real global and a national priority and become an integral part of every health system, not just a siloed approach towards improving health, but an integral part of the health system. It's just as essential as a hospital bed is, if you ask me. So let's work towards that. And the time to go for it is now, and we have no time to lose, really. Thank you so much. And I look forward to the rest of the discussion.
Thank you so much, Anne. Your passion is so obvious, and it comes through just like as it is in Juby's talk. And I'm so happy that both of you have spoken to us and given such wonderful talks. And simply you have also allayed the fears of many healthcare professionals who think that the virtual care is here to replace them, whereas it is not. And virtual care is going to only add to what we already have and going to make the world a better place and help us reach more patients. So since Dr. Sabah is not here, I am inviting Dr. Khalid, who's going to be speaking in her place. So Dr. Khalid, I'm inviting you here, and can you start by just giving a short introduction of yourself? Dr. Khalid.
Yeah, hi everyone. How are you all?
Can you put your video on?
Yeah, please wait a second. There's some problem here.
It's okay. I think it will come on. In between you did. So you can start talking.
Okay.
Yep, we can see.
Yeah, Yeah, Dr. Sabha is actually has some urgent meeting, so she won't be able to present the article. So I'm the co-author in that paper, so I will present that work. So can I start?
Yeah, please go ahead.
My screen is visible?
Yes, it is.
Yes, Dr. Pandey.
Okay, okay. Okay, recently we are working in the data science areas, artificial intelligence, natural language processing, machine learning, and Internet of Medical Things. Our some ongoing projects are brain tumor based, breast cancer, text mining, other medical and security based applications to facilitate the patients and to facilitate the medical servers about data retrieving and data accessibility with secure management. So the main theme of the artificial intelligence is to facilitate the different research areas like data science, like pattern recognition, like image processing, descriptive analysis in terms of clustering, segmentations, visualizations, predictive analysis in terms of classifications, regressions, case-based reasonings, AI algorithms. So these are the main themes of the research areas that are used in artificial intelligence and data analytics research-oriented labs. Actually, the secure energy efficient framework using Internet of Medical Things for e-health. The e-health is mainly depends on the Internet of Things, and the Internet of Medical Things is the sub umbrella of, yeah, you can say that is a sub part of the Internet of Things. Actually, these Internet of Things are has least cost equipments, and they can be collaborated with autonomous sensors to gather the informations around the environment and then send that collected information towards the cloud server or towards the processing servers for facilitate the end users. The Internet of Medical Things can detect, gathers blood pressure informations like oxygen level informations, like heartbeat, like human temperature, and these informations can be gathered and can be processed by medical servers or by medical experts on emergency basis. Using it, the healthcare-related data of patients is transmitted towards the remote users and medical centers for post-analysis. And all these medical informations is travel over the internet connections, like over the 5G, 4G, or even the 6G towards the medical centers for their post-analysis. Different solutions have been proposed in a W band, which can be known as wireless body array networks, and in this area, low power biosensors nodes are used, and the main problem is their battery powers and communication cost, because they have very limited constraints in terms of memory, in terms of transmission power, or in terms of battery power. So the energy consumption is an important issue to balance between the biosensors and deliver the healthcare information on the cloud server or on the medical systems in a accurate time. Moreover, the sensitive data of the patients, everybody knows that as the information is traveling over the internet, which is unsecure, because a lot of machines are using your data in wrong way or in unauthorized way. So security threats are another issues to prevent the your sensitive data from malicious actions. So So in this research, we proposed a framework that has two main components. The first component was to offer the energy efficient communication between Internet of Medical Things, and the other is a secure communication, that the healthcare data is securely transmitted towards the medical experts' devices. So in this case, we present the different test, and in terms of privacy integrity, we detect that our framework is improved in terms of throughput, in terms of information loss rate, in terms of latency, in terms of energy consumptions, and in terms of link breaches. This is the general framework that you can say that we put biosensors inside the patient body, or we can implant these biosensors inside the human body to detect the oxygen level, to detect the glucose level, to detect the temperature, to detect the blood pressure, to detect the to detect the heartbeat. And in that second tier, actually this framework has 3 tiers. So in first tier, the biosensors are implanted on the human body, and in the second tier, this information is travel over the 5G or the 4G or the 6G with the help of different gateway devices, with the help of different access points towards the base station. And in the third tier, the medical experts, the data servers can communicate with each other over the internet. So these are the 3 main tiers. And in the network structure, first of all IoT devices are arranged in some in some graphical interconnection, where we have some nodes, and these nodes are connected with the help of some edges, and each edge has some cost value. So in this work, we compute the cost function with the help of some weighted computation, and each weighted computation has some unique contribution. So later in this graph, we identify the neighboring policy, that how one node can forward its data towards the base station, towards a sync node with the help of some mutual collaboration. So in this, we use intelligent routing scheme, like as I told you that we compute cost function. So with the help of cost function, we extract subgraph using artificial intelligence technique, and then all these subgraph are arranging in a ascending order. And in the last block, we divide the patient data, or we divide the healthcare data into different blocks, and we achieve data privacy or data integrity with the help of blockchain. So in blockchain, all these patient data are divided into different blocks, and each block has some hashing values, and all these hashing values are interconnected in the form of chain. Furthermore, we use some digital signature algorithm to provide the authenticity of the blocks, or to provide the authenticity of the to provide the authenticity of the devices. So in this way, we achieve secure data transmissions as well. We conduct some experiments in some simulations, and with the help of network throughput, we achieve that our framework is better than some other solutions, and we perform these experiments with respect of different times interval. You can see that 50, 100, 150, 200 with a passive of 250 seconds, and with the help of simulations, we achieve that our network throughput is better than some other healthcare solutions. Okay, we also detect the packet loss ratio, and after the experiments, we evaluate that our solutions gives improved packet loss ratio than other solutions. Similarly, we detect network latency, end-to-end delay in terms of patients' data, that in how much time it receives at the cloud server or it received at the medical experts' devices. So after the experiments, these are some results that we obtained. So, and in the last, we compute the link breaches or energy consumptions. So our proposed frameworks were better in terms of energy consumption, link breaches, latency, network throughput, and packet loss ratio. So the main theme of this work is to propose energy efficient framework, including data security. So the patient's data, the healthcare data using IoMT can collect the patient data, and it is securely transmitted over the internet towards the cloud servers or towards the cloud systems, and where medical experts, medical doctors, hospitals, staff members can access the data from the cloud, and they can facilitate the patients remotely. So thank you so much. If you have any questions, so anybody can ask.
Thank you, Dr. Khalid. The questions will be at the end. So we have one more speaker, and I am inviting Dr. Ritesh Sethi, who has been, are you here, Dr. Sethi?
Yes, I'm here, ma'am. Yes.
Okay, thank you. So, so Dr. Sethi, you have been a sort of a trendsetter. You are what I would call a very futuristic-minded doctor, because after your basic medical degree, you've gone and done your PhD in genomics and integrative biology, something not many would have done before you did, at least from, you know, these parts of the world. So in that sense, you're already a trendsetter, and it's not surprising that you are involved in clinical research, infectious diseases, and policy making, and you know, you have numerous articles to your credit. So it would be interesting to see what you have to say in today's session. So it's my pleasure to invite you.
Thank you, Dr. Navir. My pleasure to be here. I'll just start sharing my screen and take it from there. So I believe my screen is visible.
Yes, it is.
Perfect. Thank you so much. So thank you, the organizers, for having me here, and I'm delighted to be here. Amazing talks before this. So I'm also going to be speaking about AI in medicine and public health from the standpoint of our own experience in both of these fields. So my personal context is I did my medical graduation from Government Medical College, Amritsar, passed out in 2005, did a PhD in computation biology. For the last 15 years or so, I've been working in the space of data and machine learning models for healthcare, specifically ICU and public health settings. During this time, I have been associated with the All India Institute of Medical Sciences as a fellow of the Wellcome Trust, DBT India Alliance in the Department of Pediatrics. I've also been a visiting faculty member at Stanford University School of Medicine in the Department of Biomedical Informatics Research, now called the Center for Department of Biomedical Data Sciences. And more recently, I am leading an effort in the Center of Excellence in Healthcare at IIIT Delhi, where I'm a faculty member in the Department of Computation Biology. In this center, we are moving towards bringing technologies, emerging technologies such as AI and IoT to the bedside and for public health use. So very happy. If somebody has questions, please feel free to connect with me on my email. So the key takeaways from my talk, so this is something that I would like you all to go away with if you don't remember a lot of other stuff, because I think there will be some things, there'll be a lot that will be coming in the next slides, that AI in healthcare comes in many flavors. There's no one AI approach to medicine or in public or for public health. So AI back then, when it started, let's say in 70s and 80s, was it meant expert systems such as the Mycin algorithm, which actually kicked off AI in healthcare, which was an expert system coding how doctors think about infections and how to treat these. But AI now typically means machine learning. and artificial intelligence based on approaches such as deep learning, which start from data and not from the expert reasoning. And towards the end of the talk, I'll actually come to where how AI in healthcare is coming around a full circle, where doctors are now coming back into these systems to provide more context. So, but currently what we understand of AI and machine learning is working with heterogeneous data sets, which may include structured data, which are data which can be neatly organized in the form of tables. It can also work with unstructured data. A few examples from the previous talks talked about text data. So these are typically unstructured data, which we do not typically think about as data. For example, doctors' notes or nursing notes, the text that they write. So, but these cannot be neatly organized in the forms of rows and columns, but yet are amenable to artificial intelligence algorithms. Finally, in situations where we do not have data at all, we might need to simulate data. So I will keep this context at the back end and move forward in presenting our own work in structured, unstructured, simulated, and finally contextual AI, which I believe is the pinnacle of AI in healthcare, where all these approaches need to be given a context with the clinician coming in as well. So let's start with AI on structured data. I'll talk about this from the standpoint of our project in the Department of Pediatrics at All India Institute of Medical Sciences, AIIMS, New Delhi, where we have a project called the Safe ICU project. Safe ICU stands for Sepsis Advanced Forecasting Engine. This project started way back in 2015 as a project supported by the Wellcome Trust TB India Alliance. And the hypothesis is that ICUs are places where we generate amongst the highest density of data. It's about a gigabyte of data generated in our ICU, which is an 8-bedded ICU, routinely generated and routinely lost. And this is true for ICUs all across the world. This is not just true for developing settings, but most of the ICUs across the globe do not store high density data. By high density, I mean as soon as a patient gets plugged onto monitoring machines in the ICU, they start spitting out data on heart rate, pulse rate, oxygen saturation, respiratory rate, and so on at the frequency of even as 512 hertz. And these are big data, which are routinely lost. So far, we have warehoused more than 1.5 million patient hours of continuously monitored data in our pediatric ICU settings at AIIMS, New Delhi, which is now allowing us to build machine learning models. So we started really in a modest fashion. We started out by building our own software and hardware systems that connect with these machines in a very lean manner. And by making use of our own software, we were able to then also build in quality indicators into data warehousing systems. And that's, I would say, the first message that I would like to give, that good quality models depend upon good quality data. So it's prudent to have data quality as an essential factor while we build these big data systems, and going forward as we scale up these systems to be brought into deployment and for practice. So when we had these systems in place, we were starting these out. We did not have all these 1.5 million patient hours. So we decided to start again lean with our approaches towards building insights. So we did not right away start building prediction models because clinicians would not trust, and as a clinician, I would not trust models that are built on small data sets or evolving data sets, or even black box models, for example, deep learning. So we started by building trust with the clinicians by displaying dashboards on some of the things that they care about. For example, what is the antibiotic usage in my ICU? How is my patient faring in terms of their oxygen saturations on a minute-to-minute basis? Remember, no nurse is recording data in a minute-to-minute basis. So on the right-hand side here, you're seeing antibiotic usage, data quality, the quality of oxygen monitoring or saturation in babies in the right oxygen saturation range. It's very important because if babies are beyond 95% of oxygen saturation, they may actually end up being blind because of retinopathy of prematurity. If it is low, if it is less than 88, obviously they go into hypoxia and organ failure. So it's important to create value for clinicians at every step in our big data and AI systems. And once we had done that, now we started asking the real prediction questions, such as prediction of sepsis, prediction of shock, critical outcomes, and so on and so forth. So when we say prediction, we are not meaning prediction as in computer science usage of terms, because many times computer scientists talk about prediction of tuberculosis in an X-ray, or prediction of breast cancer in a mammogram. Now that is not prediction, that is detection, that is phenotyping, that is diagnosis. Here we are talking about prediction into the future, where can we look at this data before the black line to predict what could happen after the red line. So that becomes the data, the time between the black line and the red line is the window of opportunity in the ICUs. And for conditions such as sepsis and shock, this window of opportunity could range from anywhere between 30 minutes to 6 hours or 12 hours or 24 hours, because sometimes you can really take very simple measures, such as administration of fluids or antibiotics, to really reverse some of these outcomes. So this is an example where we integrated these, as I said, the 1.5 million hour patient data sets, along with novel modalities such as thermal imaging. And why thermal imaging? So again, we try to inject domain knowledge into our systems and our data as much as possible. And so it so happened that one of my friends actually just gave us a thermal imaging camera that can be attached to a smartphone, and asked what can be done with this in an ICU settings. And the first thing that came to my mind was that in first year medical school, we are taught that in shock, which is a condition when there is a mismatch between oxygen supply and demand in various tissues of the body. So the body really reacts by redistributing blood from the less important organs, such as skin, to the more important organs, such as the heart and the brain and the lungs and the core of our body. So could we really detect these temperature gradients or redistribution that may happen as shock emerges? So we first tested out this hypothesis in a lean manner, in a manual fashion, by doing some user studies, which we published. And then actually we automated all of this. And here is the automated model where we are feeding in these images into a computer vision system, which actually segments out the body parts, for example, between the center and the periphery. We show that the segmentation accuracy is more than 90%. Then we feed these features into our 0 hour, 3 hour, 6 hour, and 12 hour prediction models for shock. And we were able to show more than 75% accuracy, even at 12 hours ahead of time, for predicting shock. And not just accuracies, also precision and recalls, which means that these can be actually used in the clinical settings. Now, these thermal images are non-invasive. These are non-contact. These can actually be done in telediagnostic setting, because you can imagine a peripheral healthcare worker in a rural setting clicking an image of a child, and the model is running over a server. And that's what we are currently testing these out. Some of these efforts actually got derailed because of COVID, but that's what we were testing out in a peripheral health setting in one of the outreach of AIMS for testing these models in the hands of ASHA workers. The other thing is that it's okay to build models that can perform in one ICU, but can these models then also scale up across many different ICUs? And that is one of the holy grails of all the AI models, which is called generalizability. So we are testing, we've actually tested, and this manuscript is in communication. You can actually find the preprint already online. We are testing our models generalization across multiple geographic settings and multiple age groups by taking models that are built on one site and then scaling up across multiple other sites. Here we are looking at more than 200 different ICUs from the US and settings, because that's where most of the ICU data sets reside. And then we are testing how do deep learning models actually generalize better than standard hand engineered featured models. So we show that there's more than 10% generalizability when we take a model and deploy it at another setting where we lose generalizability if we were looking at hand engineered models. So in the interest of time, I'll not go into that, but these are models which work with structured data. Let's come to AI with unstructured data. As I said, most of the healthcare data actually reside in the form of notes, text. And this is a paper, not from our group, but a paper a letter in Nature that came out in 2019, which actually recapitulated the properties of materials by just training models to read literature and then predict which new materials may be discovered. Remember, without referring to the periodic table. So reconstructing the material science properties just by training models to read text. And if you look back, it's not so surprising because Google predicts what we're gonna type next, or in the Gmail or in the Google chat. So very similar models are used in these kind of works, which are called word embedding models. So in our work, we thought that a lot of textual data exists out there as guidelines. Not even doctors read them, leave alone general public. So can we really make use of the guidelines, the news stories, the text that exists out there, and train models to provide the right information to the right people in the right format at the right time? Which means that can we really train models over guidelines and news stories, convert it into summarized, bite-sized audios, and deliver it to people to raise their awareness about some of the most important health-saving measures, such as WASH, which is water, sanitation, hygiene. So this project really became, we were doing this before COVID, but became relevant when COVID struck. So our WASH Karo app really was presented at the WHO infodemic consult as a method for providing the right information by using machine learning. So this is the WASH Karo engine. Again, the preprint is online, and the paper is in the final revision. We hope it will be out soon. But what we do is we use AI to summarize text, compare it against WHO documents to check for validity. We keep a human in the loop to vet these articles, and then basically use translation and text-to-speech APIs to generate audios that can be then provided to users of the app. So we showed that over time, our AI systems actually learned and provided more relevant articles for COVID in the period it was being used. Unfortunately, in August, Google said that no apps can provide COVID information. So we repositioned our app for tuberculosis. That's what we are currently doing. We are not providing any COVID information, but this was our analysis for COVID. And we also show that more females engaged with our app in Hindi than in English. Again, saying that we have to segment out the population where we are reaching out to. We have to really consider the context in which we are providing these public health interventions using AI. We also used similar AI-based approaches to mine emerging evidence by making these models read text that was emerging in literature. And we showed ahead of time that from March to August, thrombosis was a main component that emerged in evidence in literature by using our word embedding models. And this is important now because we are now even talking about vaccines and their side effects and blood clots and all of that. Our models were able to capture these small streams of evidence coming together and merging together as one thick streamline And not only this, we can predict what's coming up next. This is a dashboard that's available in the name of Evidence Flow. Finally, in the next 3 minutes or so, I promise I'll not take more than 3 to 5 minutes. I know we are over time. I'll talk about data where I'll talk about AI models where we don't have data, so which means simulations. And we're talking about robotics. These models have been used to train robotics or to train models that actually can play Mario games. But we asked, what can we do with this in the healthcare space? So this is not new. Google has been training reinforcement learning models, which are used for robotics or for training Mario players, essentially to fold proteins, which is important for learning how can we discover new drugs. And this was a recent news story from the AlphaFold 2, which is the Google's DeepMind's algorithm, that we have essentially made a huge advance in folding proteins. But we asked, can we use these algorithms for training models for better allocation of vaccines? Because vaccines are scarce resource. We have a reward that we want to mitigate the pandemic in the shortest time possible. How do we develop models that take all these contexts into account and then tell or guide that this much vaccine should be delivered to this state? So we did the way back in August 2020 when it was announced that the vaccines are in the phase 2 trial. And we are currently running this dashboard called Vaccine. Our paper is online, currently in review, and we show how much potential cases can be prevented, how many potential cases can be prevented by using reinforcement learning approach over the naive strategies or the current strategies. This is a screenshot from a dashboard where we show that you can compare against different optimization algorithms, as well as, for example, the current strategies. And we show that in just a month's time, depending upon how many new cases we are seeing, we may prevent more than 100,000 new cases just in 1 month by just reallocating strategies of vaccine distribution. Finally, context becomes really important. So not all AI models can be deployed in all contexts. Workflow integration is important, as has been said. So in this paper, we published way back in 2015, we use contextual AI models. So here you can see a network, which actually combined the context of different districts of India and then gave recommendations. We don't have the time to go into it, but I can just give you the high level message that we were able to pull out the context from epidemiology and available data to say that if we were able to increase the penetration of clean cooking fuel into the districts of India, we would reduce the incidence of obstructive airway disease almost by half. This makes sense in India because a lot of obstructive airway disease happens because of unclean cooking fuel, such as wood and coal burning. So again, we don't have time to summarize. AI has a broad range of application and methods. I hope I'm able to convey that it takes many flavors. With structured data, which can help bring up underlying patterns. Unstructured data can help synthesize new knowledge, which exists in text. Reinforcement learning models can help simulate scenarios, for example, the vaccine scenarios or protein folding. Finally, all these models need to come into a context to help make decisions on the basis of these models. So I'll stop there. This is our team and our funders. I'd like to acknowledge them all, and I'm happy to take questions. Thank you so much.
Thank you so much, Dr. Sethi, for such an excellent presentation. We are running short of time. So can I invite, let's say, can I ask Dr. Garg Shubham, can I invite the audience for like one question? If
yes, absolutely. I'm taking a look. If there are any questions from the audience.
Yeah, we will just get into the tea time. So if there are any questions, it would be good.
So no questions from the audience at this point?
Yeah. So in that case, I think we can summarize the session, because I, for one, learned a lot, because to me, you know, what we've been hearing in bits and pieces about AI and here and there. I think this session has really put everything in a nutshell, very, very concise. And the way I see some of the key takeaways that we have from this session is that virtual care, I think it is time to make sure that virtual care is also reimbursed and facilitated, and we have the appropriate government regulations in place. In some countries, the government regulations are already there. Some of them are in their infancy, I should say. But I think we need to now take cognizance of the fact that it is here to stay, and that we need to make sure that it gets popularized and that it gets paid for. We also heard the speaker say that the better use of technology can now help us do more proactive, predictive, and preventive medicine. And I would add more personalized care as well. And like Mrs. Susan said in the morning, that healthcare is a global good. I think this session has, really proved that healthcare and wellness both are truly global goods. And the more we see the use of AI and the digital technologies, and I'm sure there are going to be more emerging technologies that will, enter the field, this will truly shrink the world, and we will all be talking the same language. And that's necessary because healthcare is for the entire humanity. It is completely agnostic of geographies. And that is where we need to be headed, and that's where we need to look. And it all sort of, beautifully was summed up by Dr. Sethi when he said that, and when he spoke to us about contextual AI, which is really where everything needs to lead to. And it's very good to see that we already are making headways in that direction. And if nobody else has a question, I have a question for Dr. Khalid for these implantable sensors about how, is that going to progress towards wearable sensors rather than implantable sensors?
Yeah, this is implantable sensors, wearable sensors.
Yeah, so I mean, if I could wear it on a shirt, that would be more better than implanting it under my skin. That's
Yeah. Actually, these biosensors can be used as a wearable sensors or as a implanted sensors.
Okay. All right.
So it is up to the convenience of the patients or human body.
All right. So thank you very much, and thank you, Dr. Garg, for organizing such an array of wonderful speakers who have summed it all up beautifully. And I really wish that, we could have more such sessions, and it's a pleasure to learn from all of you. It's been a wonderful session. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Thank you, Dr.
Thank you.
For conducting very ably this session of luminaries throughout the world. And hopefully we will have this conference next year. And again on the same dates, April 15, 16, hopefully in the real form, this pandemic will go and we will have. And during this period also, we will have some webinar or so. So we will have continuous meeting. Thank you very much for each distinguished panelist for sharing your wisdom to this subject. Thank you very much.
Thank you. Stay safe.
Yeah.
Thank you so much, Dr. Uma. Thank you so much to all the speakers, Ms. Jubi, Dr. Khalid, who was speaking on behalf of Dr. Saba, Dr. Ann Etz, and Dr. Tavpritesh Sethi. Thank you so much, all the speakers, and Dr. Uma for chairing the session so beautifully. And we got beautiful and extreme important insights into the field of artificial intelligence. And with that, we'll take a very short break here. Up next, we have another interesting plenary session coming up ahead, and that will be at 1600 hours, where we'll be talking about the new health informatics, healthcare transformation as well. But that is coming up in about 15 minutes from now. So I'll see you on the other side of the break. Thank you so much for having joined us. Thank you.
Dr. Gyani, congratulations on your award today.
Good afternoon, Dr. Gyani.
Yes, please. Good afternoon.
Sir, you'd be moderating this session. You'd be the chair
Okay.
for this session, sir. And whenever you will give me the green light, we can start the session. We have Dr. Meena with us. Very good afternoon, Dr. Meena.
Good afternoon. Good afternoon to all of you.
And we also have with us Dr. Divya. We have Dr. Rafiqul Islam Maroof joining us. We also have Mr. Abdullah Salim joining us. And these are the people who would be joining us. So, sir, whenever you would give me the green signal, we can start with this session.
Mr. Shashi Gogia is also there.
Sure,
Shashi
sir.
Gogia. Yeah. So, Dr.
Very
Gyani,
warm welcome, Doctor.
Dr. Gyani, can we start?
Yes, please.
Yes, sir. Okay.
So I think
All right.
about
Okay.
How much time we have got?
So the total time we have is from 1600 hours to 1800 hours. So accordingly, the speakers have to, keep their presentations.
Okay.
So we have a 4-hour session, basically.
4.
3-hour session, 3-hour session. I'm sorry.
So, actually, it's 2-hour session, starts at 4 o'clock till 6 o'clock.
Yeah, that's right.
Yeah, okay. All right. So it's a 2-hour session. Yeah.
Each speaker can have about 15 minutes time.
Sure, sir. Sure, sir.
Yeah. Okay.
All right.
I think with that, I welcome my fellow panelists. And this is a very interesting session. In fact, the whole conference is very interesting because health informatics is going to drive the next generation healthcare. The kind of shortage of resources which we have among doctors, hospital beds can only be overcome by use of technology. Otherwise, we are going to take another 10 years' time to come up to the level of achieving universal health coverage. And that, the healthcare transformation, it will be driven by what I call technology in medicine and technology in operations. So this session, I think more will be talking on technology operation, telehealth, telemedicine, smart hospital, digital hospital. Those things will be discussed. And we have, of course, a panel of very eminent speakers. So I will try to follow the order in which the names have been given. And maybe to start with, I invite Dr. Meena Kelani. Is she there?
Yes, I'm Yusuf. I'm with Yusuf.
Oh, you're which university?
Yes, okay. May I share the screen now?
Okay.
Okay. Can you see it or not?
Yes.
Yes, Dr. Yes, Dr. Meena, we can.
COVID-19 flourish, telemedicine leads the world towards virtual healthcare facilities. Can you see it?
Yeah, you can.
Yes, sir, we can. Yes, doctor, we can.
Thank you very much. First of all, I would like to thank the honorable organizers of this wonderful virtual conference. I've been so privileged to be among you today. And also congratulations to Dr. Ghani for the Lifelong Achievement Award. It was really very fortunate for me to attend this ceremony early in the morning. Today, I'm going to talk about my real life experience using telemedicine to treat and to manage COVID-19 patients. It's quite very strange for me. I practiced ordinary medicine, traditional medicine for more than 15 years. And due to COVID-19, I've changed my my usual practice because of this isolation. And so I want to figure out some of the prospective future aspect of this telemedicine approach. So let's see. On January 2020, the world has been awake on an epidemic that soon transformed into a pandemic. All of us currently know as COVID-19. At the time, I was alone working as a visiting professor in Kingdom of Saudi Arabia after my family has traveled back to Egypt for a short vacation. Suddenly, the international air travel was locked and I became isolated alone in my home, away from my family, from my little daughters, and from my elder parents, with no possible way for them to come or for me to go to them. I had nothing but an anxiety, fear, and research, seeing the news that is spreading all over the world. Wishing to help my isolated family back in Egypt, including my elder parent, as I've said, and two young daughters, 4 and 2 years old, my COVID-19 research evolved fast as I have never been able to, and fruited a first of its kind pioneering article to repurpose 2 inexpensive FDA-approved drugs, claiming a survival benefit if taken early during COVID-19 due to restoration of interferon balance. At that time, there was no research about the role of interferon, the role of these drugs, if taken together to manage COVID-19, and these drugs were nitazoxanide and azithromycin. At first, it was preprinted at a famous preprint server, and soon it became published in a Q1 journal, which is pharmacological research. And after that, it was cited by dozens of other researchers and publications. However, I was also very anxious about the claim that non-steroidal anti-inflammatory drugs might be hazardous for COVID-19. This claim came when a correspondence appeared in the Lancet Respiratory Medicine. You can see the title, "Our patient with hypertension, diabetes, are increased risk of COVID-19 infection," and the authors, unfortunately, anticipated that ibuprofen and non-steroidal anti-inflammatory drugs might be hazardous if they are taken for COVID-19. I have examined this correspondence and I was amazed. This is my specialty. I'm a physician as well as a pharmacologist. So when I examined their proofs, I found nothing. I even called it a scam. This is unusual for me, but because I've seen the world all over, the countries are avoiding non-steroidal anti-inflammatory drug because of this correspondence, I tried just 1 or 2 weeks later to send to New England Journal of Medicine, as well as dozens of other journals, that their claims are not true at all. I even in this, transcript called it a real scam. And of course, I found rejections. They can never accept a scientist from the Middle East or from Africa to say a scam about those notable researchers. Dozens of rejections were encountered. I counted about 12 rejections from reputable journals, and not a single honorable peer review was sent. It was just, we cannot publish it. However, I was fortunate to have advice to lower my tone of criticism. And almost 6 months later, it has been appeared after being peer reviewed, and it was published in a reputable international journal. And I called it not a scam, I called it the other side of the mirror. I truly actually have not changed a word from the science, but I lowered my tone of criticism. Actually, I was claiming since the early beginning of COVID-19 that this hyperinflammatory disease should be better managed by the anti-inflammatory drug. So I from the first start, I said that non-steroidal anti-inflammatory drugs have survival benefit, have beneficial benefit when taken over the paracetamol, which like a lot of potent anti-inflammatory drugs. And soon I had another paper peer-reviewed and published in a Q1 journal, also Biomedicine Pharmacology, saying why I believe that early use of non-steroidal anti-inflammatory drug will actually save lives, prevent complication, and improve the clinical outcomes when taken early in COVID-19. And this was another published article after also several rejection unexplained without peer review. But as you see, the world has still honorable editors, honorable people that will not refuse to send an article for being peer reviewed. Actually, they are few. The vast majority, perhaps because I'm African, I'm Egyptian, I don't know, but the vast majority of the journal will not send it to peer review. And when it is sent, I found I can reply to the editors and it actually will be published. Later, other preprints have explored other mechanisms to reason for the non-steroidal anti-inflammatory drug potential COVID-19 life-saving. Here is one currently under review at expert review of infective therapy. This is a reputable journal also. And here is another preprint also under consideration at another reputable journal. And at this time, my anger and passion was reflected through my social media account. Surprisingly, I began to receive compassionate requests to help from my fellow Egyptian people, whether in Egypt or in Saudi Arabia. At the time, if you remember 1 year ago, the mortality rate was very high. We had no treatment. And meanwhile, I also have published some papers criticizing some of the drugs that were being administered at the time, including hydroxychloroquine promoted by President Trump. I don't know why, including remdesivir, which is still, and actually I have a paper recently published saying that remdesivir is really potentially fatal drug. And that's why I found many compassionate requests to help. And for the first time of my life, I changed it to telemedicine and adopted as a practice and evolved my experience using these techniques new to me, one who has also only used the traditional techniques of inspection, palpation, percussion, and auscultation. Now I'm counting only my clinical sense and my social media video and my experience while asking and taking the history from the patients. And here is a YouTube video published on May 2020 saying that COVID-19 safe treatment protocol is being ignored because of Trump and Dr. Anthony Fauci bias and politics. I was not afraid to say my opinion boldly and clearly because I believe and still believing lives are on the stake, and I should not be afraid to say what I think is true. Then, for those patients, I've used non-steroidal anti-inflammatory drug, nitazoxanide and azithromycin. And meanwhile, I evolved this immunomodulatory protocol, as I named it later, to safely manage dozens of COVID-19 consented patient and legal guarding, including and presented 45 telemedicine. The most recent update of this preprint include my experience with 45 telemedicine consented cases, which is highly documented. It was first reprinted on June 2020 and described it as breakthrough. Since then, I have received the usual unexplained denial of review from dozens of journals. Once it was sent for peer reviewer, by the way, by a reputable journal, and it was accepted. This breakthrough, it was accepted on November 2020. Yet, unfortunately, it was withdrawn from publication in unprecedented act that I don't know exactly why are the reason for this action, because it is unexplainable from my point of view. And here is a proof post-acceptance agreement, and they withdraw it from publishing. I don't know why. Some unexplainable excuses that I just ignore. Those 45 patients included children, adults, geriatric, pregnant, lactating, and immunocompromised patients. And it is all written in this preprint that has been once accepted after being peer reviewed. Some patients were categorized as moderate to severe COVID-19, it is also described, and many patients had multiple comorbidities. The patients included 12 confirmed by PCR, the others were highly suspected by laboratory, radiological, as well as the history and clinical picture, and had no way to access for the PCR. As you know, in Egypt, as well as some developing countries, it is not easy at all to perform PCR. The success rate, as it appeared, was 100%. No serious adverse effects were reported. And I called it an observational study. For 1 year, I'm asking for large clinical trials to be adopted, but in vain. I do suggest that telemedicine can be a very valuable tool, as it has been in this pandemic. You know, there is a wonderful review article coming from India, and you are doing a wonderful job. I can see and encounter multiple papers coming from Indian researchers, and they are just presenting some novel and elegant medical approach. And here is one of these reviews. And here is another review coming from USA also about telemedicine use. In both reviews, you will find that telemedicine is currently being adopted and used successfully all over the world, and it has a lot of benefits, a lot of potentials that can be built upon and that should be built upon. And in my point of view, in management of infectious diseases in particular, telemedicine might have a crucial role as an alternative, more practical method to help patients, especially in developing countries where private practice is the dominant one. By the way, my presented 45 cases as well as other cases were managed for free. Yet, when I resume my private clinical medical practice, telemedicine, and adopt this telemedicine approach, it will cost, as we have taxes, rent, and salaries to pay. I wonder if one day, probably soon, big institutions might think of virtual hospitals and healthcare facilities where different clinics, specialties, use telemedicine to provide a proper medical advice and management. Moreover, after remote telemedicine, robotic surgery has evolved. A branch of these virtual hospitals might have a ward on the actual ground, where after evaluation by telemedicine, the patient would go there and have their robotic surgery performed remotely by their consulting surgeons. COVID-19 not only changed our world, it has also and more profoundly changed our minds and medical practice. Many disciplines, including telemedicine, were underestimated and they are currently in huge progress and evolution. I suggest a prospective evaluation should begin soonest to prepare for the next normal steps for the best interest of the medical practice. Finally, I still believe that the editors of the Lancet Respiratory Medicine who have authorized the release of that catastrophic correspondence and refused repeatedly, together with those on the mother Lancet journal, refused to publish the reply promptly, should be penalized because they affected the lives of patients all over the world, as I do believe. And I think the claimless scams that prohibited for long non-steroidal anti-inflammatory drug to manage the inflammatory COVID-19 should be put under investigation. One day we might witness them and other editors and authors to be judged properly, hopefully in this life, not in the other one. Here is one of the papers recently published. I thought it will never see the light because I'm criticizing remdesivir, favipiravir, and I'm saying that dexamethasone have questions that should be answered. And I'm saying clearly that dexamethasone used in the developing countries is wasting lives because it is malpracticed. Not all countries like India. A lot of developing countries, people heard about the dexamethasone is like a magic. So they give it to mild and moderate COVID-19 patients, and we saw mortalities and fatalities because of this malpractice. And even in this severe COVID-19, dexamethasone have rules to be done and to be administered, and you might also examine this peer-reviewed published article that had no response till now, as well as all my articles. And here is another preprint that I think also will not see the light, because every time I send it to Nature, Science, and even not reputable journal like this, they are afraid to publish it, because I'm just saying that SARS-CoV-2 vaccines have some hazards and we should know it, then decide. I'm just saying that we should know it and decide. These hazards include autoimmunity from my point of view, and some also a phenomena called antibody-dependent enhancement. And unfortunately, this paper is also seeing the much ignorance and purposeful neglect as other articles. Thank you very much.
Thank you very much, Dr. Mira. Actually, I absolutely agree with you that in spite of 1 year experience, we have not been able to standardize the treatment protocol. There is a vast variation the way our physicians are looking at in the different hospitals. And this is really an area of concern. Other thing is that data which could have been generated from the patient in the big countries like India, Indonesia, USA, actually has been missed out. Partly, of course, Lancet or BMJ have done some work, but we could have done much more. I think really very practical presentation you had made. I really admire your work which you have presented. Very useful for the participant. Thank you very much.
Thank you, sir. Thank you very much. It was
Now, next on the list is Dr. Rafiq Islam from the Japan. Rafiq Islam, are you there?
Yes, sir.
Yeah, please come in. Yeah, welcome.
Thank you very much.
Yeah. Dr. Mira, can you remove the presentation? So Dr. Rafiq.
Actually, I think I will get out and rejoin right now because I don't know how to end it.
There will be, down the line, stop sharing.
You can share your screen.
Yeah, now Dr. Rafiq can share.
Yes.
Can you see it?
Right. You can make it full screen, yes. Now we can see it. So.
Okay. Thank you. Thank you very much for giving me this opportunity to talk to this platform. My name is Rafiq Islam Maruf. I'm originally from Bangladesh, but I live in Japan. I'm an associate professor at Kyushu University Hospital. So today I will talk about a portable health clinic. This is a telehealthcare system, and we have a MCS module. So we'll talk about maternal and child healthcare in unreached rural communities. As we are talking about telemedicine and telehealthcare, I think this is very much relevant, especially in this time. And as I mentioned that I represent Kyushu University right now, but earlier I was working in Grameen group of Bangladesh. So during that time, we actually started this activities, portable health clinic. So the context was the developing country like Bangladesh. And I think this is more or less similar in all the developing country. So let me give a little background of the health profile of my country so that you will understand the significance of this project. Bangladesh is a highly populated country, and we have about 70% people live in the rural area. But unfortunately, like many other developing countries, we have insufficient hospital and clinic in the rural areas. We have absence of qualified doctor in the rural areas. On the other hand, the doctors we have are basically staying in the city areas. So we thought how we can provide better service to the rural people. Then we come up with a solution that telemedicine could be a solution so that we can use the urban doctors to provide the healthcare service to the rural patient. But when we think about the telemedicine, we have to ensure whether we have enough doctor in the urban area. But the fact is, although we have a good number of doctors in urban area, but that is not enough. If you see the graph here shows that when WHO recommends that if you have a population of 10,000 people in a village, you need at least 12 doctors. But in case of Bangladesh, we have only 5.5 doctors for every 10,000 people. So it means that this is less than half of the minimum requirements. So if this is the situation, it's difficult to provide the telemedicine with the limited resource of doctors. Then what's the solution? Then we feel that we need to increase the number of doctors, but this is not an easy thing. So of course, we have to increase the number of doctors, but at the same time, we can do another thing, that is reduce the number of patients. If we can reduce the number of patients, then we can handle the patients with the limited doctor. But now the question is how we reduce the number of patients. The solution could be by introducing preventive health care. So we feel that to tackle the situation with the limited doctor, we have to go to the preventive healthcare system. So then we come up with a solution with the advanced telemedicine, telehealthcare system, and preventive healthcare. Keeping these two in mind, we come up with the idea and we call it portable health clinic. So what is portable health clinic? Let's give me a little brief. Sometimes we call it a doctor in a box. But what is this clinic? Actually, this is a box of medical sensors. It is a lot of medical sensor, and it has a tablet PC that has an application, and it is connected with the doctor's call center. We have a city call center in the urban area, so it is connected with the call center doctors, and it is operated by a nurse. So altogether, there are 4 components. First, it is a box of medical devices, as a toolbox. With medical sensor and with internet connectivity. It is operated by one health worker, a village health worker, and it has an online service database service server system so that doctor and patient can communicate and exchange the data. And also it's connected with the call center doctor, so call center doctor can provide the consultancy to the patient. So I have a video on it. I think if I show the video, it will. It's a short video I have. Let me play it. It will help you to understand the situation.
As a land of 57,000 square miles of Bangladesh, with more than 160 million populations, people are suffering from various health problems. To overcome the doctor shortage and inadequate medical facilities in the rural areas, Portable Health Clinic, PHC, is a revolutionary invention. This is a joint initiative of Kyushu University, Japan, and Grameen Communications, Bangladesh, to ensure the universal health coverage, UFC. This will bring the healthcare service to the doorsteps of the unreached communities of the developing countries in an affordable and sustainable way. PHC enables physical checkup using automated medical equipment and transfer the vital data directly to the call center, doctors for their reference. PHC measures BMI, blood pressure, body temperature, diabetes, hemoglobin, urine tests, etc. Based on the test results, PSC triage system classifies subjects in 4 categories: green, yellow, orange, and red. Orange and red category subjects are to be connected with a call center doctors through video conference. PSC has been primarily developed for providing basic healthcare services, with a special focus on non-communicable diseases, NCDs. What is the main cause of deaths? However, there are many patients who need other types of secondary or tertiary level of treatment. To address these demands, PSC has gradually added new modules like telepathology, tele-eye care, and maternal and child health care. Recently, COVID-19 module has been added to tackle this pandemic. Other than Bangladesh, PSC has been replicated in many developing countries including Cambodia, India, Indonesia, Liberia, Malaysia, Pakistan, and Thailand. The global healthcare team of Kyushu University has been continuously working with the partners in other countries for further development and expansion of PSC system with the mission of fulfillment of the Sustainable Development Goals, SDGs.
So thank you. This is the short video. And as you can understand, as it is an online server system is involved here, so all the data are preserved on the online system. So as a result, automatically we have a online electronic database system of the from this system. And you can see the format of prescription. This is an e-prescription. We provide this prescription to our rural patient. The doctor prepared the prescription from the urban city, and it is in the box. Actually, we have a printer, so the patient can get the prescription immediately right after the consultation with the doctor, and the health worker distribute this prescription to the patient. And if you see the prescription, there is a specialty here. You can see the all vital information are in the prescription with the consultancy together. And in case of vital information, you can see that color distribution. As it mentioned that there is a triage system in this PSC system. So all parameters has a representative color, because this is very important for the rural people. Those actually, they don't understand the significance of the disease. If you say your temperature is 120, 180, they don't understand what does it mean. But if you say your temperature is red, they can understand that this is alarming. So they can be careful about that thing. That's why we use the color code for in the prescriptions. And automatically, as all data are there, so it has a online personal health record is automatically developed. So any patient can monitor her personal data using her smartphone or whatever device they have. They can see from anywhere, anytime. They can see all the previous record in a form of personal health record. And as I mentioned that PSC was originally initiated for the basic health checkup, basic health care with the focus of NCD, but later on we extended the service in different areas based on the requirements like eye care, MCH. But today I will talk, next part of this presentation, I will talk about the MCH care, maternal child health care, how we use PSC system for maternal child health care. So if you see this data, you can see the infant mortality rate in the Asian countries, some of the countries, especially in the Asian countries. If you see this graph that in our country, BDZ, I mean Bangladesh has about 23.67. As of 2021, we have the infant mortality rate is 23. Compared to Japan, it has 1.6 only. If we consider the maternal mortality rate, still it's very high. We have 173. So this is a huge number, you can understand. So, but if you see the lower graph, it shows a sharp decrease of the infant mortality rate in case of Bangladesh. Like in 1971, during our independence, when the rate was about 160, by 2021, it fall to 23. But still it's very high. So we need to do something how to improve this. Because if we go to with this flow, it will take another, we have to go until 2046 to come to a single digit. So it's a long time. So we need to do some urgent action, how we can improve the infant mortality rate and maternal mortality rate. So that's why we came up with the challenge that now we have a challenge in our rural area. We have a baseline survey when we find that only few people are taking antenatal care and postnatal care, very few people. The main reason is we have less healthcare facilities in the rural area. Every area, they don't have that facility. And another thing is lack of awareness. Most of the rural people, they don't understand the significance. They feel when they give birth, they will go to the hospital or somebody will take care of them. But before and after, they don't care sometimes. So this is something. So then we come up with the solution that if we can provide the maternal and child healthcare service using our PHC, portable health clinic, then it can work. Because in this system, we provide the service at the home. It's a home delivery service, and we provide the telehealth. So we can use the urban resources, urban gynecologists to support this system, and we can use home delivery service so that maximum people, they will get the service at their home. So there will be less miss of attending the antenatal care. And what we provide in this MCS service under PHC service is that it is we just follow the WHO protocol. As you know, that there is 8 stages antenatal postnatal care. 4 of them as the antenatal, 3 as the postnatal care, and including 1 birth delivery. So 4 stages care is there. So our health worker in the rural health worker, they provide this healthcare service by a home delivery system. So health worker visit, and all mothers, all pregnant ladies, they can attend this service from their home. And in addition to these 8 stage services, we added 2 more to follow up until 1 year of the age of the baby. So we added test 9 and 10 at the age of 6 months of the baby and at 1 year age of the baby. So altogether, we provide 10 services. And in our portable health clinic MCH box, earlier I mentioned that in our box was designed basically for the primary healthcare. But when we added the MCH module, we added new components in the box, like heartbeat measurement tools and ultrasound image devices are added in the system. And basically this device was operated by health workers. So this is the village health worker. They are not, they are just having 2 years diploma in paramedics. So they need a training from our expert team, and they are provided with the devices, they're provided with the training. Based on that, they can start providing service in the rural area. And in rural case, we have some traditional birth attendant, and basically we try to use them, but they need the training, and based on the training and their capabilities, we appoint them. And we use the urban gynecologist as expert doctors to support the serious patients. But we have the general physician also to take care of the ordinary patients. And this is some images of the service. You can see that initially we have some survey, collect the patient history, then we have check and take the vital information. Then we have the checkup of the mother. If the baby is in advanced level, we use the ultrasonogram. And finally, we connect to the doctor, city doctor, if necessary. And this is another picture. You can see this is the real picture. Actually, the health worker is visiting the house of the patients, and they are providing their service at their yard. And of course, for the privacy, they provide the service inside the house for the special care of the mother. And this is a short result of our last 1 year. We are working with the MCS program in a pilot phase. We are using one village with 14,000 people. And we have, under that, we have provided the basic healthcare to the 360 productive age women. And other than 134 pregnant women were under this program right now. Actually, under 170 pregnant women are under this program, and out of them, 134 give birth of their babies. And we are lucky that we didn't find any stillbirth there, and there is no maternal mortality death there. But there was 2 deaths, 2 baby were died. That is not actually, that was a special case of COVID-19 situation. Due to the COVID-19 situation, the mother and the baby couldn't get support from the hospital because hospital was partly closed. That was the main reason we can understand for the deaths. Other than, we could say that this could have a good result to the overall situation in context to the general situation of Bangladesh. And in the bottom chart, you can see that in the trials of antenatal, in antenatal case, we had 175 antenatal checkup. And out of that, you can see that 9% were rape patient and 52% were orange patient. It means these are the patients who needed immediate doctor consultants, who needed expert opinion. So we can say that using this system, at least we can cover these people, they could get the consultancy from the experts. If this service was not there, it means that these 61% people were not taking care of antenatal, were not under antenatal care. If this is a situation that can cause a lot of death, like that is the reason why we have a high mortality rate. So this graph at least ensure that we can cover, we can provide the fundamental service to the people, those who need, and this can save a lot of lives. And actually in this program, this service is provided by the village health worker, and this is not they are not the employee of our team. Actually, they work as an entrepreneur. They take our license, they take our training, and they start this service. So this is the best, some criteria to be the entrepreneur. And finally, I will conclude with the conclusion that PHC, it's a PHC MCS care service. It's a very cost-effective and simple technology. And as we provide the home delivery service, we can ensure maximum participation of the continuum of care. And rural medical resources like village worker can work together with the urban expert so that we can make best use of our resources. And one issue remains, that's the public insurance needed. In rural area, as this is a payment-based service, most of the cases, rural people has some trouble to pay the money. So we feel that if there is some sort of public insurance system in the society, then it can help the rural people to get better service. So that's it. Thank you very much.
Thank you very much, Dr. Rafiq Islam. You see, I have done a lot of comparative study on the Asian countries, and I must tell you that we rate Bangladesh health system as far as primary healthcare is concerned, and particularly child and women health is concerned. You had a very high score. In fact, a country like India, which is known for tertiary and quaternary care, for which in Bangladesh people come to us. But our primary centers have to learn much from the Bangladesh. And so I think I hats off to you to study. I think the data which you have presented is really learning for me as well. And in fact, I will be requesting you to share your presentation with me some other time. Thank you very much for excellent presentation.
Thank you very much. Thank you.
So now we come to Dr. Divya from the National Health Mission Program. So Dr. Divya, please make your presentation.
Thank you, sir. Thank you, Girdhar Gyani, sir. I hope I'm audible.
Yes, yes.
I'm Dr. Divya. I am actually leading the training team of state of Kerala, which is a small southernmost state in India. I hope at least someone would have heard about the state. It's one among the smallest state with thickest of the population. And we were the first state to what we actually, our COVID-19 cases started first in Kerala, to say in January 2020, 30th, we reported our first case in India. And after the first incident itself, we started our journey towards the new normal or the next normal, towards what is that, online trainings, online schoolings, home deliveries, and lot of restrictions that actually brought us near the Government of India platform for telemedicine. I am presently heading the training and telemedicine, which requires a lot of technical assistance from many of the what is the technical team who are around us. We actually implemented our learning management system, which brought our whole of health workers towards the training and in a virtual platform that is accessible anywhere, anytime, with the help of a mobile phone. And we have launched many modules in that also. But now, as all of the three speakers have told, like that, I am also concentrating on the telehealth, what we have done in our telemedicine platform. Our telemedicine platform is nothing other than the country's SIDAC's telemedicine platform, that is eSanjeevani, which was officially inaugurated by our state health minister on June 2020, June 10th, 2020. So I'm sharing the screen. Is it visible right now?
Yes, only the.
We can see your screen, but you need to click on the presentation, I guess.
You can see the Explorer. Maybe you have shared the wrong screen. You have to share the full screen or the presentation after starting it.
Is it visible right now?
This is your directory. We can see your file names, not the file.
No, what you have to do is stop share and reshare the full screen. You are sharing the Explorer.
Is it okay right now?
Yeah.
Yes. Now it is fine.
Yes, actually our telemedicine platform is same as the Ministry of Health, Family and Welfare eSanjeevani platform, which state of Kerala has now completed around actually I prepared the slide 2 days back, and that is why it is 95,000. Now it is around 1 lakh consultations. We started it from June 10th, 2020. Actually, what we intended to do was nothing but Kerala is a state having 3.5 crore population, and many of Keralites are having very high health-seeking behavior. Because Kerala is a small state and it is similar to a urban population only. So people actually tend to move to hospitals for every silly, simple questions and queries. It was a big hit for all of the Keralites when we locked down the state. I mean, locked down the country for a few months. Our lockdown started in around March and continued till April, and our state having a big load of non-communicable diseases who were continuously managed by the GPs were locked down in their homes. that brought to a big problem of increased caseloads, increased what is the difficulties in managing them. They're full of grief, anxious, and like the first speaker Meena sir rightly pointed out, they were calling us with in the call center. There is a call center also for the state of Kerala, day and night. So that brought us to the idea that we should start a telemedicine platform at any cost. And then there was the eSanjeevani platform of Government of India, which came for our help. We started a general OPD. General OPD is just an MBBS doctor handling the cases. With 10 doctors, we handled almost 1 week. Then we identified there is a big demand for specialty OPDs. We are having some of the premier institutions in the state, and we approached the premier institutions like Regional Cancer Center, Cochin Cancer Center, Malabar Cancer Center, IMHANS, Indian Institute of Diabetes, and we started all the specialty clinics over this platform. It was tremendous, and we received a lot of good responses via this platform. There was actually services being provided for all those who are geographically separated. And now we are having around 1,000 of doctors on board in this platform. And Kerala is one among the state which is having this teleconsultation status and ranks only up fifth. We are having states with 10,000s of consultations happening daily. So this is the picture of our inauguration by our Honorable Health Minister. She took our initial consultation and inaugurated it. Actually, it is a free platform. There is no cost, and our doctors are also empaneled by National Health Mission or our Directorate of Health Services, who are all permanent employees who were given an additional responsibility only. It's a two-way communications in which the patient gets a prescription slip itself. But there is some setbacks, as we already heard about what Bangladesh told. There is no direct interaction with the patient. We are actually connecting the patient through phone only. So patient can avail this service through a Android mobile phone, where in Kerala the penetration of Android mobile phone is around 80 to 85%. That will actually assure that almost all of the majority of the population can avail this service. We have the specialty OPDs like dermatology, psychiatry, pediatrics, oncology, counseling services, early intervention centers like physiotherapy, speech educator. Everything is being supplied. Can be availed through this platform. Actually, people are using it very happily. And since I already said, there is RCC, Sri Chitra, Indian Institute of Diabetes, IMHANS, CCRC, etc. are part of eSanjeevani. There are lot of people who are traveling across the state from the northernmost district to the southernmost district for reaching this premier institution. And the government of Kerala, what they did to support this platform is they issued the government orders in view of getting these services. Like they issued orders for all the pharmacists to issue medicines with the prescriptions of eSanjeevani, and all the medical practitioners who are permanent employees of government of Kerala are instructed to be a part of eSanjeevani. What we are doing is we are just pooling the free times of the doctors so that they are available in a time where they can be pooled and rotated to be accessible for the general public. So we are actually there are some heart touching stories where eSanjeevani platform is being utilized in jails. We are having jails where there is consultations became severely affected when lockdowns came. So jails, orphanages, palliative care centers, etc. are utilizing the services. We Kerala are having a good primary health system. Like we are having for every 5,000 population, we are having multi-purpose health worker or female health worker and a male health worker who are visiting or doing these house visits and giving preventive and promotive services. We are also having mid-level service providers who are appointed as part of Ayushman Bharat. So they are also doing this house visits. So all these house visiting teams are actually instructed to educate the general public to utilize this service through this app, which is a simple app which can be downloaded from the Play Store itself, and providing their mobile ID and getting an OTP will get them to this service. So we are training all the primary and preventive healthcare providers to access this service and make their beneficiaries very much familiar with this platform. Nowadays, we are getting consultations around 400 to 500, which is equivalent to a primary healthcare center in each panchayat. Panchayat is a geographical area with a population of around 25 to 35,000. So we are having for every 25 to 35,000 population, we are having a primary healthcare center, which similar to that. For each primary healthcare center, we are catering around 200 or 150 OP. So comparing our eSanjeevani virtual platform to a primary healthcare center, it is serving more than 4 or 5 times of a primary healthcare center. And giving the specialty, making the specialty services accessible for all is actually a big part of this universal healthcare. So it is actually saving lives and helping them diagnosing patients with warning signs. And one of the major breakthrough is the mental health center, mental health care being provided by this eSanjeevani OPD, because we know we are all having that stigma to reach a mental health center if at all we are having some problem. Maintaining the anonymity and privacy in this telemedicine platform help the patient to adhere to the treatment, where in telemedicine or when in psychiatry patients are the majority of them who might have a who will go who will lose their treatment in between. And there is dermatology OP is also giving big services for big width of services to the general public. So there is a lot of areas where it can be extended to, like we are having pediatrics OPD being conducted, like prevention of like early identification of metabolic diseases and all being done through the Shalabham project. There is cardiac diseases being identified through the Hridyam project, and these single entities can be linked to a single console in the state, where universally they can always access for services and opinions. So keeping all these possibilities in mind, we are planning to expand the services rendered via this platform and by onboarding more of specialists, linking with the presently working e-health system, linking with the sub-centers in family health centers and PHCs, where family health centers are the renamed PHCs with a lot more of services added, like ENT, Ashwas, mental health, Shwas, that is COPD, chronic obstetric pulmonary diseases. We are also planning to implement, not even planning, it is in the way only. It is, they are already doing that, implement the services, door-to-door delivery of medicine using the Arogya Sena, that is a voluntary group in each panchayat. So it got such a much attention among the people and became a big breakthrough, and people are getting their routine medical attention professionally. This platform is necessary to continue and tackle the situations created by not even COVID-19, any other diseases which can prevent the patients from attending the crowded hospitals where the spread of diseases are happening. So this is the one way where we technologically handled our COVID-19, and we are having a lot more of technical areas where COVID-19 was in between this big tragedy also, which turned our which actually opened many chances for the healthcare professionals. Like the learning management system is also gaining a lot of attention, and it is making our life very much easier. And I'm stopping here. We'll hear more from during the discussion. Thank you, sir.
Thank you very much, Dr. Divya. I say thanks to COVID, the teleconsultation has been now legalized. Number one. Number two, many of the doctors who were very reluctant to use this have started using. But I tell you, still we are a long, long way to go. But your initiative here, beside technology, has got a lot of human issues, a lot of socialistic issues. And that is why I think we compliment your effort in bringing up this kind of initiative. Kerala, I think it is applicable in the whole country. And this has been successful. I have learned from my colleagues who are working in Amrita Institute. They keep telling me about this, Dr. Prem and Dr. Sanjeev Singh. So thank you very much for the excellent presentation. And now I move over and we invite Dr. Sushil John from the George Institute of Global Health, India. Is Dr. Sushil Jain? Yeah, please. Do we have Dr. Sushil Jain? Sushil John?
I think he's been disconnected. I think I can't see him in the list.
Okay. And do we have Mr. Vinod Nacharajan?
Yeah, hi. Good evening, Dr. Girdhar. Good evening.
We are not able to see you. Yeah, here you come. Okay. So welcome to the talk. Please make your presentation.
Hello.
Yes, please.
Yeah, is my screen visible?
Oh, yes.
Yeah, great. So thanks to all of you all, for this opportunity to be addressing such an great audience. I would also kind of, take this opportunity to say a word of thanks to all of you healthcare professionals. You all are doing such a great service to all of us in these testing times. So thanks a ton for everything that all of you all are doing. With that, I would just quickly kind of get into the reason for my session. We've been kind of constantly, in this current session, we've been hearing about telemedicine, etc. And previously we've been talking about digital transformation and how that is going to impact the healthcare segment. Dr. Anil ji kind of thought that a session on cybersecurity would be very pertinent and relevant to everyone here. So that's the reason I'm here today. So just a quick couple of points about us, myself and our organization. So I'm the Chief Business Officer at AI Cyberwatch and Net Data Vault. At AI Cyberwatch, we are helping organizations to transform and strengthen their cybersecurity postures. Financial services and healthcare organizations are two of our focus verticals in uh, in what we are doing. Uh, our sister organization, Net Data Vault, is into the business of providing cloud hosting and backup and disaster recovery solutions. We've kind of got our operations across the globe, while we are primarily centered in headquartered in India.
Bit loudly, please. Speak bit loudly.
Sure. Can you hear me better now? Is it better?
Yes, yes.
Okay. All right. So I was saying we have operations across the globe. So that's it about us. Now getting to the crux of the presentation today. If you this is just an overall a general cybersecurity landscape, as I would call it. Most of us have kind of been constantly reading about the cybersecurity in various news articles, or been kind of listening to things. So I'm just trying to kind of decode and simplify stuff for everybody's understanding, and to kind of drive home the message for the evening. So what we see is that the attack surfaces are increasing for all sorts of activities. Earlier there was a time when people just used a single desktop, then it kind of moved to a laptop. Now you have multiple devices. You have your own iPads, you have your mobile phones, you have IoT enabled devices. So the attack surface is kind of increased, making it easier for attackers to get to you. Also, the threats are becoming far more sophisticated. Earlier there was a time when a particular virus would just say probably destroy one particular floppy or a few files on your computer. Today your entire systems can be impacted. So the threats have become far more sophisticated. Of course, compliance laws are changing across the world. The data privacy guidelines are coming into force, and more organizations are going to have to adhere to those norms. You got to kind of and in while all of these things are true, it is also true that most organizations, not just healthcare but across the board, have a fund shortage, especially when it comes to IT budgets. Almost everyone kind of talks of how there is a limited IT budget. And another challenge, of course, is coupled with this is that there is a security skill shortage. Just today I kind of read an article which was saying there is 3.1 million jobs that are or positions that are to be filled in cybersecurity across the globe. Now that's a huge number. So obviously, if there is a security skill shortage, you got to kind of pay them more. So limited IT budgets and a security skill shortage. It's a perfect storm if you would kind of think of it. Now, let's quickly look at some numbers which are relevant to healthcare. On an average, it takes 55 days to detect a data breach. Now, just think of it. You're having an ailment, and almost for 2 months, you're just not even aware that there is an ailment. So that's a pretty serious issue. Once you are able to decipher that there is a breach, the efforts to contain the breach and to kind of remedy the breach can go on for as long as 3 years. So that's how bad it is. What you see is one of the things that research shows us is 46% of all breaches are caused by ransomware, right? So that's again a staggering number. Ransomware might seem to be like one of the most simplistic threats out there, but it is causing the maximum damage to most organizations, right? Again, almost in our surveys, what we have found out is that 36% of IT professionals, this is medical or healthcare IT professionals and chief security officers, are kind of not confident of their ability to be able to ward off cyber attacks, right? And now put all of these data points in conjecture with the fact that you have close to 3.7 million medical devices which are connected to the internet in some form or the other, and which are being used to monitor patients. So you can see that, the where I was just in the previous slide, I was talking about the attack surface kind of expanding or exploding. You get a sense of what is happening right here. Again, there's a lot of numbers out here, but the messaging or what you need to be kind of aware of is this, that healthcare organizations are really being targeted very strongly. The overall increase in cyber attacks on healthcare has been, it's really an exponential increase. And what's worse is the financial impact on all of these things. Now, just think of it today in these troubled times when there is not enough funding for fighting COVID, you're going to be losing money to such sort of attacks, or it's going to prevent you from working. It's a really bad thing that's happening. I mean, you can see some of these numbers over here. Of course, these are global numbers, not specific to any particular geography, but $300,000 or $1 million of financial impact is very severe, right? uh, what we need to kind of especially focus on is over last year. I mean, with COVID, what we saw was that the attacks on healthcare institutions actually increased a lot more. It was almost as if they thought it would be great to kind of go after healthcare, because right now it is the healthcare entities which are most in demand, or they're doing a whole lot of work. We read enough and more about how some of the vaccine manufacturers were attacked and compromised, and how it impacted their operations also. And you can see these are statistics of attacks from across the globe on healthcare organizations, and which are kind of directly linked to the COVID time period or to the COVID situation. So you can see that a lot of folks have had to pay ransom or had their operations impacted. So it's as for almost for 15 days to 20 days you are unable to do anything significant because your systems have been compromised. So that's the kind of threat that we are witnessing today, right? um, Now, this is slightly technical in information, but this tells you as to why a lot of these attacks are happening, or what is one of the key concern areas. A lot of unstructured data is being stored in third-party locations. Now, of course, from a electronic perspective, it is kept in data centers. There's a lot of paper-based patient records or hospital records which are given for safekeeping or for handling in other organizations. But the information owners are not making an effort to kind of ensure that the data being stored either in a third-party data center or in elsewhere is being kept safe. So a lot of your critical patient data or other specific information about your organization is very easily available to hackers. And it happened very recently with one of the prominent pathological laboratories in India, whose entire patient records were lying in a popular cloud provider, and it was had no password, no nothing, and it was easily hacked. Now, these are some of the reasons why we are seeing more and more attacks and loss of patient data or loss of critical information from the healthcare organizations, right? Uh, so just I'm just trying to summarize what are some of the critical challenges that from a cybersecurity perspective that healthcare organizations are facing. As I said earlier, ransomware is like the biggest threat. Almost 50% of the attacks are for ransomware. Now, what is ransomware? Ransomware essentially is all of your data is locked up by the hacker, and you no longer have access to the data. If you want your data back, you got to pay the ransom. Only then will you get your data back. Correct? So that's like one of the biggest threats. Second is, of course, email compromise. Now, what happens is, and as most of you must be also be aware, last year there were a lot of emails, floating around, which were talking of the WHO, about as if it was coming from WHO and talking of some sort of COVID cure or some sort of COVID relief. So these are all phishing emails, which unsuspecting employees tend to click, and then there's a data breach happening. Then, of course, there is the whole challenge of insider threats. It's about your own employees not either not being scrupulous enough or inadvertently leaking some information. Correct. The other, we've been constantly hearing about telemedicine and connected healthcare. So the more and more the number of devices that are getting connected to the internet, IoT is here, of course, and IoT has great benefits. So as some of the panelists before me have been mentioning, the benefits of connected healthcare are many, but at the same time, the risks are kind of have gone up manifold, right? Another thing that we have kind of seen is most of the a lot of employees are really not even aware of the basic cybersecurity hygiene. I was chatting with the security in charge of a prominent hospital group, and he was telling me a lot of their employees, their passwords are 12345 6. I mean, so it's like so basic, but there's just no awareness, or they're not caring about it. But the things like this can have a massive impact on the organization, right? Similarly, two things, which is, again, this is at an enterprise level. You have a multitude of old devices, or old healthcare devices, or old IT systems, which are much more prone to attacks. So their defense mechanisms are not as strong. Similarly, one last thing is what we have seen is in while communicating with other organizations, or while communicating between organizations, encryption is barely followed. So the communication protocols are open for the whole world to kind of see. So it becomes far more easier for hackers to tap into your information. So these are some of the cybersecurity challenges, or the reasons for major breaches happening. So we just saw a huge list of breaches that have impacted healthcare. These are some of the causes, as I would say, right? Now, we saw we just saw the causes of your breaches, or what's plaguing healthcare cybersecurity. While the challenges are immense, it's also not so difficult actually to kind of prevent a lot of these issues. There are some very basic things that can be done, very basic steps that can be taken, wherein you can protect your systems, organizations, where you can protect yourself. And it's what I've kind of tried to depict over here is it's as simple as wearing your mask, right? In today's day and age, what we've been constantly, the message being hammered in is wear a mask wherever you go, where do not step out without wearing a mask. And this is, I mean, that it's basic, right? I mean, it doesn't require anything much for us to follow. And that's what some of these things are, right? You kind of constantly do penetration testing or vulnerability assessments of your systems to figure out if there is any way in which it can be breached. You conduct cyber awareness trainings for all of your employees, constantly every quarter, have them go through some cybersecurity hygiene training, provide, keep refreshing that content and providing it to them. Similarly, while you while you communicate between organizations, or in while today, where we are enabling remote work, and also we are talking of telemedicine, etc., it is very important to kind of, at the very basic, have something like a VPN protocols. So VPN protocols ensure that the communication that you're doing with anyone outside your organization is going through a secure channel, and nobody else is able to kind of get into it, right? Now, of course, having an enterprise grade antivirus is also very important. We have seen organizations who have been so lackadaisical as to not even having a proper antivirus in place, or not even kind of managing the antivirus policies better. Now, all of these are actually just, tactics. What is really important is having a cohesive, comprehensive policy in place. You need to have a proper cybersecurity policy in place, a proper information security policy in place, and all of these solutions really have to tie in together to the stated objectives of your information security policy or your IT security policy. Otherwise, what we see in a lot of places is folks are just kind of doing random things. So doing disparate taking disparate cybersecurity measures is just not going to help. I mean, to kind of put it in a medical parlance, just because you are cautious about what you eat, but you do not do any form of exercise at all, then you're kind of it doesn't really make enough sense. If you want to have everything in place, you need to have a proper schedule for what you do, how you do it, and have a holistic mix of all the things that can take care of your health. So that's really what is needed. More importantly, of course, like, again, just kind of trying to connect it to our current situations, you need to have the what you saw on the previous slide is a lot of basic stuff that can be done quite easily by your in-house IT teams and doesn't require a lot of support, etc. But what is equally important is you need the services of trusted service providers who can provide you some of the pieces that we talk of over here. For example, backup and disaster recovery solutions. So backup is the only proven way to fight a ransomware attack. So if somebody locks up your data, but if you have a very an up-to-date copy of the data in another location, it will not impact your operations. You can quickly restore your data from there, right? But that backup needs to be maintained in a particular fashion, in a particular environment. You cannot have a backup of your data attached to the existing systems that you are running. It has to be in an offsite location, separated from your existing operating systems, etc. Right? For all of this, you need specific individuals who are kind of trained and have specific capabilities. For example, something like the Security Operations Center. Now, this essentially monitors your IT systems or your connected IT devices on a 24/7 basis. You need trained engineers who need to do this. And the good part about all of this is today, there are many organizations like us who provide all of these managed services, and you do not have to invest a huge amount of capital into it. You have a pay-per-use policy, and you can get all of these services like a data loss prevention, etc., and ensure that your systems are completely protected at all points of time, right? Um, on a closing note, this is what I would like to leave you with. What we have seen is more than 50%, there is 56% of ransomware victims have paid a ransom, but 25% of them didn't get back their data. This is like saying, you didn't follow all the precautions, you didn't wear a mask, you didn't kind of probably get vaccinated, etc. And then if you're going to be out and about, you're surely going to have some, bad impact, and it might not turn out too well for your organization. So with that, I would like to kind of close my session. I hope all of you all found it useful. You can be happy to connect with you all offline also, and for any further discussions or any requirements that you have. Thank you so much.
Thank you, Vinod. It is very interesting and scary also that ransom is being talked about for the hospital business. In fact, let me add, in one of the conference, they talked terrorism also, that if you are not secure, do not have cyber security, you are also subject to terrorism, also will play a big role here. And so let me put it this way, each hospital today has to have hospital information system, without which it cannot function, number one. all records in time to come have to go on the cloud. That is also going to be mandatory or the business requirement. So I absolutely agree with you. This business becomes very susceptible to the cyber threat. And let me tell you on positive side, many pharma companies, many research companies also will be interested and use hackers for their, this is a flip side of the whole issue. So all said and done, this is going to be a gold mine. This data of healthcare is going to be a gold mine in many respects, in a positive way, also in a negative way.
Absolutely,
That's
true.
ISO 27,000 will do the job, but actually, healthcare system needs much more than ISO 27,000 standard. So I appreciate your concern, and I'm sure many healthcare organizations will be happier to contact you for the valuable guidance and services. So thank you very much.
Thank you so much, sir.
Now it's my pleasure to invite Dr. Marvin Leo from Birmingham Global Hospitals. Do we have Dr. Marvin Leo? Okay, maybe. Okay, fine. We'll wait, And do we have Dr. Abdullah Salim from the Omni Hospital? Oh yeah, I'm seeing you, Dr. Abdullah Salim. Are you ready for the presentation?
Yes, sir. Can you make me the presentation if you don't mind, please?
Okay.
Okay, share my screen.
Right.
Able to see my screen?
Make it slideshow. Full screen, yeah.
Right.
Thank you. Right.
So, thanks for giving this opportunity, sir. And I'll not take much time, and precisely I'll just try to conclude my session. And this is I think every individual has put a very good emphasis in terms of the healthcare transformation and telehealth and telemedicine. Though this technology was available more than 1.5 decades ago, but implementation and the adoption of this technology was nowhere. But this pandemic has enforced to the clinicians and the patient also to go for it, and up to some extent this technology has taken a good shape in terms of getting the remote consultation, and this belief have come by first it has come from the patient perspective, fraternity, and then the doctors. So the constraint which was earlier there between the doctors and the patient in terms of the telemedicine, that has been addressed automatically up to some extent, not fully, but definitely down the line it is going to be much better. Reason behind that all big hospital, corporate hospital, they have changed their SOPs, especially for the consultation. The SOPs, they're saying that 80%. They are saying that 80% consultation is supposed to be remotely, and just 20% this consultation will be done in person. For example, first consultation in person, the rest of the follow-up consultation is supposed to be remotely. That's the SOPs are being implemented across. But only the people are talking about the telehealth, telemedicines, and it was working in silos. I saw that during pandemic. Too many people quickly they stitch up their solution from here and there, and they start selling it out. And on top of it, the EMR component was missing, and this was not the main component of the native solution stack of any product owner. And if the product owner not having the main component into their solution stack, then definitely the consumer will not be having that. So having said that, the telemedicine, telehealth component is must-have feature into the native solution stack, and the product companies have understood and they have added into it rather than going and selling it out as an individual component to the organization. So this is and this is what the telemedicine's enabling the continuity of care in terms of patient engagement is the best one, and patient engagement in terms of not the garbage, entering the garbage data and just preparing the prescription is done. But this is supposed to be work with the CDSS, clinical decision support system. It should work on top of it. Then the right patient engagement will be achieved. Then the recently we use this telemedicine solutions in the home quarantine and hotel quarantine concept, which was first, which was enabled by the Omni group of hospital, and we were monitoring the patient on this application. All the vitals were being monitored through the applications, and in case of abnormality, immediately the patient were being taken to the respective Omni hospital and start the treatment. So where there again, it was showing that the cost effective, unnecessarily it is not required, and home quarantine, hotel quarantine was far cost effective than just putting the patient in the hospital and start treating and charging unnecessarily to them. So that's when we started with this technology. It helped a lot on that. And then the post-discharge, and geriatric medicines come in picture, that after post-discharge, we also keep follow up with the patient for the quarantine, the COVID patient, as well as the patient who are really chronic patient in terms of heart failure patient. We are using this technology, and complete EMR longitudinal record is accessing by the doctors and giving the treatment to the patient to ensure that he is getting the right treatment at the right time. That's the second part of this telemedicines and telehealth and health solution has used for. As I said, the first consultation in the person, the second consultation is the SOP we have implemented across our 7 units, and the integrated part of, and this we have made that it is an integral part of the EMR of solution rather than running it in isolation. And enabling clinical decision, again on top of it, telemedicines, the doctors are doing the consultation. He is using the complete platform of clinical decision support system, where the doctors being alerted in terms of the right clinical pathway he is selecting, and treating the patient and preparing the prescription. And the clinical reminders and notifications for the patient, for the doctors, are being generated on top of it. So that's where this integrated telehealth, telemedicine solution has been added value for the patient fatality and the doctor and the doctors and the hospital as well. The second thing is to stop the clinical errors. Of course, if we're running the telemedicine isolation, there is a possibility that knowingly and unknowingly the doctors will commit their medical errors. That's, we have to stop that. Improve patient care experience. That is another goal, that a patient experience and provider experience should be improved rather than losing it. And then the efficient EMR, EHR improvements work efficiency and help healthcare providers to reach their goals. So the goals is that the patient satisfaction. So that's where the integrated telehealth, telemedicine applications is supposed to work on that. EMR improves work efficiency and help healthcare providers to reach their goals. Enable cost-effective treatment. Of course, if you're working on the integrated telehealth, telemedicine, then all the redundancy, you don't have to do a redundancy. You have to just views your entire longitudinal records of the patient and take a clinical decision to start the treatment. Avoid redundancy in terms of CPU also. and EHRs are used to, and these are the part, and that are the part of the EHR, EMR, so that you have a complete records of the patients to perform research on top of it, the right data. Healthcare, and then EMR improves work efficiency and healthcare providers to reach the goals. Again, I have said earlier, provide quick access to critical patient care for efficiency and coordinated patient care. Offers a favorable environment for healthcare providers to enhance their productivity to work-life balance, reduce diagnostic and medical error to improve overall. It means if the integrated solution, if it is not working, whether it is a medicines, then there is a quite a chance to only commit the medical errors. And if it is medical errors going to happen, then the patient is going to survive, and ultimately, in worst cases, the patient may die. So that's where we say that the telemedicine is the must-have feature component in the native application. And the EHR facilitate advanced healthcare decision, providing evidence-based care all the time, because whenever we are talking about in the primary care, there also the evidence-based the clinical pathways are defined, and the doctor are using the template during the primary healthcare treatment to treat his and her patient. To enable quality healthcare for all through appropriate adoption of world-class clinical information system in affordable and sustainable manner. There are some challenges which we face. There's a challenge. There's a huge list of it, but I have found out a bit of the integrated with native solutions stack instead of running it in isolation. Is still a lot of EMR in India. Few EMR companies are there, and globally they have started stitching this telehealth solution into their EMR main application stack. And then the second is that was the problem from the product side, product owner side, and the second from the provider side, healthcare provider side, budget constraint, IT spend for application and infrastructure is still now this pandemic has enforced, and they have come to understand, yes, the IT spend is important, and slowly the hospital started budgeting for it. Earlier, the hospital was not budgeting. Now they have started budgeting for the IT spend after this pandemic, because I see that whenever we are talking about the budget of the upcoming year, so the IT budget discussed on a large scale in terms of application and infrastructure, the data security. Earlier, it was not there. And that's the reason that the lot of hospitals were not able to buy the EMR and get it implemented. Contradiction between product company and provider clinical users, that is also being addressed up to some extent. For example, doctor start teaching the technology to the technical person, and technical person start teaching doctor the medicine. Both ways are wrong. So that gap has somehow been addressed, and have said that okay, the technology is as enabler which can resolve the issue of the end users. On top of it, the doctors cannot teach the technology, and technical person can't teach the medicine to the doctors. So that gap also some is being that barrier is being addressed. And rural area infrastructure is one of the major. And the goals are missing with, and product side, anybody who is making a product, they must have a goal based on the need of the market. They should have a goal in terms of the pain area of the customer. So the people are making the solution, and without goal, and if that application has been made so well without the pain, understanding the goal of the goal in terms of pain of the patient, definitely it will be a huge failure of the product. And it is very, NHS is one of the best example that where the Lorenzo EMR was one of the best EMR I have seen ever clinically, but it got failed due to the performance, and it could not implement it across NHS. Though I don't know how many million pound was spent. So the customer, the hospital, the healthcare providers has started talking about the product owners that if I'm making that, what is on what basis your product has been made and why you are saying that it is a wonderful product and it will going to add value to us, and how we are going to get the ROI and the patient engagement. There are 3 goals I found out, that they say that always the expectation is that if the solution is that it should be faster than paper. It means if a doctor is scribbling a prescription in 3 minutes, at least doctor is saying that, boss, I let the system also allow me to scrib the prescription in 3 minutes, not less than 3 minutes, but at least within 3 minutes. So that way, that kind of solution is supposed to be made. Technology is available. Now then, the sub-second response, it should not be, it should be a faster to paper, means talking about that, again, talking about the prescription preparation, and sub-second response is means if I entering any data and output it come in sub-second, it should not move around the busy cursor even for a 10-second. Doctor is not accepting that. They will not accept that. They will throw out and they'll say, this is not a solution, I cannot use it. That's one part. But technology is again available, and technology is again far better technology is available to achieve it. Solution, it does not need any training to the end users. The solution is supposed to be made, the clinical solution is supposed to be made in such a way that doctor does not need any training, because he knows all the jargons, the dictionary, the coding system and everything. If evidence-based templates are being triggered based on the parking the diagnostic sign and symptom, then the doctors knows much better than to fill up that template automatically and quickly. So, so it should be made in such a way that doctor does not need any training. And the doctors are saying that, boss, if I'm going to run a small smartphone, do your son who is 3, 4, 5 years, does he need any training? He starts swiping and just and playing on his own rather than you trained him. So it is proven. And that's where the product-based organizations are failing. Their product are getting failed if these goals are not met during designing this solution. So that's all from my side. I wanted to add quickly on this telemedicines and telehealth, adding it in the integral part of the EMR and EHR to provide a quality healthcare within individual reach. Thank you.
Thank you very much. You see, we were discussing yesterday in a governmental panel here that when government decided to attach hotels and banquet halls to the, and actually it is very well said that 100 bed in a hospital can create another 100 beds around the hospital for the patient who are home quarantined. And this is the only way. But the point is, it has to be structured. It cannot be, just loosely connected. So you need the basics. Similarly, I think the challenges which you have brought out for the remote location, you need basic structure in those remote locations. Let us say primary health centers may be there, health and wellness center may be there, through which this channel can work. But let me put it very straight. We need 2.5 times more number of beds in our country. Accessibility is very poor. Some locations have got too many hospitals, some locations do not have a single hospital. So this is our answer. Telehealth is the answer. But really it needs to be worked out, and experts like you who have done work on this area, we need to put you together along with the other people and have a networking and prepare a solution. But this is the need of the hour, and thank you very much for the excellent presentation.
Thanks, sir. Thank you very much.
Yeah. Now we move over to Dr. Shashi Bhushan Gogia. Do we have Shashi Bhushan Gogia? Yeah, you are here. Yes, please. So may I
share my
invite?
screen.
Yeah. Kindly make a presentation.
All right. Hello.
Yes, Dr. Gogia.
Yeah, thank you for inviting Dr. Garg. And I see out here my good friend, Dr. Gyani, who's moderating so well. So first of all, a little bit about me. I am a surgeon practicing from AIMS. I've edited a book called Fundamentals of Telemedicine and Telehealth.
Yeah.
And I'm part of various organizations which are not so important now. But basically, most of my talk will be based on what has been mentioned in the book already. So it's gathered from various sources. But I was at the start of this, I was not sure as to what to talk about, being the last in the session. Many of these things, some of them have already been covered, but a few have not, as I noticed. So I'm okay, but it's very difficult now to change the presentation because that is the way I made it. I hope you understand. So, yeah. So basically, I'll talk about the overview of telemedicine and telehealth, the barriers and opportunities. We'll talk a little bit about. I don't need to really go through this; it's already been talked about. But one important point which I always focus on, and this was very nicely pointed out by the previous speaker, Dr. Abdullah, that we have to make something which is practicable, and the component which is required for that is what is called change management. So, let me just go to definitions at the start. What is telemedicine and telehealth? Telehealth is the provision of healthcare remotely by means of a variety of telecommunication tools. This includes telephone, smartphone, mobile wireless device, which can be with or without a video connection. Unfortunately, most telemedicine so far was just a video chat or a telephone chat, and they said, okay, I've seen the patient online, but that's not the right way to go about it because it misses a lot of the actual wealth of what tele can do. And along with, more important, it is the more the tele component rather than the information processing component, which is very important to make telehealth even better than a physical this thing sometimes. So it is mainly about transmitting information like the voice, data, images, rather than moving people. So the idea is that when you are away, and I'll show you in the next slides, it encompasses health provision as well as education, and some of the education aspects have already been talked about. And lately it has expanded to the term digital health with the use of new devices, faster processing, as well as mobile technology. So these are the main three terms which are being used. Telemedicine is teleconsultation, which is pure medical care provision using communication technology. Telehealth is healthcare provision, so it goes up over and above teleconsultation and telemedicine. So it includes teleeducation, wellness and public health, ancillary components which add processing and analytics and knowledge management. So you do public health processes, you do data, you can, like in COVID, where are the vaccines being distributed, get appointments, things like that are being done through the telehealth company. And then digital health means that each and every place we are using electronic methods, which include devices, artificial intelligence, CDSL, blockchain, robotics. This come under the digital health, and we are generally progressing towards that. And they are filling up some of the gaps which telehealth had to make it a comprehensive, all-inclusive system that we are trying to develop. So the case for telemedicine, we come to the basics, is where there is an immobility or inability to travel, either by the patient or by the provider. The provider may have gone on leave, so he can see his own place or his patients remotely. The patient cannot travel, he is bedridden, various things. And in emergencies, when time is of essence, for example, in distances, and of course, to maintain the social distances, which is why COVID, as the first speaker said, COVID has really brought telemedicine and so on, because the need to stay away. Previously, most people used to say that unless I've touched the patient, unless I've understood the patient well, I'm not confident with that care. Now they don't want to do it. But when a person is in a remote location, he is as important a patient as the one who is next to you. And how does it come to you? How do you cover the distance is what telemedicine is all about. But there's a lot of things involved which make the people in remote location needing telemedicine, because they may be adequate of local skills, there may be inadequacy of knowledge, and there may be inadequate equipment also. But these can be sent. So telemedicine can overcome the thing through equipment. We can do some remote care directly, because a person should not need to travel because a particular equipment is not available. Their operator is not available is a different thing altogether. So what improves as a result? We have higher patient satisfaction, better clinical workflows. There's a thing of working at the convenience even from your home, and the doctors can also continue the family responsibility as well as the patient, and diminish chances of spreading COVID-19, which has now become so common. We have seen the movie called Maji, which talked about a person whose wife died because he could not get into the hospital in time. And then he built a road across a mountain so that other people do not suffer. In this day and age, he would have just required to build a telecom tower or just buy a mobile. So that's what it has worked. But unfortunately, the problem with telemedicine is what we are seeing is, for some, it has become something like a remote control. How many of you have gone to switch on the TV or switch the channels in your TV recently? You get so used to it that you stop using. There is still a need for physical travel, is what you have to remember. People are getting too much to the other side, and they can wake up a doctor at the middle of the night thinking that, okay, since this is a convenience, I can use it anytime. So that misuse we have to try to avoid. So it's a preferred choice for those without means of travel, veterans, so this I've already told you. Also in chronic diseases for medicine refills, and also, in this, if you can separate the travel for small little procedures, if you can do the training of the local people how to do a stitch removal, like I did today, because my own place, my staff has got COVID, so I cannot see patients now. I had to take somebody's stitches, so I showed him online, and I got the patient to remove the stitches of that lady at home only. So, this is what telemedicine can do. I wish I had recorded, I could have shown you today only. It's just done today itself. So, but important, as the previous speaker said, you can avoid revisits, especially if you're maintaining an EMR. And this is what we are doing at our place. We are maintaining an excellent EHR. So us following up on a patient is very, very easy. And as the previous speaker said, our EMR, we make a prescription in less than a minute using templates and all. So, this is the cause of movement of patients. We have a patient, like simple thing, he requires a dressing. He goes to the local practitioner, which can be low cost, 20, 30 rupees. The knowledge, drugs, and equipment has to be available locally. And if this is adequate, he doesn't need to travel. Sometimes he has to go to the doctor in the near, and it's still affordable. But in case he wants to go to super specialty center, this 20 rupees has become 2,000 rupees because of the cost of travel. There's a high cost of treatment, which is relatively high, but not completely. There's also a cost of stay for the relatives. Sometimes you stay with the relative. So that's why upper classes having relative money can prefer to do that. But still the cost difference is enormous. And this is what makes healthcare expensive for people in remote areas, which we try to cut down through telemedicine. And how to do it? Basically, there are two types of these things. I'll show that later. The important one, which I believe is the same, is what is called store and forward, in which you try to maintain an electronic record. Like you take a history in a normal circumstance physically, you take the history and break it into electronic components like text, images, sound, video clips, waveforms, and do a video conference for correlation. And similarly, examination can be broken down to text, images, sound, video clips, etc. These images, sounds, and text require slightly higher bandwidth. And then we go on to, so finally, we have a flow pyramid of the information. You're actually, what is happening in most telemedicine of now is that they talk about video conference and real-time images, but these are not regarded because they constitute only 20 to 30% of the diagnosis. The actual, this thing should be done in a proper way, like you do yourself. You take the history. You find out what is the problem the patient has. Text data is 80% of the diagnosis, only 1 to 5 KB. So even with a simple mobile phone, if you are using store and forward, you can get this almost as good a teleconsultation. So you should not feel despondent that unless I have a high bandwidth connectivity and high this thing, I cannot do. And rural people are suffering from this thing. They do not have the right connectivity to get the full telehealth this things. But you should try for them for their need, even with simple text and all that. Do a patient hack case, identify the patient, send the actual data, and you can do telemedicine. So not doing telemedicine just because full connectivity is not there is something which we should try to overcome. This is the classification. I'm sorry, this slide should have been earlier. There's a thing called store and forward, in which the data sharing is asynchronous through SMS, WhatsApp, email, but better is to sharing an electronic health record. The real time is when both the patient and the clinician are at the same place through a telephone or video consultation. And of course, most telehealth apps which you use are a hybrid in which both of these are involved through health apps using Android, browser based and all that. And the new this thing which is being done, this is telemonitoring, in which there's a device on one side which sends the data across. And you can give some decision based on it. But finally, you need a hybrid. The history is the most important component that you try to do. The reason why telemedicine has failed at some places because they looked at the high-end component and not the low-end components. If you do that, you can do a much better job. And this is called mHealth is when we are using mobiles. So the various streams of sending the information across between home health care is when you're using devices or Internet of Things. From patient to doctor is the most common, and this is what I'm looking at. This is what the telemedicine practice guidelines were made for. But the most important point to me are between a health worker and junior doctor specialist. Some sort of physical care is always required. So the local practitioner can do the physical care, which is of very simple quality, dressing, removal of stitches, giving eye drops, giving certain medicines. But he takes the consult from a specialist, and the communication between, in that case, the patient privacy issues are not so much. The patient can give the care. Even in a hospital, a nurse is qualified to give an injection. And when she does that, when she's calling up the doctor, even in the hospital, that is also telemedicine. So this is the most important fact that we should try to emphasize on. The communication modes vary according to the speed, whether it's wired or wireless. Wireless is less consistent, but most used these days because it's more convenient. But it is definitely less convenient. Wired is the one that you shoot cables, like in the form of broadband or fiber optic, and this is a better one. You must remember that video conferencing and video streaming requires high bandwidth, text requires low bandwidth, and cloud-based systems, it varies. If you're going to store all the images and all that in your own database, it's going to be high. So even cloud-based system, you should try to make it in a way that it uses more of text rather than the full display. The best way to do telemedicine, as pointed on the last one, is that you should create an electronic health record, which is make available for all that. It will help efficiency, it will help bill clearance processes, and the records are ready for teleconsultation. Data is also available for other users like epidemiology research, supply chain, etc. The National Digital Health Blueprint was created with emphasis in EHRs. Unfortunately, we are shifted now to a National Health Stack, where the emphasis is only on a PHR, which is, to my mind, less efficient because this is patient created and we may not get the right data. Of course, the emphasis on the consent is important. A true, this thing should be a telemedicine, hospital information system, health information, and EHR should be working side by side as a sort of a conjoined feature. And if that is done, a healthcare availability to each and every citizen of the country should be possible, which is already being done in places like NHS and all that, as already pointed out. But you must remember that transiting this is the main barrier, because we have technology. People have tried to say, I have this technology and it will do that. But finally, you need to change the people to adopt and use the technology. Like was stated by the previous speaker, your EMR should not take more than 3 minutes to make a prescription. Unless you make such systems And more importantly, even if it does in 3 minutes, it will not take place in the initial time. My EMR takes only 1 minute to make a prescription, but he has to take a learning curve of 2 to 3 months for him to understand how to make that prescription quickly. That learning curve is different. So you must remember that you have to do what is called advocacy and training through what is called change management. And this is the only way, unless you bring out change management principles and do an advocacy for adoption of technology, bring about the motivation, telemedicine will not take place. I agree that COVID has created a certain motivation, but we are still not there, because as soon as it went down, with the cases went down, people went back to the old thing. Now the cases are come up and now the need is being felt again. So you should try to emulate the day-to-day procedure of what is called principle of minimal or no change or evolutionary change. That is, bring about the changes slowly and do a need assessment gap analysis. And without that, if you just try introducing new technology with an old order, you only get an expensive old order, because you spend a lot of money on the technology and nothing has happened. But certain technology is definitely very, very essential. Like without technical connectivity, telecare will be zero. But can you make it with low connectivity? Can you adapt to your system to that? And can you train the people to use the SMSs only for sending this? Is what the advocacy system will be all. Most projects have been failed because of the person than the technology. Because that's why change management and improvement, there's a role of common standard operating procedure and connectivity standards are required. Planning for most telehealth has been taken place in the cities. The need is in the villages. The important thing is training and evolutionary approach and use locally available tech. And that Bangladesh project was excellent in that regard. I'm very happy to say. Also, another thing which is used is that use images, this thing, because they can be captured and sent across easily along with the history. They speak 1,000 words. So overall, currently, most of the specialties in telehealth and COVID pandemic has become essential. There's high in wound care, dermatology, it's high because we're depending on images. Ophthalmology is high. Psychiatry, because it depends on video conference. Intensive care is high. Like that. Go according to the specialty where you can use it, get the proper equipment. And this is a patient that I'm showing, which was my own. And the patient came to me from Mumbai. I did the initial treatment, sent her home, and she kept sending her own images, and you can see the prognosis here. Mobiles are offering new opportunities. They are allowing the complete solution on an app. But they also, because patients are used to working with a mobile, even their adoption becomes easier. But you must remember that there's a high patient demand after COVID, but even before that, 76% of the patients in the US would prefer a teleconsultant over a physical consult. So in India, we have reached there already. And if you think that you can stop telemedicine after the COVID is gone, you are barking up the wrong tree. You will need it for your day-to-day. Aarogya Setu is part of it. So if we are talking to clinicians, I can this thing, how to start if you're a clinician. You should start, you should have a computer with a big screen and tablet if you want to be mobile. You dedicate a special room with soundproofing, etc. for such advice. You should be able to learn to do proper video consult. You should sit in front of the light and all that. And use a dedicated app or link it to an electronic health record system. You train yourself, invest in peripherals which are relevant, like a dermoscope for a dermatologist, tele-ECG and telescopes for a cardiologist. Psychiatrist only needs to use video conferencing, etc. So with current this thing, there are better opportunities because of better awareness, because of social distancing, it is patient-driven. The mobiles are given better connectivity, there's government support, there's telemedicine practice guidelines, and new things like AI and blockchain are coming up. So in summary, do the change for starting online, do change management, do capacity building, use appropriate technology, which you can understand, you are working comfortable with. Keep it simple, and remember everything has a cost. Use the simplest thing for a start. Experience the problem and you will get the motivation. You have experienced COVID and you got this thing, and identify the target. Just like Arjun did for his bird, the eye of the bird is what you should, but always remember the constraint like emergencies, whether it requires a procedure, you're not sure of consent, or the incomplete or a complex. In that cases, do not go for telemedicine, go for a physical visit. Thank you.
Thank you very much. We know Dr. Shashi Gogia as Solution Par Excellence. Today, I think I learned he is a trainer and educator par excellence. In fact, I would have preferred your talk should have been the first talk in the program. You know, the way you have brought out the overview of everything, it is like a classroom session, complete in all respect. It takes actually a role model talk today. Very nice, Dr. Shashi Gogia. Thank you very much.
Thank you, sir. And yes, I was worried that some talk has already been done, and I really appreciate the talks that we heard, especially Mr. Meena and Abdul Salam and Islam. It was very good talk.
Value adding. I agree with you. All very value adding talks today. Thanks to Dr. Anil Kumar Garg for bringing this kind of speakers on one platform. So I hand over back to Aishwarya.
Dr. Gyani.
Yeah.
Thank you very much for excellently chairing this wonderful session, and congratulations for the Excellence, Global Excellence Award for Lifetime Achievement.
Thank you very much.
Healthcare. Dr. Gogia was worried, and he has asked me several times. I know his capabilities. He has asked me on which topic, where, how. Then I said, I know you, and you have written and edited books also. So I know your capability, and you will be at the last. Why at the last? Because very senior person will always speak at last. So this is a tribute, this is an honor to Mr. Gogia, and he has done very well. All the panelists, starting from Debya, they have done wonderful presentations. And as far as Meena is concerned and other persons are concerned, they have done wonderful job. And the presentation of Mr. Vinod, that was relevant to this session. And that's why we have invited that nobody talks about cybersecurity. So give some insight into it. And Rafiqul Rahman and others, they have done an excellent job. I'm really thrilled about the presentation in this session. And we will have some webinars, but annual conference, this is an annual conference of World Healthcare. This will be held 15 and 16 April next year. Dates are fixed. So 15 and 16, whatever day may be, Sunday, Monday, or Tuesday, whatever day may be. But this will be held on 15 and 16. We will invite you, Dr. Shashi Gogia, especially I am talking to you. Okay? So we will invite you next year also, and we will see how best we can convey our message for the larger good of the people, poorest of the poor.
Thank you so much.
Dr. Gyani, I have one request. One of ONGC fellow is suffering, his wife is suffering from the COVID, and she wants a bed. Can you help us in getting some bed in Delhi or Noida or whatever city?
Where is she from? Location?
ONGC is a wife of ONGC officer, so money is no problem.
Just send me the number, her name, age, and number. That's all. Just send me on my WhatsApp.
Just send me your number or whatever number you like.
Okay.
So I shall be personally obliged to help my colleague in this situation. Thank you very much.
Okay.
And some of the speakers file COVID from UK, 2 from US, and 2 from India. So this is a very unprecedented situation, and stay safe, be comfortable, and we will meet next year on the same dates. Thank you very much.
Thank you very much. Thanks a lot, sir.
Thank you so much. Right. Thank you so much, Dr. Gyani. Thank you so much to Dr. Meena, Dr. Rafiqul Islam Maroof, Dr. Divya, we had Dr. Shashi Bhushan Gogia, Mr. Abdullah Salim, and Mr. Vinod Natarajan. Thank you, all of you. It was indeed a wonderful session, as pointed out. And thank you so much, Dr. Gyani, for chairing the session so beautifully. And it was not just this session, but in fact, I would say that we had indeed a great day today, a very fruitful day wherein the plenary sessions of the day threw more light on various topics related to the healthcare. And in fact, the topics that are not just relevant, but are pressing issues rather, that need to be dwelled upon, be talked about, to be discussed with passion and zeal, and also the takeaways that we are getting from these sessions be implemented upon. So we had these thought-provoking sessions on digital transformation in the healthcare, artificial intelligence, blockchain, robotic surgery, and new health informatics, as well as telemedicine. So it was indeed a pleasure to have been a part of this August gathering, and that gave us opportunity to get more insights on the healthcare topic, and also which is obviously the biggest treasure that we all human beings and animals have. So I'd like to say that please join us tomorrow as well, because there'll be more sessions that we'll be having on the day 2 of the World Healthcare Conference. And I'm looking forward to more August, the company of dignitaries like you. And we hope that we'll have another fruitful day tomorrow as well. Looking forward to your August.
Thanks, guys. Thanks. Bye-bye.
Thank you so much for having joined us. Thank you.
Bye-bye.
Thank you. It was
Thank
really a
you.
wonderful session.
Thank you, Dr. Meena.
Thank you.
Thank you, Rafiqul Rahman Saab, Islam
Thank you
Saab.
very much. Thank you very much. It's a pleasure.
Thank you.
Thank you so much.
Gogia Saab.
Nine 682 822 78। ये उनका है ना?
क्या नाम है?
नाम क्या है? महेश हाँ पारिक।
ठीक है।
ठीक है, आप बात करते हैं।
सुबह गुलेरिया भी थे ना, एम्स के डायरेक्टर।